Good morning, everyone. Can I have your attention, please? I request the audience to put off your mobile phones to silent mode. A warm welcome to all the dignitaries, distinguished guest speakers, delegates, students, and my dear colleagues. I'm Dr. Jyotsna Tanigundala. I work as a consultant swallow therapist at Rainbow Children's Hospital. I'm pleased to welcome you all as a host on behalf of the entire organizing committee for the two-day conference on mental health. This has been organized by CDC, Department of Pediatric Neurosciences, Rainbow Children's Hospital, in association with Department of Psychiatry, Institute of Child Health, Nilofer Hospital, National Institute for Empowerment of Persons with Intellectual Disability, and Center for Health Psychology, University of Hyderabad. Our theme for today's conference is Current Challenges in Child and Adolescent Mental Health and its Practical Solutions in the Post-Pandemic World. The aim of the conference is to bring together and provide a premier interdisciplinary platform for all the important stakeholders, including subject experts, leading professionals, researchers, policymakers, academicians, and students to exchange and share their experience, ideas, and to update ourselves on the recent innovations related to the child and adolescent mental health. It gives us newer insights of various issues related to the differential impact on people during the COVID-19 pandemic situation and after around the globe. It is pertinent to discuss at this juncture on the mental health effects of the vulnerable groups, that's the children and the adolescents. Even though the scenario has been changed with the scientific and medical advances in handling the threat of COVID-19, still the bio, psycho, and social effects remain as the challenges. So these are the areas that we as medical and service providers should deal cautiously and provide suitable interventions and coping strategies to the affected and the family as a whole. I hope the participants would get inspired, gain new insights and clarity in looking at the directions ahead and the importance of providing psychosocial care and support towards the mental health issues. Now I would invite Dr. Rishikesh Garu to invite the dignitaries onto the stage.
Hello everyone, I'm Dr. Rishikesh Garu, Associate Professor Nilofer Hospital, working in Department of Child Psychiatry. So I've given this job of inviting dignitaries. Before going into that, thank you madam for the great introduction for start of the day. I hope all you get relaxed here and enjoy the feast of education, what about importance of child and adolescent mental health. And first of all, I invite Dr. Professor B. Rao Garu, Vice Chancellor of Hyderabad Central University onto the dais. So thank you for the great help giving us the auditorium and suggesting few things to organize this. And next I invite Dr. Ramkumar B.V. Garu, Director of NIPID. Sir, you are doing a great work in NIPID. And Dr. Lokesh Lingappa, pediatric neurologist, one of the best neurologists I have seen working in Rainbow Children's Hospital. And invite Professor Geeta Vemaganti Garu, Dean of School of Medical Sciences. Thank you, ma'am, for gracing the occasion. And Dr. Ram Subbareddy Garu, Head of the Department Child Psychiatry, Nilofer Hospital. And Dr. Umashankar sir, Superintendent Institute of Mental Health. And this is the Center of Excellence for Mental Health. We are the sub-department which are working under Institute of Mental Health. Sir is doing a great job about mental health. Recently, we got Aragyasri also, that is the latest achievement by Dr. Umashankar sir, which he has achieved mental health under Aragyasri, which gives a lot of immense things. And also, there is a lot of developments happening in mental health awareness programs, is giving us chances, wide range of chances in developing mental health. And I thank all the dignitaries on the stage for gracing the occasion. Thank you so much. Now I welcome Dr. Ram Subbareddy Garu to give a opening speech about today's program.
Good morning to all the dignitaries and delegates. So our today's chief guest, respected Professor B.J. Rao Garu, Vice Chancellor, Hyderabad Central University, and our chief guest, Dr. B.V. Ramkumar Garu, Director, NIPIT, Secunderabad, and guest of honors, Dr. Usha Naik Madam, former HOD, Department of Child Psychiatry, Nilafar Hospital, and today's guest of honors, Dr. Uma Shankar Sir, Superintendent, Institute of Mental Health, Hyderabad, and our Professor Geeta Vemuganti Garu, Dean, School of Medicine, Hyderabad Central University, and Dr. Lokesh Lingappa Garu, Pediatric Neurologist and in Rainbow Hospital. I welcome all of you for the today's conference. And today's conference on current challenges in child and adolescent mental health and its practical solutions in the post-pandemic era. And this conference is being organized by both and various groups. Rainbow Hospital in association with Nilafar Hospitals. And today's topic is relevant in present times, post-COVID era. Hello, right. And COVID-19 pandemic have disrupted lives of people around the world, and it is clearly evident that direct and indirect psychological, social, and effects of people are involved. Studies reported that pandemic causes stress, worry, helplessness, social and risky behavioral problems among children and adolescents. In older children and adolescents, greater depression symptoms, anxiety, externalizing behaviors have been reported with greater alcoholic and substance abuse. The exploration of effective channels regarding development and delivery of evidence-based, age-appropriate services to lessen the effects are required. The COVID-19 causes physical restrictions, social distancing. These measures have affected each and every domain of the individual. School closures, isolation have negatively impacted mental health and well-being of children. This is the anxiety, depression, disturbance in sleep, appetite, as well as impairment in social interactions are most common presentations during this time. In the absence of vaccines, public health measures have been implemented to prevent and reduce the spread of virus. Schools have been closed, extracurricular activities for children and adolescents in group settings have been cancelled. This led to psychiatric morbidity. Domestic violence, child maltreatment, these are the common things occurred in the families. Income loss, economic hardships led to marital conflicts. Being parent, it is daily challenge with the realities of COVID-19 to adjust. It is important to be calm and proactive in our conversations with the children. Otherwise, they will get severe anxiety and depressive symptoms. Caregivers can engage children in creative activities such as playing, drawing to help them express and communicate negative feelings. As children often take their emotional cues from adults, it is important that adults manage their own emotions well. Role of parents and teachers should get equipped to detect and deal with the early signs of mental health. In adolescents, especially between 10 to 19 years old, hyperactivity, fidgeting, sleeplessness, eating disturbances, agitation, increased conflicts, physical complaints, and most importantly, delinquent behaviors and poor concentration are also common among the adolescents. With multiple threats to the mental health, current pandemic could also provide opportunities. The absence of appointments, occupational trips brought rest to the families and it causes relaxations to the individuals. Then people know how much stress they have been facing all these years. Several external stressors disappears. Most time with caregivers can go along with the social support which strengthens the resilience. In addition, children troubled by school bullying and other stressors can experience relief. Mastering current challenges could contribute to personal growth and development. The last 2 years are a clear impetus to continue the study of how early stress and trauma impact development and to explore innovative strategies for fostering and resilience among children. Millions are missing out on basic health services and education and protection simply because they were born into poverty. COVID-19 has widened the inequality gap. The social, economic, health impacts of pandemic will reverberate for years to come, threatening child rights. So there is a need to rally behind a practical, concrete plan to protect the children and invest in health and education is required. There is a need to build trust on vaccines as it was not there in initial stages. Even some of the doctors, they did not take vaccine in initial stages. Bridging the digital divide can help in bringing the quality of education for all. Reimagine Education by UNICEF is revolutionizing learning and skill development to provide quality education for every child through digital learning with connectivity and devices, and most commonly the affordable data is required to implement all these things. Digital tools can be game changers. Digital toolkits should reach the most vulnerable children in the world. Children are twice as likely to be in poverty compared to adults. They are also more susceptible to suffer from irrevocable lifetime consequences. Rarely children have a second chance of getting critical early nutrition and quality education. Social protections like cash transfers can be crucial in helping families. They were useful in short term and also helpful in fighting inequalities. Though cash transfers programs are most commonly criticized by the public, and these cash transfer programs really helped in the COVID times. Some of the governments are implementing these cash transfer programs. Today's conference has to bring out the solutions to tackle the post-COVID problems in the children and adolescents. The topics are selected to deal with the real problems like treatment strategies in internal and external disorders, neurodevelopmental disorders, role of early intervention in identification of SLDs, and the required interventions through inclusive education pattern. Technological and gadget addiction in children has become very common during COVID times, and it is difficult to addict, and this is a real challenge for both psychologists and psychiatrists to addict from the gadgets. I hope this two-day conference will help in tackling the children and adolescents problems as well. And regarding the Institute of Mental Health, see, our superintendent, Dr. Uma Shankar sir, is doing a lot of good work in improving the Institute of Mental Health. He brought the Center of Excellence and is taking care of all these legal problems in the psychiatric sector. Thank you all for giving me this opportunity. Thank you. Okay. Now we'll go for lamp lighting.
I invite Dr. Nitya Murthy, child psychiatrist from Rainbow Children's Hospital, to start the program with a prayer song. Vinayaka Ninu Vina Brochudaku Vinayaka Ninu Vina Brochudaku Verevarura Vignaraja Vinayaka Anada Rakshaka Anada Rakshaka Anada Rakshaka Nivegada Adarinchi Mamu Proba Radha Vinayaka Ninu Vina Brochudaku Verevarura. Very nice melodious start. Now I request the delegatories to light the lamp and to start the session. Dr. Somashekar will assist in it. Naresh Garu, can you please assist the team?
So, with this beautiful song by Dr. Nitya ma'am and lighting lamp, thanks all the dignitaries for gracing the occasion. I'm very honored and to see all the people here who are involved and striving for mental health, including psychiatrists, clinical psychologists, as the department from schools, and also I thank Rao sir for giving us this hall for doing this occasion. Thank you so much, sir. Now we start the first session. Uh, we'll start the first session by Dr. B.V. Ramkumar, Director of NIPID, Hyderabad. His topic is the role of government agencies of mental health rehabilitation. And the chairperson will be Dr. Uma Shankar, sir, who is Superintendent of Institute of Mental Health. Thank you, sir.
A very good morning. Sorry, can I start?
I'm so sorry for the hiccups. I would like to invite Dean of Hyderabad Central University to speak a few words about it. And then we'll proceed on to the talks.
A very good morning to all of you. I'm delighted, those if you're Hindi or Telugu speaking, when our pihar or susral wale jab milte hain, the delight that you have, that's what I feel today, because all the clinical people are here, and the team from Naderfor Hospital, nice bed, all the clinical institute. This exactly is what University of Hyderabad is looking forward to. A very close interaction of clinicians and scientists. And since there is very little time, I would like to now actually thank everyone for choosing University of Hyderabad as your venue. I would ask you to spread this word and get all your clinical colleagues to have their host their meetings here, because we have one of the best campuses. You would have enjoyed the ride to the campus. So breathe the fresh air and spend. So I would encourage all the clinical institutions to host their meetings here for two reasons other than the ambience. It's time now that we have interdisciplinary studies, as I was talking to the. I'm a clinician scientist. When I moved from clinical field to research, I felt like fish out of water. We don't know how to talk to, what words to use when we talk to a scientist. When I started going in my stem cell area, when I went to these meetings, oh, what are they talking about? You know, those molecules, those genes. You know, I felt that we were not trained enough to understand what the scientists are saying. But then subsequently, I realized I was wrong. We were taught. We are taught in anatomy, physiology, biochemistry, pathology, microbiology, forensic medicine, pharmacology, everything we have been taught. It's just like we call it as a recency bias. We only remember the clinical subjects and we forget all the first 4-5 years of our training. Subsequently, when I took up research, I realized it's not something new that we are learning. We are learning more details of one particular area. Like when from general medicine, you go to medicine or psychiatry or pathology like me. I started with pediatrics, by the way, and then I moved to pathology. So what I'm trying to emphasize is today is an era of interdependence, not independence. There are no boundaries in subjects anymore. There are no boundaries, borderless, we call it. So beyond borders, there's a movie. It's a beautiful movie, but in every area that applies. With that small thing, I would like to emphasize that the School of Medical Sciences in University of Hyderabad was started with the intention of having a hospital. And there was some hiccup, so we couldn't move ahead with that. And I hope we will now pursue our goal of having a hospital in the campus and we are not looking for an undergraduate teaching program here. We are looking for a specialty hospital where we can have more of research in collaboration. We don't want to be independently working as a hospital totally independent. No, we are not looking for that. We are looking for interaction with other hospitals for clinician scientist program. The new medical council is opening up, the National Medical Council. So it's opening up an opportunity of developing clinician scientists. So the MD can be given by clinical institutions, PhD can be given by institutes like us, Institute of Eminence and Institute of Importance. So with that, the School of Medical Sciences, we were left with in a very vulnerable situation. What do we have? So we started with a course of optometry, which is now part of the Allied Health Professionals course, as you would know. There were many courses, as you would know. They didn't know where to find spaces other than medical, nursing, pharmacology, and rehabilitation council. There were a lot of courses which all our colleagues working in these areas, they didn't know where to go. Now the Allied Health Professional course has brought in 40 specializations into one. And we are all colleagues who are. So the optometry program is an integrated program of 4 years bachelor's and 2 years master's, which we are running. We have a Masters of Public Health. In fact, one of the courses we started was disability studies as part of our MPH as core electives. And we also have a PhD program in all these streams. So another thing which came up actually for a logistic or administrative reasons is that 2 centers got added into our school. That is Center for Health Psychology, which is now headed by Dr. Padmaja, who is with us, and Center for Neural and Cognitive Sciences, which is headed by Professor Ramesh Mishra. So the reason is we may not think that we are all organically linked, but then if you see what is required for disability studies or mental health is all of us. We need people from public health, we need from psychology, we need from public and neural and cognitive sciences and other specializations. So right now our young school has these 2 centers with us and about 20 faculty, and we have expertise in various areas. But all of us, irrespective of where we come from, not only from our school, but all the faculty from our university, I can vouch for them that they are very keen to actually get into translational research, what we call it now. It's now not even a choice actually, it's a mandate that we contribute back to the society. And this topic of mental health is personally very close to me. Mental health, as was alluded by the speaker, it's about developmental disorders and of course the iatrogenic or the pandemic induced or many other things. Personally, as not a direct caregiver, but I have seen there is a child in our family, autistic child, to get the diagnosis of autism or if part of the ASD was a task by itself, as we were just discussing about the problems of this. To get him into a school was a challenge. To get special educators for him was a challenge. To get vocational training for him was a challenge. And he is a swimmer, world-class swimmer now, and we are very proud of him. And Shraddha School, I'm sure many of you have already interacted with them. Shraddha School is one of the institutes which there are many other organizations and which help them. And Sridevi Garu, who is part of this, has been taking care. And there is one hostel developed at the outskirts of Hyderabad where they are requesting parents to have a small unit there so that they can be. But then is that when we are having education as inclusive, why are we having hostels not inclusive? Why are we not having residents inclusive? So an ideal way would be that every community, whether it is a flat or anything, should have one flat or one apartment for specially able people. They should not be outside. I mean, that's my personal opinion. I don't know the logistics. I may be totally wrong. But I feel inclusivity should happen at every level. Education, living, community, everywhere. And including government. So the last thing I would touch upon is our keen interest in having any of your teaching programs with University of Hyderabad. This is an open invitation for all of you. The new educational policy opens up a lot of opportunities for us. Interdisciplinary studies. You can have it with either Center for Distance Education, but then that also has a minimum of 25% contact classes. So there are, whether from Center for Distance Education, for e-learning, or in NEP programs, now they are going to have entry and exit. So I cannot tell you as an educationist how exciting this time is. And if we don't get together and make the best use of this opportunity, we'll miss the bus. And we have been working in, the expertise is there in clinical and basic sciences. So I would, on behalf of my Vice Chancellor and all my colleagues of the university, I can assure you that university is open to associate with all of you and take up any education programs that are feasible with our expertise there and here. So with that, I thank you once again for choosing University of Hyderabad as your venue, and I thank Padmaja for collaborating. In fact, she asked me, it's not our conference, it's someone else's, can we do that? I said, yes. All India Ophthalmic Society meeting, of which has more than 6,000 delegates, they have a teaching program for all their postgraduates and undergraduates. 5-day actually course. So they wanted to do it here. And that was the first time I realized how much enjoyable it is to have all these meetings here. And it's like win-win situation for all of us. So with that, please enjoy your meeting. And thank you once again on behalf of University of Hyderabad School of Mental Health.
Thank you, ma'am. Now I invite Professor B.J. Rao Garu, Vice Chancellor of Hyderabad Central University, to address the ground.
Good morning to all of you. Namaste. This These are two important days for all of us to discuss about not mental disorders but mental aberrations in children and adolescents. Very, very important topic. It was important pre-pandemic. It was important during pandemic. It is certainly important post-pandemic. It is always important. So thank you, Ramkumar Garu. I'm missing Lingappa Garu. Where is he? Very good. And Geeta Vemuganti Garu, Padmaja Garu, and others for hand-holding these 2 days symposium. So this is a partnership effort between University of Hyderabad, Nilofer Hospital, Rainbow, NIPID, and all of you. These kind of partnerships is the call of the day, because the problems that are there to be solved are difficult problems now in every walk of life. Unless we work together, firstly, we will not understand the nature of the problem. Secondly, we will not train enough number of people to address the problem. Thirdly, we will not be able to implement the solutions of the problem. At every level, we have to work together. I couldn't agree more than what Professor Geeta Vemuganti has said. So working together is a mantra these days. But typically in India, working together has been a non-mantra. Typically in India, we work for ourselves. So this working together is a new business that we are entering into. This is so in many, many walks of life in India. But we have to work together, because the problem in this particular domain that we are going to discuss today and tomorrow is a humongous problem, global problem. If you compute that the magnitude of this problem, it is mind-boggling. Estimates are about 10 to 20% of the human population in toto have some form of mental aberration or the other, of some degree or the other. It's a huge problem. The numbers may vary. Whatever variation you do in 10 to 20% will be a large number in the population. But added to this misery is that we are training very, very small number of people who can address this problem. So both ways we are hit. We are not training enough number of personnel who can address this problem, because universities and institutions and hospitals have not come together. As simple as that. And if they come together and talk, details have not been worked out. If details are worked out, we go away into our daily routines and we forget about implementing these details. So at every level we are failing. This is a damn serious task, especially for India, because I think we are again a capital here. For the size of Indian problem, we strain minuscule fraction of personnel for this. Just to give a comparison, in advanced countries such as UK, just take an example of UK. Population normalized, if they have 100,000 trained personnel addressing this, we have only 3,000. Population normalized. So you can see how far behind we have been. So better late than never, these meetings should happen, and we should move forward with a positive spirit, and we should actually work out the details and implement it. The problem in these conferences is we talk, but we do not implement it. We do not take the next step. This I am seeing in many, many meetings in the country. We know where the problem is, we know how to go forward, but we do not make the first step. We do not make the second step. So there are issues that we need to address. Now, whole design of the system that gives rise to mental disorders, the mind and the brain, is such that the design intrinsically has to make errors. Why do I say that? Because we have several billions of neurons. That's not the problem alone. We have several trillions of connectivity between neurons in each of us. When we are dealing with several trillions of connectivities, mistakes will happen. That's the nature of the design. So the nature of the problem that we see in the society is a natural consequence of the design that biology is endowed with. Cannot be questioned. Because that is the level of processing you need to have higher cognition. Or any cognition. So when you are dealing with such a design, errors will happen. Therefore, we need to come up with solutions to address those errors. So we have a beautiful design. It can do wonderful things. It is doing wonderful things. It is bringing people together. It is also telling people work together. But there is also something in the mind that, okay, let me work for myself first. That's also the nature of the design. So you can see that the design is meant for beautiful things, but also is meant for ugly things. There is also design that you can go beyond the design. That is where we have to go. And that beyond the design step is welfare of the society, welfare of everybody around us, decreasing the misery. That empathy also we have, but let us stay at that empathy level and implement it. Let's not go back to our dal chawal problems. So I would not say much more than what I have just said. We should have more of such meetings in the university systems. We should also have meetings in the hospital systems where we can come and sit with you. Both ways should happen. And let us work together a modus operandi of common ground and work out the implementations. National education policy, Institute of Eminence, and country as a whole is moving towards that. Let us move also faster. So thank you very much for all of you to spare your time. It's a pre-Diwali cracker show. Okay, let us do dhamaka and follow it up after Diwali. Thank you very much. Namaste.
Thank you so much, sir, for the wonderful talk. Now I would like to invite Dr. Uma Shankar Garu, Superintendent IMH, to address the crowd.
Good morning, all of you. Today's chief guest, Professor B.J. Rao Garu, and another chief guest, Dr. B. Ram Kumar Garu, and guest of honors here, Lokesh Lingappa Garu, Geeta Vemugandi Garu, and chairperson, Dr. Ram Subba Reddy, and other deputies on the dais and off the dais. Today, we are going to have a good lectures on mental health. Suppose if you want to define health, without mental health, we cannot have a health. That is important component of health is a mental health. So that is, suppose a person is called healthy means he should have all the components of health, then only he will be completely healthy man or healthy woman, whatever, healthy society. But here there are multifactorial origin of ill health. Especially mental health. Everybody think that some problem, just like some psychological, means they don't know what will be the cause for that. But maybe neurological problem, psychosocial problems, other interpersonal problems. There are so many various reasons are there. If we know that, definitely we can address them to make the people comfortable. So here, recently, last 2 years back, we have a pandemic. In the pandemic, lot of people were infected with COVID virus. Some people are dying. Some people are they're crying for help. That way, so many stress factors were there. Because of that, many people they were faced a lot of psychological trauma. That not only for that time, that is also continued. Still, also it is there in so many families. While we are discussing the patients and we are observing that. During that time, not only they faced this trauma, as well as this education, most of the institutions are closed. Even children also, they could not go to the schools. Suppose once they started only online classes. So what happened is the children they may not be knowing that suppose if they give some gadget like some cell phone, something, so they don't know what to click, what to see, what. Suppose they get into some other things, they might be going to some like some videos, some other things, and they are getting disturbed also. That also caused many of psychological problems. Like that, there are so many problems they faced. Now, this is the area we have to address and to make them comfortable. In that, these psychologists and the social workers and the psychiatrists have a big role. But here, what I want to say is, without adequate treatment, adequate knowledge, with adequate knowledge only we can treat those people. But here a lot of people are coming up. Nowadays we are seeing in a hospital, regularly they are coming for exposure of clinical exposure like that, they are coming. Suppose if they have a adequate knowledge, if along with some clinical exposure, they can address properly. That is very important. But here, after going back to this society, how many people are ethically they are addressing, that is also very important. We are seeing nowadays in the media or somewhere, they are talking whatever they know. But it is damaging most of the times rather than helping them also. So we have to keep in that also mind. And also, I am being a CEO of the State Mental Health Authority. Now this mental health is under one act, that is the Mental Health Care Act 2017. According to that act, everybody has to get registered, those who want to treat that. So, whoever it may be, the psychologist or psychiatrist or social worker, they have to get registered. That is very important. Once they get registration, they can address those people. Suppose something goes wrong, they will be penalized. And also, whatever the institution, either rehabilitation institutions, substance induced, or any institution, they have to get registration also. That is also very important. So, without that, just like we are opening a center and counseling or treating or whatever it may be, it is not correct. So, as per the law, we will be punishable. So I emphasizing is, please help the society with a proper way. Definitely the society will be benefited, and also will feel comfortable by helping them. With this, thank you the organization giving the opportunity. Thank you.
We'll proceed with today's sessions. I request Dr. Ram Subba Reddy sir to chair the next session. The next session will be delivered by Dr. Ram Kumar Garu, Director NIPET, Secunderabad. That's on the role of government agencies on mental health rehabilitation. Uma Shankar. Okay. Ram Kumar sir, please take over the mic. Dr. Uma Shankar sir would be chairing the session. And
A very good morning to one and all. At the outset, my respects to the Vice Chancellor, University of Hyderabad, Professor Rao Garu, and all the dignitaries here who have graced the dais, and all the delegates. In fact, it's very pleasing to see very young people here. And frankly, I've been a rehabilitation person, more into with disabilities as a core sector, and very less of mental illness. So obviously, don't please feel bad if my talk on governmental schemes would be more on the disabilities, especially less the mental illness. But notwithstanding, in fact, as I was talking to sir, I just come back to India after about 15 days being away, and was preoccupied, so had very less time in preparing. But I will speak my experience here more than making it a formal presentation. So before I go, in fact, I understand we are all professionals, so I think these are lesser nitty-gritties, what is mental health and what a WHO says and what are the statistics and all. So I'd like to skip all this part. I would like to say, as you all know, the Enhanced Mental Health Survey, which actually has been a very good study, actually says about the prevalence of 10.6% among adults and adolescents, 7.3%. And imagine what sort of impact it has on the society in all terms, not only just in terms of the healthcare sector professional burden, but also the impact on the economy. So they are the greatest workforce, and we have to look at from that angle also. Again, there is a greater prevalence among the persons in the urban metros, even though most of our actually services are actually centered around the urban centers. And maybe this is the way of life, the stressful life what all we all lead in the urban centers. And again, the person with low incomes are also susceptible. And this goes without saying. All the speakers before me also have said the gaps in actually the requirement of the number of professionals and the availability. It's very glaring. And this, in fact, the government also acknowledges. In fact, during the course of my speech, I will talk about how we are trying to mitigate this sort of gap by actually engaging people who are not just qualified professionals, but also other people who can actually make a contribution. So this is the status of our, workforce availability in India, and there's nothing to explain here. Psychiatrists 0.3%, nurses 0.12%, psychologists 0.07%, social workers 0.07%. And in fact, I would like to say before 1997. Even the masters in psychology were actually, going ahead with doing the assessment part and all. But with the RCI coming in, they have made it mandatory that only MPhil qualified people are actually the one who can do the assessment. This has added to the burden, on the existing number of professionals.
Well, I understand we are all professionals here. We all know what this is all about. You see, this is a small glimpse as to how we have evolved in terms of governmental acts and policies. It started with the Indian Lunacy Act, and in fact, this was more actually, to try to protect the normal people from this, person with illness or disorders, and this was highly criticized. And it really took us like 70 years to repeal and bring about something which is slightly more meaningful. And here, in fact, this National Mental Health, this new act, that's the new Indian Mental Health Act, which came in '87, actually was drafted and recommended by the Indian Psychiatric Society in 1950s. And it took about 37 years for us to actually pass this legislation. And frankly, the application and its utility actually was in the 90s, not even 87. And obviously, since then, there have been very good progressive acts in terms of the government of India. And it started with the district mental health program. In fact, the start with the national mental health programs and then the district mental health programs. But the basic aim of all this is basically trying to prevent illness and then intervention, rehabilitation, and also creating awareness. As we all understand, you see, there is complete lack of awareness. In fact, many of us, many of known people also are actually having mental illness and associated problems. But again, there is absolutely lack of awareness. We do not even understand that we are actually going through anxiety, depression, or whatever it is. And on top of it, the lack of professionals actually compounds this, and also the infrastructure. And this national mental health program and also the district mental health programs is basically trying to take it to the primary and secondary levels, and especially the district mental health programs. Basically, they try to integrate with the primary health givers in the district and the grassroots levels. 1995 has been a landmark in terms of mental illness, because it's the first time the disabilities have been categorized and mental illness has been included as a disability. And obviously there has been continuous upgradations of this, with India being a signatory to the UNCRPD. There was and a lot of criticism regarding the legal issues and also the human rights issues with the 1987 National Mental Health Act. The Mental Health Care Act of 2017 actually has come into legislation. And at the same time, in 2016, we have the Rights for the Person with Disabilities Act, which has actually enhanced the number of disabilities from 7 to 21. And it's very important to note that many of these mental disorders like autism, Down syndrome, and specific learning disabilities have actually been included, which has been a great fillip for actually people who have been going through these things. Because see, as a National Institute on Intellectual Disabilities, we have always been actually assessing and giving the intervention process for all these people. But again, they have been greatly disadvantaged in terms of governmental schemes and welfare schemes by they themselves not being a disability, but always being treated as a condition, an associated condition of or some other issue. So this has been a great fillip and one of the landmark decisions for actually including these other mental disorders in this act. Here I would like to, in fact, I'll just flip through this. Many of the state governments actually on their own, as we all understand, the health is actually a concurrent subject with both the states and the government, the central government working on it. And there are quite a few programs, and very progressively, some of especially government of Karnataka, maybe because of the presence of NIMHANS in Bangalore, has been very proactive in coming up with a lot of programs, and they have in fact initiated many programs. Likewise, a couple of states like Rajasthan, which has initiated the Umeed program. This is basically the Save the Children. And Muskarayega India, it's a telecounseling initiative by Uttar Pradesh in collaboration with the UNICEF. And Chiri, that is Smile, actually in Kerala, and Manaswar, it's a government of Rajasthan. It's a toll-free helpline. Here, I would like to say that we actually in India we have quite a few helplines. In fact, among the central government sector, the NIMHANS has been the one which has come up with the first toll-free helpline for a 24/7 healthcare counseling and services. But again, one of the biggest drawbacks has been that diversity of languages. The point is, like when you are from a linguistic state, and you are being, there's no way that you can sort of get in touch with people and, get the right counseling in the language of your choice, except for few central government schemes. So the states have actually been restrictive to their respective states. And again, the problem has been the awareness, and also the coming out of our own mindset of denial. See, many of people are, obviously it is well known that most of us are in a denial stage, and we are all good and everything is good with us. So here I would like to talk about the Manas actually, which is a very important program of the Government of India. It's a national platform which has been set up. It is the Manas is the mental health normalcy augmentation system. After this initiation of this on a national platform with the NIMHANS and CDAC and other AFMC Pune, a very important development which has been is the Tele-Manas now, which has been just launched about 10 days back on the Mental Health Day by Ministry of Health and Family Welfare. And this has been a very, very wonderful program in the sense that it is actually cutting short many of the drawbacks of the existing toll-frees, wherein every states are being chipped in. In fact, 23 organizations have been identified with NIMHANS as the lead in this. And also, in fact, I think IMH Hyderabad is also part of this Tele-Manas. And we are very proud that IMH Hyderabad is also part of this. And this has been a wonderful program, which actually will go a long way in actually trying to mitigate the shortage of manpower. And this actually, I believe it's not just about giving the services, but also creating awareness, which is very important. And likewise, Karnataka state has initiated their own e-Manas 1 year prior to this. And Amma Manasu is one program which the Kerala government is running since 2017. And it's a statewide mental health program. It aims to address psychiatric disorders among women during the pregnancy and postpartum. And as we all know, this is the phase when women go through a lot of stress and anxiety, and it's a wonderful program, and I believe it has been very successful. The Telangana government in its own actually has started a unique initiative and mental health support to individuals, and the toll-free number, as you can see, it is 14416. 25 counselors and 3 psychiatrists have been specifically trained. I do not know if Nilofer or IMH have been associated with this program. They must be obviously coordinating with this program. Well, now actually with this I'll try to talk about some of the initiatives in the COVID. In fact, our earlier speakers have actually said, COVID has been some sort of boon in disguise in trying to come up with very novel and innovative practices. And we at NIPID, and especially our ministry, and for that matter, everybody across the governments have actually been coming up with a lot of initiatives. And the power of actually, social media, the power of actually tele and, the power of video conferencing has been exploited to the health. And in fact, if you see the statistics, the survey conducted by the Indian Psychiatric Society has validated a 20% increase in the number suffering from mental illness during this lockdown. In fact, this is very contradictory to the figures what have been reported in Europe. As I said, I was attending this European Congress on violence in psychiatry at Rotterdam, Netherlands. And there was a study presented actually. It says, in fact, like what has been the study here by the Indian Psychiatric Society, it was also anticipated that the number of psychiatric or mental illness cases would actually go up. But surprisingly, they found absolutely there is a decrease, or at least there is a stagnation in the number of psychiatric cases in Europe, which is actually contradictory to this study. In fact, when I was asked what is the state in India, I said, yes, there has been actually an increase, which is again very different than what your experiences are. And another aspect which has been brought out was, it was anticipated that the aged and old people actually would have more psychological issues, stress because of their many comorbidities and their likelihood of actually perishing due to COVID. But it was noticed that the young and the adult have actually had more psychological issues than the old people. Well, this is a learning for me, in fact, from there. Now talking about our NIPID initiatives, as I said, we have actually we have been very prompt actually in coming up with a lot of initiatives. But the first thing we did was it started in March 2020, and we have seen that, in fact, all the children with intellectual disabilities, ASD, Down syndrome, and all those people who have been restricted to their homes, and not being accessible to professional care by special educators and others, there have been a lot of psychological issues and behavioral issues with them, which includes aggressive behavior and all. In fact, we started getting calls from so many parents. Sir, please do something, take our children back to the schools and, vocational training centers. We don't care about COVID. So that was the time actually what we started is we started the tele classes and online classes for these children. And we have engaged the, different types of professionals apart from the special educators, that is the music therapy. Then we have also had this yoga and all these aspects through online. And it has been noticed that, in fact, there has been again much behavioral changes in them. And we have actually had our own toll-free line for actually rehabilitation services, and which also included a mental health helpline. But subsequently in September, our own ministry has come up with the current mental health helpline, which was again, it was just before the Manas actually, which has come up by the Ministry of Health 1 year before. And the best part about this is in this current mental health helpline, which is still working and it's working very well. We get a lot of calls. I'll show you some of the statistics. The best part was all our 9 national institutes have been roped in. And apart from that, all our 24 CRCs and about 20 odd regional centers have been roped in. And about 660 professionals were put on, on the 24/7 call all throughout. And we have received so many calls, and it really satisfying that many people who are in the suicidal ideation and who are in the drink, like sir, some calls came, so we are just trying to commit suicide. I just want to inform you. From that stage, we could bring out a lot many people back and avoid the suicides. And apart from this, these have actually been very, very supportive in providing the rehabilitation services also, because our helpline was not just about mental health. It was all about, other services in terms of the requirement of the children, the person with disabilities in all respects, especially the child and the adolescents. So this is our helpline, which we have created in May 2020, and it's still very operational. And this has also actually enabled us in long distance people actually using the telephone services for the continued rehabilitation services, and not just there being no need for them to come to our center-based services. Another important initiative of the Government of India, especially our ministry, has been of setting up of the National Institute for Mental Health Rehabilitation. As we all understand, mental illness is not just about cure, but it is a continued support which is required post-curing or post-getting out of the facilities. And this center is basically, the broad objectives are basically to promote mental health rehabilitation. And in this endeavor, they're conducting a lot of courses actually for professionals who would like to be the rehabilitators post this cure, and to promote and undertake capacity building and to involve in developing trained professionals in the area of mental health rehabilitation. They would be also conducting a lot of courses and to engage in research and development. Here I would like to say that there are a lot of posts which are being advertised, and I see a lot of professionals here. I would advise you may all be interested in applying for that. And this is actually at Sihor, near Bhopal actually. As I said, these are the type of services what they are providing. And another important facet of this institute is the outreach and awareness services. They are not just restricted to center-based services, but they go into the community and create awareness and also provide services to all the people. This is the current mental health helpline, and as I said, it is a 24/7 and it's available in 13 languages. I would request every one of you to kindly create awareness about this particular mental health helpline. In fact, I know we are actually running short of time. I will conclude my talk here, because as I said, these are all the centers which are involved in our mental health helpline, the Kiran. These are all the CRCs located at different areas. And these are the number of cases what we have seen in a span of 2 years. This is the telecalls what we have received. And the type of mental health issues what we have actually handled. Here before, well, as I said, quite a few agencies are working, and but again, sometimes we are working in silos. there is a need that we all should come across on a single platform and as professionals create more and more awareness. As I said, these services are mostly restricted to the tertiary region and the urban centers where exactly we have most of the cases. But notwithstanding, maybe we don't find many cases from the rural area because they are either not reported or they're not, even aware about their, particular conditions. So it is very important that we have to reach out to everyone unreached, and we all have a very big responsibility in that in creating right awareness. And before I conclude, I would like to tell you there is one scheme of a ministry which is called Awareness Generation Program. And under this program, the funds are provided to all organizations and everyone working in this area, where they can use these funds for actually creating conferences like this. Even for conferences like this, they give us funds which actually go in creating the right environment awareness. And again, and one more thing I would like to talk about, because this is about child and adult psychiatry, I would like to highlight the Samvad, which is of the Ministry of Child and Women and Child Development. The Samvad is basically, has been set up basically to address the needs of the children and the adult. The Samvad actually stands for Support, Advocacy and Mental Health Intervention for Children in Vulnerable Circumstances and Distress. And here, as I said, how the government is trying to mitigate the shortage of the shortage of professionals by actually having trained 1 lakh people who are actually not exactly the professionals. These are the child protection functionaries, the educators, and sometimes the counselors, and even the legal professionals have been trained. About 1,100,000 people have been trained, and these people are being used. And this is being taken through the Panchayat Raj. This is where the networking is coming up with the grassroots level workers, and with them, they are providing the necessary support for them. And also, this is for the child who are at risk and child who are at risk of criminal activities, and the forensics of child and adolescent psychiatry. So the different children and adolescents with different type of problems are being mitigated. And I'm very sure these initiatives are absolutely not enough, because we are a country with such a huge population. So what I would try to take this opportunity is, as professionals, we need to create awareness about the various schemes and benefits, and try enable people to reach out. And in fact, at NIPED, what we do is we actually go to the Asha and Anganwadi workers levels by distributing the posters. And what we do is we train the Asha and Anganwadi workers, but that is not just enough. So sometimes what we do is we put our posters there, and people who are actually all even in intellectual disability for early identification or prevention, we create a lot of posters and we put at the Asha and Anganwadi workers. And we have seen that people who are in denial also, once they say it's not me, it's not happening with me. Second time they see, third time they see, when the child is not reaching a developmental milestone or child is having abnormalities, we have seen many people consulting, and when we take a feedback, it is generally seen that we get a feedback, okay, we got it from that Asha and Anganwadi worker, we saw this poster, we got this information through this. So this is how the awareness can work out. It's not necessary that we need to reach out and be physically present there, but through various mediums. In fact, our ministry actually has been extensively using the social media platform also for creating awareness on these aspects. So I would request, maybe we all should chip in and try and put in the best efforts and create the best what we can for creating an enabling and empowering environment. Thank you so much, and I'm sure I have not overshot my time.
Thank you, sir, for in giving the information to the audience regarding the mental health. What are the services available? How the acts will be protecting the mentally ill people? The rights of the mentally ill is important. So here, as you said, DMHP programs under NMHP, DMHP programs in Telangana also, all the districts are involved now. So every district's have a psychiatrist, and also in the future they are planning to take the psychologist also. That with the diseases, almost now 17 district psychiatrists appointed. Another remaining also they give the this thing. So most probably that may be along with the psychiatrist, psychologist, and psychiatric nursing. All those people will be included, sir. And also this, as you said, the state government also introduced recently on 10th October Telemanas. That is a helpline for the society. So here, entire 24 hours people will be available. 8 in the morning, 8 in the afternoon, 4 people in the night. In coordination with the Institute of Mental Health, we are providing the technical support. So Telangana government is doing itself. And during the COVID period also, in coordination with the NIMHANS, we had a helpline from the Institute of Mental Health. So we used to receive a lot of calls from the various places. So definitely that is helpful for the people, sir. And as you said, this overall this 10 to 10.6% of mental illness is there. In children also that is between 6 to 7% is there, sir. That especially anxiety disorders are very common. So for that, the children and adolescents, they're suffering with the anxiety problems, especially for that they will be school dropping, all those things will be there. So when the child is not going to school and they are telling some of the somatic complaints, if they are telling, you have to think of some psychological issues where we have to need not go for any medication initially right now. So first we have to see that what are the causes for that. That is good role. So in that way we have to check up. Along with this, in adolescents we have to think of more of nowadays we are seeing, observing also, this substance problem is very high. Even some of the schools also they are facing. So that may be because of some low mood or depressive things, maybe they are going towards that. So we have to put some eye on that also. That is very important. And right now, with the Central University, Dr. Shaman, professor of this thing, along with him and the Institute of Mental Health and the NIMHANS, we are doing the survey in urban population regarding the mental health. That is started, sir. With this, I think it is excellent information passing on to the people, and definitely all the mental health professionals like psychologists, psychiatrists, and social workers, and mental health people, nurses, they can improve the mental health state of the people by creating the awareness. That is a very important. Maximum, this lack of awareness as well as stigma is more in the society. We have to, wherever get the opportunity, try to educate them. What are the illnesses, how to help them. That is a very important. Suppose if stigma is decreased, automatically they will be approaching the people, and we can help them. With this, thank you for giving this opportunity. Thank you.
Thank you, sir. Please be on the stage for a second. I request Dr. Uma Shankar, sir, to facilitate Shri B.V. Ram Kumar Garu. So now I request Dr. Ram Subba Reddy, sir, to facilitate Dr. Uma Shankar Garu. I request Dr. Professor B.J. Rao Garu to be on the stage. And I request Dr. Ram Kumar sir to facilitate B.J. Rao Garu. I request Dr. Geetavi to be on the stage, and I request Dr. Lokesh Lingappa sir to felicitate ma'am. We'll move on to our next talk. That's on neurobiological basis of behavioral abnormalities and neurodevelopmental disorders. I invite Dr. Lokesh Lingappa, sir, pediatric neurologist from Rainbow Children's Hospital, to take over the stage.
Thank you for this opportunity. I think the whole of the conference was actually brainchild of Dr. Somshekhar, who is the interneuron here, who connected all of us and then brought this program to fruition.
Excuse me, a big applause.
Yeah, definitely. So this is in fact the second program which he has done in this year. Last one was on the autism, and yes, sir.
Sir, I invite Dr. Ram Subbareddy, sir, to chair the session.
So Dr. Ram Subbareddy said in the morning, you had chosen a heavy topic. Be kind on the students there. So I think it's difficult when there is a mixed audience to give a talk at a level where it suits everybody. But we'll try and be as interactive as possible. I've actually, although neurodevelopmental disorders have put it, but I think most burning topic for most of us today is autism, which is a single condition, which we as health professionals and pediatricians, psychologists deal with that today. And it has more unifying cause and easy to actually navigate the talk. Otherwise, it would be too confusing in that 25 minutes to understand. So I think there are a varied audience here. What do you think is the cause of autism? What are our assumptions? Acquired, genetic, mixed? Mixed. Okay. I think that we have a slightly better understanding then. So the lot of people felt it was all acquired, and most of the Western countries, they said it is all genetic. But I think it's somewhere in between. The truth is somewhere in between. And a lot of modifiable factors. What as clinicians, as pediatricians and early interventionists we need to be aware is what are those modifiable factors wherein we can intervene and make sure the child has a normal development rather than a deviated development. So we'll just emphasize through some of the etiologies and how we study these diseases. I'll just touch upon in the last few slides. So just quickly go through the epidemiology. How does twin studies help in understanding the neurobiology and genetics of these conditions? The testing technologies, what are things that have been tried to understand the brain? And the genes implicated and the recurrence in future pregnancies, that's one of the big questions. Many of this they can ask the therapist as well. My first child is autistic, what happens to my second child? What are the chances? Is there a data to say counsel these families? There are large scale studies on that we'll go through. And I think current prevalence is almost 1 in 40, they say, in US. And here probably 1 in 100, or we don't have accurate data. And it 4 times more common in boys than girls. The gender reasons, there are various hypotheses, but not an exact reason very clearly seen. And I'll skip these things. So when you look at the biology of or this various symptoms of the autism and the areas involved where this normal functioning of these things are concerned, like in frontal lobes, the prefrontal cortex is maintaining the executive skills, working memory and attention. So children with autism have significant attention issues, fine motor skill issues, which are all controlled by this area. Expressive language is a big issue, and primary and supplementary motor area for motor skills. So even the basic skills like buttoning, unbuttoning is not possible in a 8-year-old child with autism. But when you do a MRI, you don't find anything. You do an EEG, you don't find anything. All these areas look normal. So it is at a much microstructural level. And what is that level? It's at the synaptic transmission predominantly. As the Vice Chancellor was putting it across with so much of trillions of interneural connectivity. These are the areas which cannot be studied on your scans nor on autopsies as well very clearly. So we need a completely different model to look at and understand these abnormalities. Even more challenging is to study this sensory processing abnormalities. So you have visual sensory issues, they can't tolerate bright lights, and they have gaze aversion. They just can't look at you. This, you say hello, you look at them, he'll give, shake hand. So what is the basis for this? We still don't understand. You have so much of things, the chewing. They want same type of food for 3 days. After that, they will not have that food after 3 days. They want something else. But that same food you'll have for another 3 days. So all these things, we still, after all the biological experiments and research experiments, we don't have an answer to say what is the biological basis for this. Few of the things we are getting better to understand them. So this is I'm not asking you to read this. It's just that there are a lot of things which are happening at the synaptic junction, which is very important in the autism and the social cognition. So there are genes implicated in the neuronal transmission, which will come through, is one of the major area of research interest for most of the researchers who are working and who are trying to, as they said, talked about translational research. So trying to understand this and put it into clinical practice. How can we do that? So neurobiology of autistic spectrum disorder is still very speculative because there are no good animal models. You can't have a brain like human in our animal models. Our cortex is so very well expanded, you can't create that in animal models. Minimal insight you get from autopsy studies. There are some many columnar abnormalities, but beyond that you don't have much of information. It leads on to the problem that there is no magic bullet for the treatment. And hence, there is innumerable therapeutic options. Every therapist has its own therapy option. So parents are the ones who are going to be confused and suffering the problem. So that's why understanding the neurobiology is somewhere is the starting part, and understanding the role of the genetics and the other aspects which can actually help us to understand the disease. So in the ASD genetics, there is some role which is increasing. We'll just go through them. In twin studies, what they have seen is if you have a monozygotic twin with autism, there is a 76% concordance, maybe even higher, up to 90%, that the other twin also will have autism. Whereas in dizygotic, it is very variable, maybe 0% or up to 4% in the dizygotic twins are a population incidence. So these are the various things which will say there is a huge genetic overlay of the genetic etiology for the autism, because the monozygotic twins share the same genes. So they are at higher risk for autism. So proband-wise concordance in monozygotic twins is 96%. In some studies, as I said, it might range from 75 to 96%. And I'll not go through the complete details of these studies. So this is, I hope it is projected well. So when you look at the genes of these children, when they have done the whole genome sequencing of thousands of these children, and when they have looked at it, the inherited common variants, there are some common variants, but you cannot say this is the exact reason. So they have found almost more than 1,000 allelic variants or CNVs. So they are not, they are associated with very low risk. Individually, they can't cause autism, but combined probably they might cause problems. But there are around 2% which are inherited CNVs, copy number variants, where either deletion or duplication on gene 15, gene 16, and gene 1 and 17q, all these things are known and ascribed etiological factor for autism, but that is only 2%. Rest of it, we have around 9 to 10% where there are de novo variants. That is a deletion of a part of a gene, which you find will cause a syndrome, and in high incidence there is a autism with this. It is not a pure autism. The child will have other diseases like epilepsy, cardiac abnormalities, facial dysmorphism, all those things are seen. So when you see that additional factors, you are looking at this child has more than autism, more likely genetic. So you can't just start giving therapy. This child also needs a consultation with a geneticist, a neurologist. So that is how it will trigger you. There are certain children with very large head with autism. Slight large head with autism is normal. With microcephaly and autism, you need to look at genetics once again. Because generally in autism, the head size is slightly on the larger side. Because the process is that there might be impaired pruning. So postnatal when we are developing, so there is a lot of connections which are there between 1 to 3 years, which gets less and less and less, and only the activity dependent pruning happens. You give a lot of social stimulation, those connections will develop better. So when the activity dependent pruning is less, your head size is slightly on the larger side. That's why in autism, generally the head sizes are larger. So if you have a very large head or a small head in autism, you are likely dealing with either a structural abnormality called mimicking autism or a genetic cause causing microcephaly and autism. And there are around, in this study, what they showed was around 38 or 40% had clear environmental risk factors, which not only just the gadgets, what we talk of, in utero exposure to alcohol and a poor nutritional status, intrauterine infections, hypertension, all those things can be the environmental factors. Apart from the gadgets, what we commonly talk of, gadgets do have a role, huge role, but that is not the only thing which we can implicate and say this is what the reason is. So you'll have to look at the history of whether there is a history suggestive of X-linked intellectual disability, any neurocutaneous marker suggestive of tuberous sclerosis is a condition where almost 35% of the tuberous sclerosis children have autistic features, severe autism, and clue towards any particular genetic conditions, including Down syndrome, Fragile X, Cornelia de Lange, and Rett syndrome in girls. So these are the various conditions, genetic conditions. Don't read or remember this. This is not relevant for you. It is just that there are huge genetic conditions which have autism as a part and parcel of their genetic syndrome. They will have other problems. Like Angelman will have epilepsy, ataxia, intellectual disability. Along with that, they have a large contribution of autism. Fragile X, once again, will have large head, large ears, macroorchidism, but autism is a major factor there. Similarly, Prader-Willi also will have. Patent disorders will have increased risk of cancer, but in the initial infancy, they come with you with the intellectual delay and autism, and they have skin tags as well. So that's how we make out these children. So all of these children, what it is telling is, so if autism can be there in so many genetic disorders, these genes independently can also cause autistic spectrum disorders. So there are various tests. These are various things what researchers are looking into. I'm not asking once again to understand any of this. So this is pre-synapse, synaptic cleft, post-synapse. So there are a lot of genes involved in all these areas. Okay. So the common genes, what we look at as SHANK1 mutation. SHANK mutation is one of the common things, DLG, Homer mutations. These are common ones which are SYNGAP. These are common mutations which when they are seen in your genetic mutations, you can say yes, SYNGAP1 mutation is very likely cause of the child, your child with autism and intellectual disability. So there are various ways to confirm that. Similarly, there are various receptors. All these receptors at the synaptic cleft once again are being guided by the genes. How did that receptor come into that place? By the gene. So if that gene is not functioning, your transmission is not right. When your synaptic transmission is not right, you are not able to communicate. And that will reflect in autism. So similarly, post-synaptic, these are many genes. So like this, they can interact. They are having role in chromatin modeling, transcription factor, protein synthesis. See, at a psychology level, you are looking at a much broader what is manifest. But as a researcher, he is trying to understand what is causing the manifest thing. Okay, so that is why there is so much of research which is going in, and these are many other metabolic conditions. There are some chemical abnormalities which can lead on to autistic spectrum disorder. So genetic conditions with metabolic abnormalities causing autism as well. And there are certain clinical clues for a child who are looking at a mitochondrial disorder and other problems. If a child has recurrent vomitings, if there is a regression, any child, not just autistic regression, all of us know of autistic regression, where between 18 months to 2 years, the child loses the speech. Okay, around 30% have autistic regression. But there are certain regression where along with the speech regression, they will also have motor regression. So once that happens, or vision is also going down, optic atrophy, or if you have any neurodegeneration outside of typical speech loss between 18 to 24 months. As I said already, microcephaly. All these things should make you think of, we are thinking something beyond the standard autism. So what are the tests to detect these genetic causes? The chromosomal microarray is one of the common tests which is used. And apart from that, which has a yield of only around 3 to 5%. So if you send 100 children for testing, around 5% with chromosomal microarray, you get an answer. So this is a child with tuberous sclerosis. You can see these hypopigmented macules and plaques like this, which is usually a very easy clinical diagnosis. And they can have these calcifications. And this is a child with large ears and thick nose, which usually elongated face, usually part of Fragile X condition, which in males it is seen generally. Female, and not most of them are manifesting with the abnormality. I think if you see this in a girl child with autistic features, your diagnosis should be Rett syndrome. So they have repetitive stereotypic behavior. So that's why there is all autistic spectrum disorder girls with severe intellectual disability, and usually it's very easy to differentiate clinically. Although they have autistic features, but they have epilepsy, they have motor disabilities more significant than this one, and microcephaly as well. So that are good handles to say that is Rett syndrome rather than a simple autism. So this is a child with large head and had what is called as PTEN gene associated mutations. So why it is important to pick up some of this? They are rare. We have had only 2 children in last 10 years. It is important because later on they are going to develop tumors. They are going to be under every 3 yearly surveillance after they are 10-year-old tumor surveillance. So understanding that will become important. So I'll just not go into details of all the details of genetic testing. I'll just come to the thing, what are the testings that needs to be done and risk of recurrence. So risk of recurrence. So if you have couple with one affected child, the risk of recurrence in general is around 3 to 10%. So if there is a first child is female child with autism, the risk of recurrence slightly higher. It is 7%. If the first child is male child, the risk of recurrence is around 4%. Minor variations, but this is what the data says. If you have 2 children already affected, the risk is 33 to 50%. 2 children are already affected means that your genetic, this one is overloaded towards having a child with autism. So this is what the information in a very large population-based study, which has been published in 2014. And I think almost the same kind of data, but this also gives information on maternal half siblings and paternal half siblings. If they are half siblings, the risk is not very high, 2.4 and 1.5%. So what are the genetic testing we do? Generally recommended testing is 3-generation family history, detailed examination to know any syndromes. And you currently what they are doing is whole exome sequencing plus microarray, which has a yield of around 10 to 15% to diagnose any of these conditions. If a male child, you also add Fragile X. If it is a female child, if you do MECP2 sequencing as well. Okay. So all forms of genetic testing are available in India, and the cost somewhere ranges between around 25,000 if you have to do whole exome sequencing with chromosomal microarray, which is almost 20 times cheaper than what it is costing in US. So it's quite cost-effective testing. Whenever it is required under proper supervision, it can be easily done. But one of the important information when they studied the families and you gave the information, this is the irritability factor, this is the risk factor. Majority of the mothers, even when they told recurrence was an option, they didn't actually consider that information whether they want to have another child or not. They just, if they wanted to have, irrespective of that recurrence risk counseling, they went ahead and had a child. So this is one of the information. Okay, I think the last part of few slides, this is something I think it is very exciting. Have you heard of brain organoids? Yeah, I think there is 1 or 2 hands going up. So you want to study the brain, how it is functioning, but you can't get it out in and make it work outside the brain, isn't it? You can't research on it. But I want to do something about it. So now they are doing it in a petri dish. So they are inducing the pluripotent stem cells, and they are diverting with the appropriate chemicals and genes, and they will start behaving like the neurons which are there inside the brain, which is magical, nothing less than magical. So that forms medulla. You can make them to form midbrain. You can make them to form prefrontal cortex. So you can study each part, and the beauty of it is you can introduce a gene which will stop this one. Like you have a family with Angelman syndrome. So you introduce that gene abnormality into that organoid, and it will have the features of this one. So you cut that and slice them, do electrochemical experiments to see what is biochemically happening. So you have a gene missing, but how is it actually causing the disease? So that is the world, I think, is evolving towards that, and it is the most fascinating thing which will give many answers to us, I think. So this, in petri dish, they are growing the parts of the brain and making them work, and it's a huge progress, I would say, in the history of neurosciences. So this is Angelman syndrome. I've just taken this example. It codes imprinted UBE3A gene, is that called. It's called E3 ubiquitin protein ligase. So it's basically ubiquitinates proteins for subsequent, it degenerates. Actually, a lot of degeneration keeps happening for smooth progress of the working. So the loss of function of this gene caused by either deletions or mutations, it will cause defects in ion channel processing. Basically, it has a potassium channel processing. So this is the healthy organoid, and this is how the UBE3A works, and it is actually recycling the potassium channel here. So it is degrading it, it's working normally, and your calcium spikes are normal. So which is, they have studied the calcium spikes, the electric energy which is going across the synaptic channel, they have studied, and they have found the calcium spike is one of the marker for this channel is working normally. When you introduce in this organoid where the UB3A is gone, so there are a lot of potassium channels which continue to work. We didn't want to work continuously. You have to have an optimal number of calcium channels there working. When more channels are working, more electricity is produced. When more electricity is produced in your brain is electrical short circuiting is happening. Electrical short circuiting is you are having tremors, you are having seizures, all those things. Why is that? Because your calcium channel spikes are much more than what is normally there. So this is why then what they have done is, there is already a model in the research mouse model that there is something called paxillin, which is actually inhibits the BK channel. These are called BK channels, B potassium channels, and it reversed all the phenotypes in the organoids. So now you are understanding, which we understood only this gene was missing, it was causing the disease, and today we are coming to a place where I am introducing this drug to change that, and then you can actually make things better. And this paxillin treatment could ameliorate seizure susceptibility in these mice and the organoids. Okay, so paxillin is a specific BK channel inhibitor widely used in various biophysical and physiological studies. What happens is there are a lot of researchers sitting there doing years and years of research, and only probably 1% of it comes into clinical use. But I think that might make a huge difference to all of us on a day-to-day basis. So these are various things which brain organoids and disease insights, even for autism spectrum disorder, what they have found is increased production of neurons owing to accelerated cell cycle is one of the pathophysiology, dysregulation of early gene regulatory networks, and ventral and dorsal lineages are all the various things which have been found. So I think there is huge potential for us to learn and probably intervene within our lifetimes. And I will leave it with this last slide, that yes, the neurobiology is multifactorial, but there is a huge role of environment interacting with the genes and then causing these problems. But I think we should be aware and alert to all the different possibilities. Thank you.
Thank you, sir, for your wonderful presentation. Actually, these neurodevelopmental disorders, it covers nearly 60% of child psychiatric disorders. I think it is difficult to cover in a single session all these disorders, even autism spectrum disorders. So that's why I asked Lokesh sir initially. It is difficult to understand unless we know the neuroanatomy and neurochemistry. It is difficult to understand these things. So sir nicely covered and minimized these complicated things in the subject. And the main important thing here is the genetic tests are more important, and some of the clinical features of these autism spectrum disorders you require. You should understand all these clinical features. And sir, even also he covered the synoptic understanding in autism spectrum disorder, which is the new thing that you can go and search further. And the another thing he covered is brain organoids. I think I didn't hear so far. Brain organoids. I think very people might have heard. And this is a good thing. I don't know how far it is useful in the treatment purpose. Sorry, recently covered the fictioning like this. It will be helpful in curing the seizure disorders. And regarding the autism spectrum disorders and all those things, I don't know, sir, how it is helpful. Is it helpful, sir?
I think the understanding of the disease is the first part, sir. So they are making now, because now we can study the model. Like if you have a gene, or you put this one from the into the organoids, you introduce the genetics of the affected child, and then see, study the synaptic connectivity, see how it is working, and then at that point you try and the next step would be to try and introduce, is there like Pixelin was there for Angelman syndrome, is there something else for the children with autism to modify that abnormality, the increased number of neurons or the abnormal ventral and dorsal convergence of the neurons. So that is the next step. But understanding the biology of the autism, I think this is the best way.
Yeah.
That's the best way you can do it.
It is helpful in understanding the disease process.
Absolutely.
Okay. Sir, if it is a genetic background is there then?
Even for the genetic background, like Angelman disease is a genetic background.
Yeah.
So there also they could find the pathophysiology, and then trying to introduce the treatment to redesign the synaptic connectivity.
Redesigning is possible, sir, with these organoids?
Not with the organoids. Organoids will only help us to understand the disease.
Yeah, that's what.
And then that can be put into clinical practice maybe over a few years.
Yes. Thank you. Thank you very much. I think it's a very good subject, broad, and I hope we have enjoyed all these things, new things. Thank you very much, sir, for your wonderful presentation once again.
I request Dr. Ram Subba Reddy sir to felicitate Dr. Lokesh Lingappa. Now it's a time for tea. Please be back. Please try to assemble back within 15 to 20 minutes. We are running a short of time.
నా పంపించగానే దానికి దీనికి కొంచెం అది నా ల్యాప్టాప్ ఏదో అలా ప్రాబ్లం వస్తుంది ఎడిట్ చేసి పంపిస్తానన్నాను అది అవ్వలేదు మళ్ళీ ఇది షోయింగ్ అసలు పెండ్రైవ్
Check it out. Just come.
మనకి లాగిన్ చేసి డౌన్లోడ్ చేసుకుంటారు మెయిల్ లాగిన్ చేస్తారు.
వాట్సాప్
ఇక్కడ వైఫై ఒకసారి ల్యాప్టాప్ డేటా తో ఉంటుందా 5 అవర్స్ ఇంకా
ల్యాప్టాప్ అంటే చేసుకోండి ఇందులో కాపీ చేశాను
అది
ల్యాప్టాప్లో ఇంకొక ప్రెజెంటేషన్ ఇంకొకటి ఒకసారి కనెక్ట్ చేసి
సైడ్ బై సైడ్ మీరైతే ఇది ఓపెన్ చేస్తారు అచ్చా
Welcome back. I guess we are good to go. I request Dr. Ram Subbareddy sir to chair this session by Dr. Gauri Reddy madam. She is a consultant child psychologist at NICE Hospital, Hyderabad. She'll be talking about mediated learning experience by Professor Ruben. Yeah. Take over.
Good afternoon, everybody. Nice time to talk after a break. Everybody's awake. And they cut my time from like 45 minutes to 20 minutes right now. So I will try to run through this as far as I only have 8 slides with my thank you slide together. So I think I can run through this. So this is not connected to mental health as a subject or mental illness or mental disorders. So I'm trying to do learning as a concept. So when I'm saying learning experience, I'm not focusing on children with disabilities, children with specific learning disorders, nothing. It's for learning as a concept, as an experience. So how you can mediate learning, and why Professor Ruben Feuerstein has come to my title slide, because the concept is this. Has anybody heard of this concept before? This word and this person? Okay, thank you. Slowly go ahead. Fine by me. 3. Okay. So I click on the next door. Next door. So very quickly, this I will take like a minute on this. He's the person we were talking about, Professor Ruben Feuerstein. He's a Jewish psychologist. This you can just read through the slide. I have no problems because it suggests his biography taken from Wikipedia over the net. So the only thing I would like you to focus on is the first point for what he was known for. Intelligence is not fixed, it is modifiable. What do you mean by modifiable? Is it changeable? Is it equivalent to changeable? Is modifiable and changeable the same? Do they mean the same? Are they synonyms? No, not really. So changeable is you can change, but modifiable with a direction to the change. Right? And so his applied systems or theoretical systems are structural cognitive modifiability. The first 3 bullets I will discuss in brief in the next 3 slides. The next 4, I think I'll need another day to work on them if I go through them. So he passed away in 2014, and he was the founder of the ICLT in Jerusalem. They do a lot of work with Down syndrome children and children with specific disabilities with autism. So for him, the concept is his basic theory is structural cognitive modifiability. Now, my title slide was mediated learning experience, and I'm going into a different concept called structural cognitive modifiability. Why? Because this is the theory for which we use mediated learning experience. So that is to follow. So the basic assumption of this structural cognitive modifiability theory is that the human cognitive system, I'm stressing on cognitive and not behavioral. So we are working at a change at the cognitive levels, at the thinking levels, not at the behavioral levels. So this is characterized by plasticity and modifiability. So when a child comes, when a person comes, when whoever it is you have to teach comes to you, you know, oh my God, this child, I cannot work with him or her, he is not changeable, I have reached my limits. It's like I cannot work with him further. But you entrust the same child to another person, probably they will make a progress beyond what you have done because they are thinking differently, right? So the theory of, again, SCM maintains that all humans can be modified irrespective of the cause for any dysfunction or delay in their development. So the present condition of the person, I'm not even saying a child, is not primary reason for you to decide on your working with that person. So he believes, saying he does not, this Professor Ruben Feuerstein does not believe in labeling a person. He will not say, this child has autism, this child has Downs, this child has an expressive speech delay. It's like, whatever you say, we are not focusing on the observable, diagnosable, labels. We are only seeing what is the deficit. What is the deficit and how can we strengthen it? So what are the strengths and the weakness of the child, and how do we use the strengths to pull up the weakness of the child? So the child, you are modifying, trying to modify the child. Now, so I use the word child because it's just that we are so tuned to working with children. And now the third point, I am getting towards my main topic. The theory suggests that in order to create a systemic change, the individual requires the intervention via human mediation. So obviously, see, when you put in a situation, if you're seeing a stimulus, say, you're looking at it and you're assuming whatever you can from your past experience from that stimulus, right? But why do you need a human mediator there? To tell you what it is exactly it is, what it was meant to be, why it was shown in that particular fashion. So you need a human mediation, a fundamental shift in how the learner is taught to process and interact with information across all aspects of their life. So we are not confining ourselves to a classroom situation or an academic situation or a specific situation. Suppose, exactly what I'm doing today is so wherever you're any learning situation, any learner situation, this has to cross your mind. what I'm saying today here. Basic concepts very quickly. Now, what is mediated learning experience? Now, this refers to those human interactions that generate the capacity of the individuals to change, to modify themselves in the direction of greater adaptability and towards the use of higher mental processes. Okay? So, we are all leaning towards, what do you say? Thinking, using our cognitions better. See, for example, would you like a behavioral change or would you like a cognitive change in the person you're working with? Why cognitive and not behavioral? Anyone?
Because cognitive is something where the person is taking its own decision, thinking, the process is happening.
Right, thank you for that. Behavioral is a very superficial change, right? So when we talk about behavioral modification and we talk about a cognitive change, right? So there's a marked difference in the use of terminology when you're not saying a behavioral change. You're just saying behavior modification. But this is a cognitive change, right? So give me a second. I just want to open this because... Okay. Now, with this comes the next slide. Now, I'm not going to say anything about the next slide. I will just show you the picture. And if anyone has seen the diagram before, please do not answer. I want an answer from one or two people from the audience. What you will understand from that diagram. There is no right and wrong. Do not think I may be wrong, I may be right. But just see the picture and tell me what it is. Anyone who hasn't seen this diagram before? Look at it. Give it a minute. Anybody? I just have 20 minutes here. And I have 3 more slides to go, which are quite intense. Come on, now I'll have to pick up somebody then. Rishi, have you seen this before? Come on, tell. I'll start with the first bench. Come. And then I'll go to the last bench. First bench. You're sitting in the first bench right in the center. Come on. What do you infer from this diagram? I'm trying to wake up people. Come. Quickly. I'm going to go to the next speaker's time.
What is magnification, madam? What is it?
I am not saying anything about the slide, sir. You see, I am going to the mediator now. This is a stimulus. You all are the learners. Now tell me what you'll understand from this and how I will get you all to understand it. So, stimulus, S, response, and what is the O in between? Okay. Person, organism. Organism. Okay. Now, what are these two H's standing in between? Human. Okay. So, this was the stimulus presented to the organism, which I was wanting a response. No mediation there. So most of the, how can I don't know. So most of the,
you can use a mouse.
I can use a mouse. Oh, nice. So the audience was this was the stimulus, right? This whole thing. This is the stimulus, right? You all were the organism. So you all saw the stimulus. So something from the stimulus came directly to the organism, right? Without interface, without the human interface. And then you all have given me some response, the outer, without any mediation, without any interface, as you all understood it. Now, this human, me now, I am the human here. I have come in here in between the stimulus and the organism. Now, I am trying to get you all to understand via mediation to make you all understand what this is, right? So, now I have told you all what this is, right? This is the stimulus which is as understood by the organism directly. Some said observation, some said organism, which is O can stand for anything in English language. But when the human comes in, now I'm saying, so when the stimulus is presented to the organism via the human mediator here, I am trying to direct the flow of the information to you all. Right? So what do you see here? Suppose not even this. That comes the next slide. So what you'll see here, it was a picture with an S and a H, O, H, R, and with various lines going in different directions, right? So now the stimulus, this is what you'll perceive, and this is what I am trying to mediate. So it has come directly to me also, human. But I am trying to play with it and modify it to your understanding. And obviously, I cannot use one particular method to make a auditorium full of audience to understand in one particular method. So I have to use some way to do it, multiple ways to do it. So the left and right brains, the linear brains and the artistic brains. So I have to use a combination of both the brains to get there. Now, after I mediate here, you all have understood it in a particular way, right? And again, you all will respond, you all are capable of responding in your own particular way. I haven't asked you all to respond. So if I say what, oh ma'am, yes, now I understood this is organism, now you all are teaching me, you are focus, making me focus on how to understand the picture, the stimulus, and now I understand this is it. No, I don't want that answer. That is not the end goal of my slide, of this slide presentation. I want now the human is also coming in here. Because now I will say, do I want it in a concise form? Do I want it in a paragraph form? Do I want it in a verbal output? Do I want it in a pictorial output? Have I mentioned that? No. So when I come to that, when I come to this, when I'm here, sitting here, now I will tell you. Now can somebody put it in like 2 lines, 2 sentences, what is here? Are your brains working? When I say 2 sentences, what does 2 sentences mean? One sentence starting with a capital letter, ending with a punctuation. Second sentence starting with a capital letter, ending with a punctuation. I need to fit it in between those 2 only. I can't go beyond that. A sentence can't be very long and complicated. In 2 simple sentences, I'll say, to complicate it further. I do not want an and but and therefore and whereby in between, commas. So can you do that? In your heads, I don't want it out. 2 simple sentences, a summary of this picture. Done? I'm not doing further now. Okay. Now what are the cognitive functions needed to learn anything or to teach and to learn anything? Okay, sorry for that, the red one is quite dull. So obviously the 3 phases in your learning. There's an input phase where it is coming in, you're taking in information. The elaboration process where you're processing it in your head. What does it mean? Have I seen it before? Do I know it before? And the output, how do you say it out, right? How do you output the information? Now input is a receptive level. So you have to be adept at data gathering. The data presented to you, what is there? What should I be looking out for? What can I see? What is important? What is not important? It has to be systematic, it has to be accurate, and it has to be clear. So you can't say, I see it's like, I see a screen with, I don't know, there's some words written on it. Yeah, there's one red, yellow, and green blocks there. I really wanted to see what is in there, what is the head title, what is in the headings, what does it mean? Does it make sense to you now? Now, elaboration, once you have collected the data, what you see, now there's a process, how you process the information. Now, you define the problem, you consider the evidence. What do I need to look at? What should I avoid? Compare, hypothesize, summary, and retain. Retain it within you. We haven't come to the output. Right? Now, once you come to the output, that's the expression and communication part. Whether it's written, oral, verbal, non-verbal, that's a different story. Now, that has to be a mature output. It has to be accurate, appropriate to the question asked. It has to be participative and with verbal clarity. Yes, ma'am, I thought it was that, but I think it may be... No, wait. I'll go back to it. Finished. Your 2 sentences over there. There's no answer there. I haven't got my answer there. So can you be very accurate with verbal clarity with the appropriate words used in your output? Right? So even the input has to be clear. You have to be clear in what you need to gather, how you need to process it in your brains, and how you need to express what you have understood. Right? Okay, now a very straight question with the next question. I really need answers now. Otherwise, Dr. Rishi will be up if nobody's going to answer. What do you see here? Very specific question. What do you see on this slide? Somebody, just put up your hand in this because I'm not able to hear you saying it. What do you? Nobody hears anything on this. Sees anything else? Like, come on, somewhere in the back bench. Good. Okay, that's the title. Nice. Good. See, there's nothing right or wrong. See, that's how I want you to go on. Come on. Yes, parameters of family. And that's all you'll see. Oh my God, a whole big slide with so much matter in that.
This is written 3 colors.
Awesome. That's exact. That's one of the thing I wanted to hear. Yes, the 3 colors. Pardon? Oh, there's a diagram. Okay, a figure with definition in it. Anybody else? One more input. Okay. What is it you can see here? What is it you can see in the Venn diagram? Okay. Are the bullets on the left hand side and the bullets in the Venn diagram the same? Nearly the same? Please say nearly the same, no? I was trying to make them nearly the same. So, okay. The wordings are different, yes, the wordings are different because I picked it off the diagram.
Yeah, I think they are same.
Nearly the same, yeah. They've just worded differently. Good answer. So now why did I choose 3 different colors here? All my slides are black and white, it's like boring slides. Why did I choose 3 different colors here? Come on, compare the Venn diagram to my colors and tell me. No. Sorry, okay, I will not use the word. No. Anything else? Okay. Anything else? That's a good one because I was getting bored of black and white. Yeah.
Attributes of mediation, learner and...
Awesome. Awesome. Good job. Thank you. So there is a learner here who is the focus of attention. The mediator is here and the mediation is here. Right? So how does a mediator and mediation go together in making the learner a powerful whole, a complete person, right? So the learner attributes are in black, which are common to all 3: learner, mediator, mediation. The black ones, the first 2 are for all 3. The red are for whom? For the mediator. Specifically, the attributes of the mediator, what the mediator should be thinking and talking about. And the blue is for the mediation process. How does it go about? Why do you have to do it that way? Right? So this I will take about 5 minutes on this slide. Now what are the first one is intentionality and reciprocity. Now I am coming here and standing here and saying, now I will talk about mediated learning experience. Fine? I want to talk about it. My intention is there to talk about, I want to tell people in the world and this audience and get this concept, what do you say? To the rest of the world, whatever, through you all. Saying I want this concept to go to other people. But if I'm saying I want to do mediated learning experience and you all better listen to it. Now, there is an intention on my part. Is there an intention in your part to listen to this? I think so because you all are sitting, you all have paid and come here and used a Saturday to come here and sit here. So I am assuming, but is the intention there to listen to this? Do you all want further input on this? Loud, yes, please. Yes. Thank you. Okay. Okay. Reciprocity, intentionality, and reciprocity. Reciprocity is from both sides. I have to be willing to teach, and you all have to be willing to learn. If you all are the learner, right? Only then can a process happen. If it is even if it is a one-sided, you want to learn, I am not willing to teach. I am busy or something. Your mother has appointed me, given me like some 1,000 rupees per class, saying you 1,000, madam, you sit here. That is my motivation to come and teach you, not the intention to teach. I am getting 1,000 rupees per class. So that intention and reciprocity is not there. So make sure, so understand, anything which happens in this process is not accidental or coincidental. It is with a purpose. There is an intention on both sides, the mediator and the learner, and there is a reciprocity from both sides. I want to teach, I want to learn, right? And then active participation and shared conduct. There has to be active participation from both sides. Again, because I am getting paid for the class, I will not come here, or because the student is pushed by his parent or somebody or the teacher, He or she is not sitting there to sit and go through the class. There has to be a memorandum or whatever, or an agreement between the learner and the learning, saying, I want to teach, I want to learn, right? And then only can you go ahead. Now, meaning, the red part is for the mediator. What do you mean by meaning or significance, which is parallel there? Meaning is, what are you meaning? Now for the mediator, I am the mediator, if I call myself the mediator, and you all are the learners, right? So from my side, I have to know why I am doing this. What is the purpose in me doing this topic, or why am I saying these words out of my mouth? Just because I have an option here, sir said, give a talk, I have chosen this topic, I'm standing here and talking randomly, doesn't make sense. I have to know why I want to do this. Okay? There is a meaning to why I'm doing this, and that has to be, what do you say? Conveyed. Yeah, conveyed to the learner. Why I am doing this, right? And then choice of optimistic alternatives. It's like optimistic, you have to say, for me as a mediator, I have to say, okay, I'm trying method 1. I'm going in path 1. Doesn't seem to be working. I don't give up. I say, I have alternatives. What next best can I do? What is my next alternative? What is my next alternative? If you're saying that student cannot learn, it is wrong. It is completely wrong. You are not teaching correctly. Every child, every person in this world can learn. Right? So I'm not going to a child. I love this. No offense taken. But if you have a dog, you know this. See, if you have a pet first time dog, if you show a biscuit or a food, what does it do? It'll jump. It'll jump and try to take the food. Right? That is what it is. It knows, and now you're the meat, you want to train it. Right? Training is the word you use for a dog, not for a child, poor thing. But how do you train the dog? You hold on, or you say, pat it, or there are 100 million ways to do it. But is the dog trainable at the end? Of course, yes. So is a child, so is a person, so is any human being, so is any organism. You have to know, the mediator has to know how to get there. Okay? Now, feeling of belonging, again, I have to belong. I can't say I was paid to come here and I was given a chance to talk, so I will talk. I want to belong here. I want this to happen. I want to get this information across. So I need to belong to the situation more than the learner to be there in that position. Individuation, psychological differences. Psychology is the study of individual differences. So each child is different, each person is different. I have to understand that difference in that child, in that person, and pave my path along according to his learning curve. And regulation, control of behavior. Obviously, you're there to regulate it. The child can be impulsive. Then how do you stop the child from being impulsive? How do you... So, for example, in the previous slide which we went to, suppose input, data gathering, the data gathering. I have shown... Okay, I'm done. I have 5 more minutes. So, how do you teach the child to see when I told you what is here? How do I tell you what do I need from you? Do I need the titles? Do I need the content? Do I need the colors? Do I need an overall perspective? Do I need you all to go line by line? I was not clear in that. Right? So I need to be clear in what to expect and how to control the behavior. Now for the child, for the mediation process, challenge and search of the new info. See, once a child is more confident in understanding what is happening and he's more confident in his capabilities, obviously the child is searching for newer and complex things to do. He's challenging himself further. Wherein the same child was not so confident before, he said, I don't know how to study, I can't do this. It's like, that sort of behavior. Then awareness of human existence as a changing entity. So the mediation is bringing out that saying you can change, you can become better, there are more possibilities within you, feeling of competence is getting increased. Then once you're competent, once you're seeking out new behaviors, obviously you're setting new goals. Your goal setting becomes higher or more complicated, planning and achieving. And transcendence, like Sir had said in the morning, going on to higher, what was the word he used? That was a good one actually. So? Self-actualization on to higher, it's not like, if I've taught you all today how to gather, it's not gathering information for that one particular task. You'll have to be able to go and out, on a road, you're seeing instructions, you'll have to be saying, okay, what are the things I need to look at? What are the things I need to delete? It's like I don't need to look at. So those are the things I need you all to look at. So applying it to other areas of life, what you'll have learned in the classroom. That the only important, how do you do mediation? Now the best way is question. So if you have given an answer as a learner, if you say this is it, why do you think so? I English has like 5 W's and 1 H at our disposal. Why do you think so? Even if it is the right answer. I'm not saying just because it's the right answer, say, oh good, you gave the right answer and move on to the next question. Why did you say this is? Why can't it be this one? Why should it be this one? Why couldn't it be another way? See, because you're providing alternatives to the child, saying it could have been something else, but why couldn't it be that in this particular situation? So why could alternative 2 be a better option in another situation? So you're teaching the child to know and to look beyond the current situation, right? And yourself. So it's like, see, when you're questioning, you have to have a knowledge of the basic concepts. You have to be thorough in what you're teaching or what you're going through. You have to have the ability to verbalize the use of language. Your concepts and your language should be clear. Cognitive deficits, what is this child lacking in those 3 areas? Is the child not able to gather data? Is the child not accurate? Is the child not able to verbally communicate? Where is the deficit? So you have to know where to work on the child. Know how you think, that's most important, and how to conclude from my own thinking. It's like that would be really important for all this. Very quickly, can I go through one more? Sorry. What do you see here now? Come on, as a page. Very quickly, see, she's going to pull me off the stage now. Another 2 minutes.
In the previous slide, ma'am, you've written 5 W's and 1 H.
Yeah. Why, what, where, who, when, and how. What do you see here? Quickly. Come on, man, nice pictorial picture I'm showing her. Sorry. So this is one of the instruments by Professor Royal Shah. This is the basic, the first instrument and the first page of it. How we work with the child. Come on, quickly. 2 minutes. It all depends on how fast they're going. Oh, I don't see anything here. Yeah, sorry. So why is organization dots on the first page? Now let me work with you. Why is organization dots on the first, on the top? That will be the title. That is what to expect in the next pages. So that means they're going to be dots and you will be taught to organize. What do you mean by organize? What do you mean by organize? Organize as an English language? Yes, I am not joining, you know the next page. Joining the dots, you know the next page. So organization basically. So there'll be some random things and you have to learn to organize. So how is it? See, there are random dots here, stars, and you'll try to make sense out of the random dots. Now just a moment, let me think. And what is the child doing there? How do you know he's thinking? Is that the pose to do while you're thinking? One of the poses. So see, this is just the, like, not even the tip of the iceberg I have touched on this page. I can sit for an hour with you on this page and talk to you about the next hour. Just on this page. Right? So the next page would probably be like this. Okay. So this is what the first page would, the first half of the first page would look like. Now what can you see here? Sorry, it's a little blurred. I zoomed in on it. What can you see here? Color dots. Anything more specific, please? I need you all to tell me what you'll see and make sense of the page. Okay. 2 different colors. But before that, what is the thing popping out here as soon as you see the page? Shapes. And even a more wholesome view of the page. Don't go into parts. The page is divided into squares, into frames. So what is happening in each frame, in each square? So I will talk about a frame, I will talk about boundaries, I will talk about why do you need boundaries in your life. I'm not talking about boundary in here. So from frame to space to boundaries to why do you need boundaries and depending on the specific need of the child. Where do you have boundaries? It's like an outside person, inside person. When a guest comes, when you don't guest comes, when it's a family voice, it's an inside voice, outside voice. So all those will come and it's not just joining the dots here. Right? So this is how we start normally working with the child. So nothing is like limited to what you see here. Okay, end it with this. Leave you all with a question mark in the head. Search for more answers. Absolutely.
I think you use the word training can be used for a dog and not for a child.
We don't like to use the word training. We don't like to use the word training. That's all. Not, yeah. That's actually the most apt word to use, but I wouldn't want to use the word.
What are the implications of this method can be applied to any or
As learning as a concept in any field. So how you see, if you want to teach something, if you want to learn something, say now, even you're not a teacher, what do I look out for here?
Is there any restriction for any age group?
Nothing, sir. It's learning as a concept across all age groups. Any situation.
specifically neurodevelopmental disorders?
I know that's what I started with. There is no labeling here. You look at the what is a child with an autistic child
Communication
deficit? Communication deficit. So who can communicate? What do you say? How does it come here? What do you say for this? How can you get it out? So you work on that particular deficit. Do not say he's autistic. Right? Thank you so much. Sir, any comments? He's my boss.
So, Madam was my colleague in Nilofar Hospital, Child Psychiatry Department. Madam is an excellent speaker with very good knowledge. Unfortunately, she resigned from a government job. That is a still deficit we are feeling since 3 years or 4 years. 2014, since 8 years, we are feeling the deficit. Of course, Madam is working in a private sector. So, I think you have experienced her teaching skills just now. It's the flow of knowledge. I think this topic requires at least minimum 1 hour. It's not possible to cover in 20 minutes. It is a punishment for them to finish in 20 minutes.
I just hope I got the concept of it.
Yeah. It's a really mediating learning experience. It's a very good concept. Even first time also I am listening and learning from her. I think most of you are psychologists. You might be knowing better than me as a psychiatrist because you might have depth of psychological knowledge and all these things. Even the advances also you must be learning. So, madam, just you tell that you can utilize this mediated learning experience in any age group or any condition. But so, what about the average intelligence, below average intelligence, subnormal intelligence, mild mental retardation? Anybody?
That's what labeling is not a concept. What is the child?
No.
What is the child?
So the person should have a normal intelligence to receive the concepts. How can a person with a below average intelligence receive the concept?
That is where the mediator has to go to the child's level or the person's level to make the child understand. Teacher should adapt.
Okay, that's okay. You are telling is it's very good. Is it possible to make to learn the subnormal intelligence people?
No, I'm not saying make the subnormal child a normal child.
No, okay.
So make the subnormal, wherever the child is, make the child learn one step better.
Okay.
Personal cleanliness, hygiene, probably. I'm not even saying academics.
Okay, right. Okay, not academics, you can improve.
Absolutely.
Okay.
So I think it is the imparting of the skill which is important over there.
Exactly.
And the way you impart the skill which is important.
So what is the deficit in
So
the
it is
child?
customized.
Very
Yeah, it is customized to that particular child.
Very child.
Even these things are applicable in autism everywhere, in every condition, any condition it is there.
So we only talk about cognitive deficits here. We do not talk about the diagnosis of the child.
Okay, only deficits, how to deal with the deficits. So any one of you having any questions or clarifications regarding the madam's presentation? I think the topic is not yet completed, I think. Yeah.
So you can't escape.
Actually, your learner should have the intention and the reciprocity. So, how do we establish it? Like when the first time learner comes to the mediator, the person, how do we establish it and how do we develop it?
I'm not saying giving you the answer, you're giving me the answer. How, if you are the teacher and if the child has come to you, how would you establish the intentionality or reciprocity? Just say, the child has come, is sitting in front of you, the parent has sent the child, pollution. Now, how do you know the child wants to
Turn on the mic.
The first thing is making them comfortable, approachable. Me being approachable to them,
Okay.
so that establishing the communication rapport and
How would you do that?
talking to them, talking about their favorite things, or talking about something that they can connect with
Correct.
to initiate the communication
Right.
first, and then getting into the
So you establish rapport with the child. That is step one, as all of us do. Like step one, rapport. Then how do you know the child is keen on learning, or how do you know the child is intent to learn? Next step.
the way they respond, the way they talk, the topics of their interest.
No assuming behaviors here, please. The process has to be accurate, clarity. Say, today we are here. I am here to teach you this. Are you willing to do this? Are you with me on this?
No,
Yes or no?
it is difficult to make you understand in one session.
No, it's like
Okay.
it's a very simple straight question, sir. Are you willing? I am here to teach. Are you willing to learn? And what are we here to teach? I am here to do this 1, 2, 3. Are you willing to be with me? It can be yes or no. If it's a yes, fine and well, you're happy.
What
You
if it is
continue.
no?
No, then say why no. Why is it a no? Why don't you want? Do you want to do something else? Or how else can we do this better? I am here to do this, but what do you want to do? Then see, always pull from where the child is to your side. You go there, pull the child to
We
your
just
side.
basically try to make them understand what we are there to do first.
Yes, absolutely. There has to be a clarity of the situation with the child also. Why the child is there.
But still, by the end of the conversation, if still yes or no, then how do we?
Then you have failed. You're not doing something right
Okay.
as a teacher.
The end result should be they saying yes. That's it.
Not yes, but at least pro learning, not anti learning.
Okay, thank you for your question. Thank you, madam, for your wonderful presentation. Once again, you want one more question?
I don't know. I left it in your head.
That's all.
Oh, we will have a separate 1 hour presentation later, madam. Thank you.
We should
Thank you,
have
thank you.
a small workshop on this one, not only 1 hour presentation. Should be so nice. I request Dr. Ram Subba Reddy sir to felicitate Gauri Reddy ma'am. Hey, come on, yaar, at least give a good applause. I invite Dr. Gangaram sir, retired professor in psychiatry from IMH, to felicitate Dr. Subba Reddy sir. So I hope there are too many questions in the brain. I think we can process it in the evening. Now I need a small attention from the crowd. It's my pleasure to call upon Dr. Pratima Giri ma'am onto the dais. She would be chairing the next 2 sessions. She is a developmental pediatrician at Rainbow Children's Hospital, Banjara Hills. She is trained in pediatrics from Neelofer Hospital. She has been working in the field for the past 20 years, and she worked in various countries like UK, Australia, and New Zealand. She has a special interest in children with autism spectrum disorders, ADHD, epilepsy, and in Rett syndrome. I would like to invite Dr. Alivelu ma'am, Professor of Neonatology from Neelofer Hospital, Hyderabad. So madam would be taking a talk on early warning signs of psychological problems in pediatric day-to-day practice.
So good afternoon, everybody. Greetings from Neelofer Hospital. I am actually working in the neonates day in and day out, and I'm wondering how come I'm here in front of you. I'm sure all of you must be thinking too. I think the chairperson is more qualified to talk about this than me. So, but anyway, I'll try and do as a pediatrician what I had seen day to day in the hospital and in my clinic. I'll just come out with few stories. So, besides the slide, I think I'll be talking more from my experience. So I think all of you know the definition, and I think it's just that whatever disrupts a person's ability to function in terms of mental illness. And this is again statistics which I found from one of the journals. I think we have more of illnesses in our urban cities than the rural, or probably rural are not being screened properly. And I think we need to work here in urban schools a lot more than I think the psychologist is a necessity nowadays than before. So again, warning signs, I think all of you know about this. So anything that is away from the normal, like recently you saw the news, there was this 4-year-old child who suddenly was withdrawn, and the parents were, they picked up that the child was going through some trauma at school. So the parents were so alert to pick up those small signs, I think, or probably the behavior had changed so much that they noticed. So anything persistent sadness that's lasting more than 2 weeks or more, withdrawing or avoiding social interactions, hurting oneself, or talking about death or suicide, outbursts or extreme irritability. Like here again, outburst or extreme irritability sometimes may be some illnesses as well. So depending on the age, I think all these definitions do vary in pediatrics. It's not so simple as in an adult. And out of control behavior that can be harmful. Again, this is again something that can vary from normal to very severe abnormalities. So drastic changes in mood, behavior, personality, changing habits, loss of weight, eating habits. Again, as pediatricians, we always see parents coming. A child is overweight, but the mother comes and says, my child doesn't eat anything, he refuses food. And that's our usual stories in clinics. So, but still, there is sometimes, if you see, I had a pediatrician herself, she was my student. She came with her 11-month-old daughter saying that this child stopped taking milk and, solid food suddenly. And we were wondering what was, and when I looked at that child for 11 months, the child is already 11 kgs and looks all healthy. But as a pediatrician, she definitely did notice something was abnormal. So when I just started to see, and then I just sent a random urine examination where the child had UTI. So sometimes even though the child was so healthy, the mother does pick up those signs. So we always learn to listen to the mother in our practice. So difficulty in sleeping, frequent headaches or stomach aches, of course, pain abdomen. This is something most pediatricians see now. And pain abdomen and anxiety they go hand in hand. So even though constipation is the main reason, many children do have a pain abdomen, but we've seen school fear or something, bullying at school, and then pain abdomen association a lot more than before. Difficulty in concentrating, changes in academic performances. So recently I kept hearing from the other parents. There was a 12-year-old girl. Suddenly her her marks started coming down. Her academic performances coming down, and she was more into a room alone. Then they came to know that she was giving some laced cool drinks in school, and she got onto drugs. So this is not uncommon, and this is also what we are seeing more and more. And this is from one of the affluent schools. So it's not just anywhere. So again, evaluation will include a complete medical examination. Recently, I had one 9-year-old male child brought to me by one another pediatrician because he was related to him. He tells me that the child doesn't interact. He gives a blank stare. He does not listen to in school, and his suddenly deterioration has increased than before. He's already slow, and then now it has increased. So when we saw his thyroid was normal, his growth is normal. His he had an MRI done because he had gone to several pediatricians and before coming to me. And as I routinely just asked for a hearing assessment, and he had severe hearing disability. So the impairment had caused his delay. So we need to look at all these aspects. So complete medical examination is one of that, and hearing should be must. Medical histories, history of physical trauma, emotional trauma, family history. Of course, I've seen so many of these young parents having family problems, divorces, and then the children suddenly getting withdrawn, not eating. This is not uncommon at all. and review of symptoms with and general concerns with parents. Like I told you, always listen to the mother. Timeline of child's developmental processes, academic history, interview with parents, conversation and observation of the child, standard assessment and questionnaires for the child and parents. So this is the ASQ scale. These questionnaires. These are like ages and stages. So something like, have you heard about ECD program? Early child development. So even our Telangana MCP card, that is the maternal child program card, has an ECD typed on it. So they've written a pictorial diagram like, if the child doesn't have head holding, that's a red flag sign, please come to us. So these kind of early child developmental cards also are now incorporated into our government setup. So again, I think all of you are more aware than me. So I'll just keep talking few things which I come across, which I have come across through my experiences. So again, mental retardation, we had Dr. Gauriman who talk about it. So it's not that, I think unless we know how to communicate with them, there can definitely be an improvement. And I've seen a lot of improvement when we send these children to our early intervention program. So I've seen children who had severe stiffness developing, the tone had improved. And after 2 months, when we got the same child for the examination, the improvement was dramatic in the tone and the way the child behaved. So definitely we need to see that they have better communication skills, self-care, home living and social interpersonal skills as well. So this is the definition. Mental retardation refers significantly to sub-average general intellectual functioning resulting or associated with concurrent impairments in adaptive behavior and manifested during the developmental periods. So again, developmental period, I think Dr. Pratima is an expert here. So I've just seen a mother recently. For an 18-month-old, the child went on to pick something, a toy or something, away from the line in the Nilofer hospital. She wanted the child to stand in the line, and because the child went out, she pulled the child inside the line and she's giving a nice banging. Do you think the child will understand? So do you think that was disobedience? No, it wasn't. The child's inquisitive nature. So, but this is again very important that the parents understand what is normal, what is abnormal. So I think the developmental pediatrics is another big, I think should develop more, and so probably all parents should understand. So Dr. Pratima has a big role. Again, this is something depending on the levels and the IQ and how they can be trainable, educatable. I think I won't be talking too much about this. Of course, I just wanted to talk about Down syndrome. And I had actually as a PG, when even Pratima was there with me in their emergency. So there was one duty where the child had Down syndrome and the mother was a widow and the baby also had severe anemia. So they do have a lot of physical issues because of the hypothyroidism. The child also had anemia. And by the time I could arrange for the blood, the baby went into cardiac failure and expired. The mother was so unforgiving. She was so angry at me because these children are so lovable. The parents do get a lot attached than a normal child. So because the child was so attached to the mother and the mother was so attached to it, the mother couldn't take the death of the child. And I still remember Down syndrome is something that I think is not abnormal, and these children can be trainable and they're very, very friendly. And I think since it's the commonest syndrome, we need to work on them more. And these are the learning disorders. Like just now, Dr. Gauri was talking about. Again, I think like she mentioned, these mediated learning can be for all of us. So we actually have cognitive, then affective, then the psychomotor. So the same thing for the children as well. So again, dysgraphia. All of you must have seen Tare Zameen Par. And so many of our undergraduates had been so mesmerized by that movie that all of them wanted to become psychologists. So then the motor skill disorders, again, cerebral palsy is one of those. We've seen so many of these children in Nilofer Hospital, and they are improving a lot now with all the, again, communication disorders. expressive language. Again, here the main autism. Then phonological disorders. I think we do see a lot more. I think even I have it. So, anyways, but I know a very famous neonatologist. He's overcome this with just some counseling and practice. Stuttering, again with pervasive developmental disorders. Here again, there are so many aspects to it. There's defects in the reciprocal social interaction, communication, and presence of stereotyped behaviors. So autistic Rett disorder and childhood, I won't be going into details because I hate even Dr. Lokesh Lingappa talk about it. And this is the M chart we can use in our busy practices to screen for it. There was another one of my friend from US had sent his cousin's son. He was diagnosed as having developmental delay, and he went through MRI, again the big list of investigations. So when the child was brought into my clinic, I just saw that he's not having eye contact. That was enough for me to tell him, and I sent them to Rishi. And that child had come to Nilufar. The child does have autistic behavior. Now they're going, of course, to NIMH as well, and he's improved a lot. He's now 5-year-old. He's improving, and the parents are so grateful. They thought he'll be labeled as a mental retarded for life, and now they know that he's just autistic and he's improving. So again, this was a male child. He does have average intelligence. He's not above average, but definitely his impairment has reduced. So probably this was genetic in nature because there was nothing else. This is again mirror writing. Again, this is normal for certain time of age, and then they improve on this. And Rett syndrome, you've seen the videos which Dr. Lokesh Lingappa had shown you. And I won't be going into detail because I think he's covered it. Some of these disintegrative disorders, it's called as Heller syndrome, and it is very rare. And of course, these also are then develop normally up to 3 to 4 years, and then we start to see some autistic behavior. I think we are seeing these in our clinics as well. So I think pediatricians need to get more and more aware of these syndromes. Again, I'd like to mention about whether, I don't know, all of you are seeing as well, post-COVID. So many of these children started to come to our clinic saying that they have delay in speech. They are not interacting well. And I've seen a child very typical standing towards the wall. He's not interacting. He's just towards the wall, standing there when he came into my clinic, but he's towards the wall. He's not looking at us. And what the parents tell me, he's very active on the phone. He's a pro at the video games. He knows how to search, and he's super intelligent, but he's not talking to us. So this has been a common scenario. And then we had recently, I had seen another young mother literally crying. This was her first son. He's now 14 months. He started speaking few words and then went back. She was actually a software engineer. She was in New Zealand away from her family. So she came back here, and within 6 months, I saw a lot of improvement in that child. Because here they were staying in a joint family along with the grandparents. So again, phone, social media is something that we need to consider when we are looking at the other histories. And when my parents say that they're very brilliant, but they're always on phone, I think that's where our red flag should start to. So this is again Asperger's disorder. This is that famous movie where Shah Rukh Khan was the hero. But then we've seen how they can get older and how they're autistic. They have they have near normal intelligence. So again, they have problems with social skills. I think some of these movies does teach all these syndromes. Okay. This is something where I think many of us do see this day in, day out in adults, in children. And I've seen in a very famous, he's brilliant neonatologist. Even yesterday, because of Rishi giving me this topic, I thought I diagnosed him. Because we had a LAMCON conference the other day in ESI hospital. And he's so, I know he's brilliant, one of the top neonatologists. He comes into the hall, he had sat next to me, but he was moving around. Then suddenly after 5 minutes, he gets up, goes away. Then he's coming inside again after some time. For some lectures, he's able to sit down, but for many lectures, he was getting up and going away. So I know this is not this is quite common in many of us, I guess. So, and of course, I think even I do have it. Like this was some new topic to me, and it took me so much time to sit down and read for this topic. And I'm still wondering what am I doing here, standing in front of you. So this is again very, very common, and they've written 10%, but I guess you would be better judge. Maybe we are seeing more than 10% in children, and boys definitely are 3 times more likely than girls. And especially younger children do have this. And you see parents from nursery say, the child is not sitting in the class, can you help him? But that's okay, he's a child, let him play. I think this is not at all abnormal. We expect a 3-year-old to sit down and, write sentences and saying, look at the phonetics and all those things. And now if you look at Indian schools, they are so impractical. Before 5 years, they expect the child to write a full grammatical correct sentence. I don't know where we are going. And like Dr. Gauri mentioned, I think we should look at more of the MLE than, just bookish learning. The differences with ADH is that symptoms are present over a longer period of time and happening in different settings, definitely. So this is a neurodevelopmental disorder affecting both children, and it is described as persisting or a pattern of inattention or hyperactivity, impulsivity that gets in way of daily life or typical development. So again, it can be broken down to 3 types: inattentive, hyperactive, impulsive type, and a combined type. So again, you have the diagnosis by the DSM-4. These are the criteria for these. I'm going a little fast, sorry. That's not DSM-4, sorry, Rishi. That's 5, sorry, 5. So again, it can be successfully managed. At least I'm standing in front of you. It is best treated with combination of medicine and behavior. Of course, it is like it's also when we want to do something, I think we can overcome our defect at least. Okay, feeding and eating disorders. This is something we keep seeing day in, day out. The child is otherwise normal, but not gaining weight. And of course, we see this in most of these children who are, from 2 years, around 2 years, that's terrible 2s. That's when they don't listen to the parents. They have their own mind and they don't want to eat what the mother wants them to eat. This is every mother goes through. You expect them, I have to go to the office, please start and eat, and you keep pushing the food into them, and this power struggle between the child and the mother. This is what we see day in, day out in every family. And that's where we don't realize you're not giving the choice for the child. You're not looking at his individuality. You're not looking at his appetite. You wake them, I see most parents, if the school bus comes at 8 o'clock, they wake them at 7:45. And they expect that he should eat one roti, a glass of milk before getting onto the bus. I tell them, wake them at 6 o'clock. He'll be hungry by 7 o'clock. You can feed them something by 7 and then put him on the bus by 8 o'clock. This they cannot do. Because the child sits along with the phone or the tab till 1 in the night and then he sleeps. How can we expect them to wake by 6 a.m.? Impossible. So again, pica. This is something that this is something that I've seen through my practice. I've seen group of children having pica party as well. So there were 3 or 4-year-old girls sitting down and taking out paint and removing stones and eating. So I had one child first come into my clinic, all her teeth were broken. Then her friend comes in, even her teeth are broken. So it was not one child who was experimenting by eating all this. All of them started. So there was one child who was anemic and who started this, think of having pica. And then she involved all of 3 or 4 of her friends sitting down in her apartment, having all this mud and paint and all of them with broken teeth and anemic. So I had all 4 patients because of her. Thank you. So I had to send them to the dentist, deworming, treating their anemias, follow up, and I had to send for blood tests to see their peripheral smears. I don't know how many days they were doing because their teeth were definitely deformed. So, like I told you, they eat everything: sand, insects, leaf, or pebbles. So, even adolescents can be affected by this disorder. Definitely, if there is something other than pica, I guess. So again, this is rumination disorder, but this is normal till certain age, and after that, this becomes abnormal. Okay, this is again, like I told you, picky eaters. This is one more. One of our pediatrician went to Hong Kong or somewhere to become a specialist to manage picky eaters. So this is like, there are 6 types, and I was wondering what was that in being, just picky eaters. It's just that some of them have neophobia. They're very picky about having new food. Then you have another fellow who wants only liquids. So he's called a guzzler, it seems. And so these are these 6 variants where they are, divided as why they don't want to eat. And there is one more reason: they don't want the mother to go away to office, so they don't want to eat. They keep the mother running around along with them. So these are the 6 types of picky eaters. Of course, this has to be handled. And the best advice I tell the parent is involve the child in preparing food along with you. That makes them get a little interested. And also make them sit on the table along with the family. Let them eat what they want and not what you want. Because I know they still puree their food. The child has teeth full in the mouth, but the mother thinks he cannot chew, and she purees the food down in the mixie, and that unpalatable food is expected to be eaten by a 2.5-year-old child. Impossible. So again, these tic disorders, these are all the other. Do I have time? No. Okay. Just a few more things. Enuresis is something we see, and of course, again, those so many things will, I tell them, give them the golden star. So first a normal colored star, and at the end of 1 month they get a golden star if they are dry the whole month, and then they can get an award. So not for every star, but if they develop, if they earn a golden star. So, but this does work out. Sometimes it doesn't. We do see some pathological cases as well, and just. I think I'll just talk about one more thing. Separation anxiety, of course, this is normal up to even 18 months. I didn't see any childhood schizophrenia, but I heard about it. Of course, post-traumatic stress disorders. I think all of you are busy after COVID. So many of these children losing their parents, and their counseling is definitely something that will help them. OCD. Yesterday, I was seeing a video where this 4-year-old, they are some children, we don't realize. Sometimes they cry, they throw tantrums when things are not done their way. So probably we are missing these children. We think OCD is not there in childhood, but definitely I think we are missing them. Of course, depression in children. Okay, so depression in children, I think they do outgrow of it, but I've seen where I had another family, the other child developed leukemia, the older child. So even though this child was just 9 months, female child, the other one was a male boy, 4-year-old, that child developed leukemia where the parents were very busy and they were depressed themselves. And this 9-month-old baby, I could always look at her and knew that this baby is also depressed. I never saw the baby smiling back at me or, looking at, I had some toys in my clinic, but she was never interested in those toys. So I think even probably younger children also go through this, and we don't recognize. But of course, after the child got better and the parents they went back to their normal family. Now I see the girl playing around a lot. So just one word in the last. Pediatrics is something that is, very, very unique when it comes to adults. Children grow out of it, but sometimes they can be scarred for life. And as a neonatologist now, because I'm working in neonatal unit with almost 300 neonates anytime in a unit, I realized that when the baby is having pain or away from the mother, even a small neonate who's hardly 1000 grams having a frown on the face. So and that's where I feel that, the neurodevelopment, the neurocognition, those things have to start. We have to start taking care of a neonate from that young age. So that's where I feel and I tell my pediatrician, be very, be very caring. See that when you poke them, that they don't feel too much pain, because they'll come back and hit you when they become adults. I know they'll come back and throw stones at us and break the glasses and hit us. So please handle them with care. So that's what I learned through all my neonatology experience. Thank you. So any questions, Dr. Pratima?
Thank you so much, Dr. Ademiru, for that lively talk and taking us through, it was not a bird's eye view, it was more than that. So, and it's also a bit of a challenge for me to summarize that lengthy talk, but just a couple of things I thought I will summarize. I think the large majority of you here are psychologists, is that right? All right, so the first thing was just the title of the topic, and we said psychological disorders. I mean, the same range of conditions I would discuss as behavioral neurodevelopmental disorders. So just one point I wanted to make about the terminology, that it actually professionals from different professionals manage these conditions. So it be pediatricians, developmental pediatricians, psychiatrists, psychologists, and then at the school as well, education gets involved. So we are dealing with a condition which is complex. So that was one point I wanted to make. The second thing that I wanted to mention was, in a busy pediatric practice, now we are pediatricians, for general pediatricians, they have very little time to see kids. And often with conditions like this, we do need a lot of time to assess these children, because we are observing behavior and we also rely on a lot of information. And therefore, it is important to sort of work quite collaboratively with education and other areas and get information. The third thing I wanted to say was, in as much as our diagnostic sort of entities are very helpful, because you have pathways for treatment and management, like Dr. Gauri said, that the emphasis on labeling, there has to be a balance between that and recognizing the deficits, if for want of a better word. So, and then the fourth point I wanted to make was the early childhood ECD. You said about educating families about early signs. I think it is important to incorporate these at critical points, vaccination, etc. I met somebody from education a while ago who was talking about young kids joining school, and then, a number of them not having sort of, issues with socializing and speech, etc. We do need some sort of a screener there to kind of pick these problems and quickly refer. So I think that point on ECD was very relevant. Then importance of early intervention. I think there is evidence, there is science behind this, and we know about plasticity. There's research that we identify these conditions early, and like in the previous talk, that we are able to change the trajectory of these children. All right. I also wanted to mention that in terms of sort of the attitude towards children with disability, we may see it through a medical model, but that's a child. And the example you quoted about children with Down syndrome, I think it reminds us again that we see them as human beings, as children, and not as a case of autism or as, and so just looking beyond labels. I think the other point I wanted to mention was particularly with the neonatal group of kids who are there in the neonatal unit for long periods of time, some of them, especially, 28 weekers, etc., they are separated from the mums. And you spoke about sort of responding and being sensitive to pain. I think that is a very important point, for future sort of PTSD and things like that. But also the other thing I wanted to mention was attachment with the mother, because that's a foundational thing for development. And also what more needs to come into neonatal unit to ensure.
So we do a thing called kangaroo mother care. I think all of you must have heard. So we do have a dedicated room for KMC, and even in our NICU, our mothers are allowed inside, and we encourage the mother to put the baby onto the chest and wrap together. And definitely the mother and baby will be sleeping whenever we go in and see that they are. So it definitely makes a lot of improvement in the weight gain and the way the baby starts to suck early. So KMC is one of the most cost effective, and I think it works wonder for the neuroplasticity as well, because all the senses are stimulated. The hearing, the smell, the baby does listen to the mother. So the touch, the biggest sense organ again, touch is again always stimulated. So it definitely affects the unit.
And one final point that I just wanted to mention was, over the last decade in pediatric practice, we used to see things like epilepsies, abdominal pain, chronic cough, etc. But the landscape of these referrals has been changing, and particularly over the last post-COVID time in the last 2 years, it's been a lot of behavior developmental problems. So it is something that professionals, and first of all the first responders, I think we need to have some basic knowledge about the neurodevelopmental problems, as well as how to screen them. And I think all pediatricians need to have a minimum screen for these and to be able to refer for detailed assessment. Thank you very much, Dr. Alivelo. We may have time for 1 or 2 questions.
I have a question for the audience. Whom should we refer if we see an ASD symptoms in the child or a risk factor? Come on, please, louder. Yeah, developmental pediatrician, clinical psychologist, psychiatrist, and the entire team of neurodevelopment. And I have one more thing. If the child has feeding issues, if the child is a picky eater, whom should we refer? Yes, these days speech pathologists are trained in treating children with feeding and swallowing issues. Okay, I just want that into the brains a little bit apart from ASD. And yeah, ma'am, I want. Oh, ma'am, I'm so sorry. Can you please pass on the mic?
I guess that was a fantastic talk, ma'am. And I'm a psychologist basically, and as you rightly pointed out, majority of us are from psychology background. I really appreciate the way a pediatrician looks at it and a very psychological perspective that has emerged out of your talk. That's really very valuable. Now, coming to our own perspective, when we use terms like OCD among young children, then a 9-month-old child appearing depressed and all, I think we will look at it more from a behavioral perspective, learning perspective, rather than labeling them as OCD or depression or whatsoever. Like Gauri has been pointing out a little while ago, rather than, and in continuation with Madam's remark towards the end, if we can move out of these zones of labeling at a very young age, as you know, till 18, we have to take it from a developmental psychopathology point of view. But nevertheless, something like OCD or depression in young children, I think it is the parents who have to be taken into the perspective, and a holistic perspective from a pediatric point of view, from a psychological perspective, not necessarily all clinical psychologists, but counseling psychologists, parent educators. Probably a holistic perspective is a must over here, is what I felt when I was listening.
I think you're absolutely right. So even genetics does play a role. The child I was telling you was because the mother is also known schizophrenic and she's on medication. So this male child does have those issues. So holistic view, I agree totally.
So one more thing. the whole point of organizing this conference is to decrease the boundaries between psychologists and psychiatrists, development pediatricians and pediatrics. Because I'm seeing so many cases of autism, ADHD, and SLD. It requires a multidisciplinary approach. So you can't that you have to refer there, you have to refer here, you have to do this, you have to do this. It is not like that. It has to be every part. It is a neurodevelopmental disorders presenting as a behavior problems, and there may be a genetic issue with it. So that's a medical problem presenting as a behavior problem. So definitely a doctor should be required for that, along with therapists will be running around him, and a pivotal play will be with the doctor who will be telling what can be done, what can be done. To and fro communication should be there between the therapist, all the therapists who are taking repeated assessments, and doctor will be saying what are the medical problems can be dealt, either he has core ADHD or not, all these things. So it's a multidisciplinary approach. It's not like you are referring to one point or one thing or one thing. The whole point of this conference is to decrease the gap and all those things. This I wanted to add at this point.
We are talking about multimodal therapy. That's the
So the holistic approach and multidisciplinary team is the key words. Can we take the questions in the lunch break, please?
Just one suggestion on the question. Can you hear me? I think it's very valid. I have been in the field decades, basically a child developmental psychologist, then many therapists, special educator, etc. And I have observed that even in India, now they have started prenatal diagnosis of certain disorders. And what they do is just diagnose and inform the parents and leave it up to the parents. It pains me to see that they do not advise on management and what to do about it. It will be really great if all of us together can collaborate and do something about it. It's like you have temperature, yeah, you have this much of temperature, that's it. What is to be done beyond that? That's my suggestion on the basis of many observations here.
I request Dr.
And one more, I'm sure Pratima must be knowing because I have a lot of international exposure too. Like when a baby is born, at that moment only we can make it mandatory to test the thyroid levels. We can, mandatory I'm saying, it's not mandatory for every child.
It's mandatory.
Is it mandate? So we can save the children and the country.
At Rainbow Children's Hospital, it's a mandatory procedure which they do, but as a whole, it has to come up soon. I request Dr. Pratima Giri to felicitate Dr. Alivelu ma'am. Dr. Pratima Giri will be chairing the next session too. Now I would like to invite Dr. Nitya Murthy. She is a child psychiatrist at Rainbow Children's Hospital. Her special interest lies in preventive psychiatry, early intervention, and in dealing with mother and child both. So I'm sure all of you are very hungry. So I'll try to make it. I already got a time limit. I'll try to make it quick. Yeah, overview, I'm not going to go into it. I'll directly jump into the slides. So childhood anxiety disorders, they are extremely common among children. CDC data say 9.4% among children 3 to 17 years. It varies between 10 to 20% approximately. They are classified under internalizing disorders. So that means the child deals with the problem internally rather than act it out. Okay. So these are very distressing to the child. Unlike externalizing disorders, the child goes through a lot of distress, but the parent may not be able to see the distress. So and these disorders, like why is it called internalizing disorders? Because they often present together. Anxiety and depression present together. It's very rare to find a child with only single anxiety disorder. Most often comorbid with other anxiety and other depressive disorders. So, and it's more common in female.
So why is it important to intervene early? So when a child has anxiety, there is chronic stress on the developing brain, and there is also a lot of functional impairment. The child is unable to access normative experiences that the child has to experience. For example, a child with social anxiety cannot make friendships, so does not learn social skills at a crucial age. So that is something that they will be missing out. And the course also, like these anxiety disorders tend to present acutely, like say after a stressor, but the course is usually chronic. It may go up and down, and it there is also an increased risk of developing other anxiety disorders later, or depressive disorders or other psychiatric disorders later in life. They're highly persistent. So coming to the clinical features, so one of the core feature is avoidance, avoiding either situations, places, or stimuli. There can be overt avoidance; it may be very obvious, or it can look very subtle also, like hesitation or uncertainty. A child might withdraw in new situations. There may be increased ritualized actions, as we see in children with autism, more stereotypic behavior. All these things can be seen. Anticipation of threat. This is also something that distinguishes different anxiety disorders. So, what is the expectation of a negative event that the child has? Is the child expecting something bad to happen? And that translates into worry and anxious thoughts. And physical complaints. We know that children tend to present more with physical complaints which are medically unexplained. Headache or stomach ache or vomitings, nausea, sleep difficulties. These are more often seen, and they're not specific to anxiety disorders. They could be present in other issues as well. And cardiovascular symptoms like palpitations or dizziness, these kind of things which we see, like for example in panic attack in adults, are rarely seen in young children. They may be seen in adolescents. And children who are non-verbal, they can look like behavioral symptoms like crying or clinging or aggressive behavior, tantrums. So it can present this way also. School refusal is one more thing, and even this is not specific to anxiety disorders, but a child who refuses to go to school most often, very often, it could be due to anxiety, either separation anxiety or social anxiety. So it needs to be looked into. So coming to the classificatory systems, DSM-5 and ICD-11, both are in agreement with each other almost. And DSM-5 gives some more details. It arranges the disorders in a developmental manner, like the age of onset. And the duration criteria is lesser for children. Say for adults, it is 6 months. 1 month is enough to make a diagnosis in children. And even the number of criteria is lesser in children. Like, for example, in generalized anxiety disorder, out of 6, 1 criteria is enough to make a diagnosis, whereas in adults, we need 3. So I'm not going to go into details of the clinical features, but how we need to distinguish the individual disorders. So the core belief in each of these disorders is different, and that is very important to elicit when we make a diagnosis. For example, in separation anxiety, the child refuses to separate from parents or caregivers, and doesn't like to sleep separately, doesn't like to go to somebody's place, or sometimes they may not go into another room also separately, and crying, clinging, all these things can be there. But a core belief is that they fear harm to themselves or attachment finger during separation. This is the belief. Selective mutism is when the child doesn't speak in situations like, say, in school, but in new situations, social situations. But in familiar situations, the child speaks comfortably, normally. The child may even communicate non-verbally, but doesn't speak. So where there is an expectation to speak, the child goes mute. So here we do not have an identified cognitive belief. So for the other disorders like specific phobia, the child may be afraid of animals and spiders or darkness. And here there is a fear of personal harm to themselves from the object or the situation. Next, coming to social anxiety, the child, it could be related to talking or performing in front of others. So the child fears being negatively evaluated by others. Why this is important is when we talk to a child, if we need to elicit this, is it that the child is afraid that they evaluate negatively, or is it that they think that some personal harm is going to come from that? So what is the fear will help us diagnose correctly. So panic disorder. These are seen in older children and most often in adults. So sudden unexpected fear, and they could have symptoms of physiological arousal, and they have fear of dying or going crazy. Agoraphobia is when they have fear that they cannot escape, or they cannot get help from that situation. For example, in open spaces, in crowds, marketplaces, it is most often associated with panic disorder. And generalized anxiety disorder fears about a number of events and activities on an everyday basis. Then they worry about a number of range of negative possibilities, and again, it's a fear that something bad will happen. So. DSM also gives some differentials. Okay, so we need to differentiate substance abuse, substance-induced anxiety disorder, medication-induced, or due to medical condition. So these are some things that we need to look out for when a child with anxiety disorder comes to us. No, nothing is, we need not do any tests routinely, but if we suspect something, say look for a thyroid abnormality or sugars, or look for any valvular cardiac issues, or any substance abuse in adolescence. So all these things we need to watch out for. So in children, anxieties are a part of development. So they are normative in the developmental period. Say separation anxiety or phobias, they do occur in children. Everything is not pathological. So the boundaries are not very clear. How do we differentiate? How do we make a diagnosis? So when they are excessive and persistent, when they are persisting for too long and they are severe, they cause severe distress to the child. That is when we make a diagnosis. So we should be cautious when we are diagnosing if it is in a developmentally appropriate period. So we need to be aware of when it is appropriate and when the average onset of disorders happen. So this has to be kept in mind. For example, separation anxiety is 12 to 18 months. It is normal. It happens at that time. Of course, if it is excessive, then you can make a diagnosis at any age. But the disorder, if you look on the right side, usual manifestations around 7 to 8 years. So fear of specific phobias, like fear of thunder, lightning, these happen around 2 to 3 years, but they happen a little later, early to mid childhood. Similarly, teenagers tend to have a lot of social consciousness, like what others think of them. So that is the time they also could develop social anxiety disorder. Early adolescence onwards, it is usually seen. So coming to the risk factors, why this is important is when we are actually starting therapy, we need to consider and work on some of these things. They are really important for the treatment part. So like any other childhood psychological issue, it is a multifactorial. It runs in families. Genetic heritability is predominant. And some of the factors that I would want to stress upon is the temperamental factors like behavioral inhibition. So the behavioral inhibition in early childhood has been found to be a strong risk factor in later development of anxiety disorders. So a child who is withdrawn in new situations and who is slow to warm up with new people, or the child may cling to the mother, does not smile, does not like to speak, or does not make eye contact. So these kind of features put together can increase the predisposition for anxiety later on. That is what the studies have shown. The other is negative affectivity, which is a stable tendency to experience negative emotions. So coming to parent and family risk factors, parental over control. So we've heard of tiger moms. So excessive regulation of children's activities, instructing them on how to do, what to do, how to think, and being overprotective. And this does not allow the child to develop mastery over their skills. So you're inhibiting them. So this increases risk of anxiety. And modeling of anxious behavior by parents. Parents themselves are often very anxious, and they tend to keep telling the child that oh my God, this is so dangerous, or you will go and fall somewhere. They keep alerting the child repeatedly. So this kind of modeling can also predispose the child to anxiety. And negative behaviors like being excessively critical, harsh, So the child does not develop self-esteem, and it can predispose the child to anxiety. Other life events like bullying also found a lot of correlation with anxiety disorders. So coming to the assessment, it is a combination of interview, questionnaires, diagnostic interview, and behavioral observation. Interview of patient as well as the child as well as the family, either separately or together. Children older than 8 years can be interviewed separately, and we need to be developmentally sensitive to the child. So initially establishing a rapport with the child is very important. So we need to spend time and make the child comfortable, not go straight away into asking questions about anxiety. And we can use other techniques like to elicit, for example, indirect projective means like drawing or as a part of play. And when it comes to family assessment, we need to look and see whether there are any anxiogenic traits or behaviors in parents, so which are actually maintaining factors. And as with other childhood illnesses, multiple sources of information if we can gather, and this may take more than one session. And even on observation, certain things can be picked up. So whether the child is not allowing the parents to go out of the room, the child appearing restless or sometimes hyperactive, or some kind of tremor, sweating, all these things can be picked up on an MSc. Coming to rating scales, these enhance the diagnostic accuracy. Like, in children it may be difficult to differentiate the individual disorders. So that is where the rating scales come into play. So clinically, it may be a little difficult, but it gives a more elaborate picture. And we also help, it will also help when there is discordant information. So for example, the child minimizes the symptoms, or the parents may be very anxious and they may give a lot more symptoms. So in such a case also rating scales are helpful. And we also need to decide which is the primary disorder or what has to be treated first. For example, child has depression and anxiety. So if anxiety and causes secondary depression, are you going to treat anxiety first? Or if depression is so severe that the child has no motivation to even participate in treatment, then we need to treat depression first. So what you're going to do is very important. And of course, the limitations are time and cost. We have several rating scales. Many of them are freely available online. So Spencer's Children's Anxiety Scale, Screen for Anxiety and Related Disorders, and many others. We also have scales for preschool children. Some have subscales and some overall measure the degree of anxiety. Some are specific for particular forms of anxieties also. Coming to diagnostic interviews, we have these are for determining the DSM and ICD criteria, and these are not that often used in outside of research settings, at least in India. We have KIDDI schedule, which is based on DSM-5. It gives the details about individual disorders. The ADIS, which is Anxiety Disorders Interview for Children, is also based on DSM-4 and is considered a gold standard. I'm not going to into the details of this. Coming to the management. So, is it pharmacotherapy or psychotherapy or a combination? Which is better is the question. So when we look at the guidelines, the American Academy of Child and Adolescent Psychiatry says that for mild to moderate anxiety, we prefer psychotherapy, mainly CBT. And for more severe presentations, a combination is preferred. Whereas the NICE guidelines, the UK guidelines, say that they talk only about social anxiety, and they suggest using CBT only and caution against the use of pharmacological treatment. So why this discrepancy, or this evidence is not so robust in the favor of combination? So these guidelines are based on the CAMS study, the Child and Adolescent Anxiety Multimodal Study, which initially said that combination is much better than individual treatments. But 6 years later, they did a follow-up of Camel's study. Showed that majority of these children relapsed also, and there was no superiority. I mean, they could not establish the superiority of the combination treatment over time. So in children, psychotherapy only is preferred if possible, followed by pharmacotherapy in severe cases. So CBT, I'm sure many of you are well aware, and this is just a theoretical outline. I'm not an expert on this. But it can be given in various formats, either individually, in groups, or with varying levels of parental involvement. Younger children, there's more parental involvement than adolescents. And whatever format it has been given, and whether it is children with special needs also, there was not much difference in terms of effectiveness. It was found to be equally effective. And there have been several programs that we know, and some of these programs are also adopted for children with autism by including, some techniques appropriate for them, like social stories and visual aids, etc. So, this is the Coping Cat program, which I'll briefly talk about. 16 sessions. First 8 sessions talk about psychoeducation. Second 8 sessions about exposure. We also have adaptations for younger children and adolescents also, and a program for cognitively delayed child. So the certain techniques like psychoeducation, the child is taught to recognize bodily symptoms. So, for example, the child has physical symptoms. So the physical nature of the symptoms is explained to the child, and how it is due to anxiety and it is not an illness. And those things are normalized in psychoeducation. The child is also explained the fear mnemonic, which I'll come to later. And then relaxation techniques are taught. For example, muscle tightening or deep breathing exercises, muscle relaxation, all these things are taught in relaxation. And building a coping template, this is more like our cognitive restructuring. So identifying anxious self-talk. So expecting bad things to happen, for example, and how to replace it with a more practical, coping self-talk. So next is problem-solving skills are taught to the child, wherein the therapist teaches the child not to look at the problem like a threat, but rather come up with multiple solutions. They brainstorm together, they come up with multiple solutions, and then the child goes and tries out, picks one and goes and tries it out. So contingent reinforcement. Here a reward system is established, and the child is also taught, that even partial responses can be rewarded, because these children tend to be perfectionistic. So it's not that only at the end you will get it, but even for small efforts also you're going to get rewards. Next is modeling. The therapist serves as a model. He role plays the situations, anxiety provoking situations, and how he handles it, so that the child can see. And next part is going to be exposure. The child makes a hierarchy, and mild, moderate, severe, one by one the child starts getting exposed to situations, and each step the child gains more confidence. The final stage will be child created commercial, where the child displays their skills to the parents and to the therapist. So a mnemonic like this is created so that the child can remember easily. For F is feeling frightened, E is expecting bad things to happen, and A is attitudes and actions that can help, and R is results and rewards. So this is how the program goes, wherein we have 2 parent meetings in between. So coming to the pharmacological management, SSRIs or selective serotonin reuptake inhibitors are the drugs of choice. I believe this is more for us psychiatrists, but there are very few of us here. So these are the medications of choice, and we need to know that there is no FDA approved medications for anxiety per se. We have medications which are approved for other child psychiatric conditions like depression or OCD, but not for anxiety. Nevertheless, they can still be used. And the most common ones that are preferred are sertraline, fluoxetine. And what is important to know is that with children, we need to start very low. Even test dose is also preferred, like, going really lesser than the effective dose, and then going very slowly. Like keep the same dose for 1 week or 2 weeks and then increase gradually. So this is to prevent side effects. The most common one which we see in younger children whenever we put on new medication or when we increase the dose is behavioral activation. So the child suddenly becomes restless and sleep disturbances or aggressive with early on in the treatment. So it is very important to go really slow and start low. So that is an important thing. And which drug is better? the preference is mostly based on side effects. We do not have studies saying the one is better than the other. Paroxetine is generally not preferred compared to other SSRIs. And there is also a black box warning for suicidality. That is, with these drugs, suicidal ideation can increase. Is a warning that is given, but this warning is based on studies in depression. Nevertheless, it still applies here. But when we look at all these things, it appears so scary that there are so side effects. Do we need to, really put medication? That is why there is a systematic review which compares the effectiveness of medications and any safety concerns. So it did show that overall there is a low risk for serious side effects. If we are doing it carefully, the side effects can be managed and they're not life-threatening. So that is a point that we need to take home and not be too scared if required to try. And the second category of drugs is SNRIs, but their evidence does not show that it is as effective as SSRIs. And duloxetine is the medication that was approved for the treatment of generalized anxiety disorder. So this belongs to this category. Ironically, this is the only one which is actually approved in children, but which is duloxetine. And benzodiazepines, which are given, these are not very much preferred in children. If possible, it's better to avoid because the side effect risk is more, dependence risk is more. And it is given only if there is severe anxiety and only in cases where there is rapid tranquilization. We need to control the child who is really aggressive and we need to sedate them. Only in such a cases we have to use with discretion. The other drugs, we do not have much evidence suggesting benefit. So this is just an overview of what is effective. So CBT and medications have been compared, and SSRIs and CBT have been shown to have moderate benefit. So when it comes to prevention, so what can we do? Can we intervene even before the onset of disorders? So the average age of onset is say around 11 years in these children. So studies have found that intervening in ages not in adolescence but even before is actually more helpful if we can do programs and catch them early. So there are three types of interventions. One is universal programs, which are school-based, broad-based skill-building programs. So which we can do in schools where the children, they similar to CBT, they teach certain skills like relaxation and how to manage stress, communication, problem solving. These skills are also taught. The evidence doesn't shows that the effect size for this is small, but still it is significant because these are population-based studies and they are definitely helpful. And the next one is identifying high-risk children. So selective programs, these were found to have more benefit. If we can screen and catch children who are at high risk for childhood anxiety, then that would be more beneficial is what they suggest. So this is where I would end my presentation, and I would emphasize the fact that probably early prevention is the way to go.
You all should appreciate the time management of Dr. Nitya Murthy.
And the solid hints you were dropping. Okay. Thank you, Nitya, for that very crystal clear presentation, which I thoroughly enjoyed, and I'm sure you did as well. So I think all of us approaching this problem from our respective sort of areas, we have noticed a high increase in children with anxiety. And I think the figure of 10% probably, we're probably seeing way more than 10% at the moment. I just wanted to mention, I saw a toddler, actually, she was barely 14 months old. And she was referred to my autism clinic and as query autism. And both parents are doctors, and this child was presenting with a lot of repetitive behaviors. So any toy that she would take, she would do this. She would wipe it on the cloth to and fro, and if you didn't do that, then she would have a meltdown. So in our experience, or rather, or I'm sure all of you have seen that very young children also are presenting with sort of anxiety. The second thing I kind of picked from your talk was the importance of parental factors as well. And it is again another thing where I think children kind of absorb their parental sort of emotional state and manifest it if they're vulnerable. And we see quite a lot of that. We see it in the language that the parent uses with the child as well. Then you mentioned about anxiety and depression coexisting, and I would love your explanation on why they go hand in hand and why we see the two coexist or comorbid. So that would be one of the questions I would love to hear from you, Nithya. The other thing that I wanted to just sort of mention was in terms of the neurobiology. I think there is sort of lots of sort of talk about the limbic system being involved with anxiety and how in the management of anxiety you start to sort of recruit the more cortical part and the more cerebral part of your brain. It's very interesting that with my 21-year-old son also, who experienced a bit of panic following a vaccination for during COVID. He had read up a lot of literature on the impact of the vaccine on myocarditis in the young males, and he experienced his first panic sort of reaction. But we spoke in the language of what is happening to our amygdala and hippocampus and things like that. But just wanted to mention quite a bit on the neurobiology of anxiety. So yes, and I also wanted to mention the Spence anxiety scale, which I find quite useful in screening kids with anxiety. It takes me about 10 minutes to do it, and so in my practice I find that quite helpful. So I'll just hand it over to you to kind of give your explanation on anxiety and depression, and then we can take a few questions.
It's audible now? Yeah, anxiety and depression often coexist. Actually, we see this even in adults, and many often present with both the disorders. But in adults, we are able to separate them out. In children, there is a lot of overlap in symptoms. The child with we cannot definitely it doesn't follow the diagnostic criteria. So, and they are often grouped together, and probably suggesting a common etiological basis also, and even environmental factors these are all classified under emotional disorders or neurotic conditions. So they often present together, like even biologically one predisposes the child to the other. So that would be a possible explanation. So since in children comorbidity is very high, and especially with depression, they're actually categorized together. So, but possible etiologically, that common etiological basis would be my answer.
Yeah. So we could take a couple of questions, Yoshna, if there is some time. Quickly, very quick questions.
How the approach to the anxiety and depression, especially able children, especially in case of autism?
The primary complaints will be when the social anxiety is the most common thing which we have seen. Whenever the child is taken to any situation, child will be very irritable, and he has repetitive behaviors will increase, and all they say the child may not be controlled by the parents. So, do you think it comes under anxiety or something else can play a role in that?
Frankly, it is very difficult to actually know for sure, especially in very young children with autism, like whether it is anxiety or not, because we cannot elicit cognitively, like their fears or anything could not be elicited. And what I do see from my experience is that there is increased in this ritualized stereotypic behaviors. And I've seen children being do not want to go out, they don't want to step out of the house, and they sometimes they do this repetitive touching, some repetitive actions are increased. They could be very irritable. So this is what I have seen, and I've seen good response to medication in my experience. So we have to really gather, we need to look into the family history also, see any history of anxiety or the functional analysis that we do, and ABC look for any antecedents in what situations that the child is actually becoming anxious. Probably these could provide cues as to that being anxiety or not.
I've seen most of them prescribing propranolol these days. Propranolol also they are prescribing for anxiety, and rather than prescribing SSRIs, if you have seen them prescribing propranolol before you're taking the child outside, explain them where they're taking, explain the situation before you take the child, then give them a propranolol of low dose, then you take this joint, see how the child is behaving. As trial technique, as told one, start at very low dose as a trial technique, whether it is working or not. Probably done one thing that can be done rather than starting an SSRI.
That's a very good point.
So I think we'll draw this to a close. Joshna, I think there are no more questions.
Yeah,
Thank you, Nitya.
I request you to felicitate Dr. Nitya Murthy. Just a second, ma'am. I request Dr. Padmaja to felicitate Dr. Pratima Giri. Yes, ma'am. It's time for lunch, the most awaiting break. Please assemble back soon within 30 minutes.
But his problem is way above Spence. Spence is for anxiety, but here we're dealing with a child who's talking suicide. This is way above the scales, you know. He needs a detailed saying that should be such a better of this week.
That's always jumping in that ముఖ్యంగా మీ గురించి చెప్తే సార్ ఎప్పుడు మీకు వింటాను అవును నా ఇంట్లో మీ గురించి చెప్తాను
The person would say, yes, I want to get appropriate. But this point when we are saying, okay, show me the messages that you get. No, I didn't. I'm a psychologist when it comes to it. It's very confidential. It's not confidential. We said that if he gets someone else takes the phone, then we can see. Somewhere he's getting stuck. Somewhere he's not able to choose, but he's just looking at students. Yes, if this was there, we could have, but again, he's saying, I'm just saying, I will join, I will try this. Yes, he said I was going to the hospital and I was about to be going through the way he picked up my phone. But which way?
Functional. Most of them is that it's misconception. He's doing for the sake of avoiding something or getting something separate. So what should he have at school? Because he's school already. Or he should have some specific reason which is causing the trouble. So how is this? see usually I don't think the child is trying to become a child, whether he's doing drama also, I don't think. So, don't point that it is functional. There is something. The leaders in place. There comes a child with parent. Small things. So there will be some component if the child has a problem, if the parents' family is a problem, or the studies is a problem. So all three environments we have processed. Don't say it is functional. For me, it's never functional. There is some physical stress or mental stress. If it is in the school, then for me, it's plastic problem. The school was already had told him something. The school was already saying something. Parents are fault. Or he seems of thinking something else. There is some problem which is going to be the whole school. Basically, this poses any things to our world. What he is trying to do. For that, what is getting? What is he getting? What is he getting? Attention is getting. What is he getting? He's getting attention. All of which parents are doing whatever he does. Everybody is giving. Everybody, they are giving everybody whatever he does. Everybody is giving whatever he does. Sympathy. Sympathy or attention. It's very different. Attention seeking is very normal. Children used to do attention seeking to get some gains. Gain should be there. Gain. They need something to buy a cycle, to eat this, Netflix and watch a mobile. Okay. It's not. He's trying to do the questions are not probably the right thing. We have to move towards those things he's saying that he's saying that other so don't get into that. So that is pretty bad. Never say it's functional. There will be some factor which can be which is a though it is functional, there will be a factor. So that is functional. None of the child will functionally behave. There will be some reason for doing it. So assess the environment around him, friends, relationships. So assess his daily routine, what is he doing, watching, what he likes more doing. Then the interaction, if it is psychosis, he will get affected. His daily routine will get affected. And the activities will come out. Interaction will increase. Aggressive aggression will increase. Unprovoked aggression will increase. Fearfulness will increase.
So the first session last week, we got just a one level of the shop's messages and what we was interested in voting, modeling, educating themselves. I said, if you are interested in this, I will put it as so, the situation and interest.
This may help you if you think that the person comes to to watch videos. You watch there is non-judgment. The primary thing is non-judgment. So be clear. You can't judge the child. Function. Whenever a child is with them, also like it's function. You have problems, but there is no physical problem. There is some stress which is stress can be also there are also Ask a question. You should be very smart. Ask a question if you go very smart. ये करना तो ऐसा हो सकता है करो वो भी उसके बाद ऑप्शन है सपोज क्या करते हैं उसके बाद
Even Mike is not paying attention. I invite Ms. Chitra to speak about Nayi Disha organization.
Hello. You already picked? That's great. So I'm Chitra. I am from Naidisha. Few of you know us. Few of you don't know. So we are here to introduce ourselves and our organization called Naidisha. So Naidisha is an organization. Am I audible, right? Yeah. So Naidisha is a lifelong partner for families affected by autism and other developmental disabilities. We support the caregivers. We are tech-enabled organization. During the COVID, we did a lot of workshops, webinars, lives on our virtual platforms, several virtual platforms. But now, by like last 4 5 months, we have started off with offline outreach, and that is the reason we are here to talk about Naidisha. Uh, our main three pillars are national directory, parent community, and information resources. You must be wondering what are we talking about. So I'll just give you a gist on what we do as a team of Naidisha. So national directory is basically a directory wherein we register all the professionals, all the organization that work in this field. If you are a professional and you run an organization, you are eligible to be part of our organization, and we would love to have you registered with us. So, and the next is parent community. Parent community is through which we connect parents from each other. Information resources, the third pillar, is the content that is there on our platform to empower families so that they can support and help the child to grow in a better way, to get the potential, child's true potential. So right now, our national directory has around 3,200 plus service providers listed with us. They are verified professionals. They come from diverse groups of profiles, be it a doctor, be it a therapist, be it an art teacher, to yoga teacher, to be a vocational trainer. So if you fall in any of the categories, we are the right person to be contacted. We are just outside, and my friend Nidhi is going to share the list. You can just note down your name and number. We will get back to you. And we have this verified rating and reviews of the professionals by the parents. Our parents give reviews of the professionals and the organization they visit, and they are genuine. So if a parent who is looking for a professional or an organization, they take the feedback and it helps them to reach out the right kind of a professional. The second pillar that I was talking about is parent community. We run around 27 WhatsApp group. They are basically divided on the category of diagnose and city-wise, and they are all facilitated by our parent champions. The parent champions are the ones who have been with us since the beginning, and they buddy the parents who are new, and they handle them through this journey. And we have one dedicated professional group for the professionals. They are on that. Once you register with Naidisha, you can be the part of that WhatsApp group where professionals have a lot of queries, and they discuss and they can interact with each other and build up their own network. In case of any query that comes to our helpline, we come back to the help. We come back to other professional group for help, and till now we have received a lot of help from the professional group. Right. Hope so far I am clear. Yeah. And the third pillar that empowers the families, we have around 680 artifacts now. They are all evidence based, and they are all curated content by experts from India and abroad. And they are in the forms of videos, audios, infographics, and you can visit and read them. You can download them. They are in most of them are in 3 languages: Hindi, English, and Telugu, and it is downloadable also. This is how our infographic looks. They are user friendly and engaging, available in English, Hindi, and Telugu. You can get resources from a topic of early intervention to financial planning to puberty. Anything you reach our information resources, the contents, and you will be able to read all of them. Another thing, that important thing that we do is we run a nationwide helpline support, and the contact number is 844448448996. It's on phone as well. You can make a call or you can just leave a message on a WhatsApp. And our team of professionals, of counselors, special educators, and social workers are there to support the families by providing them guidance, counseling, and mental health support. And it is free of cost, and they speak 8 different languages. So as till now, we have empowered families countrywide through our platform and other services. We have reached an ecosystem of about 80 plus partners, a thriving community of 16,500 plus families, and 270,000 people are engaged across 720 towns. So here we are to get support from all of you. If you haven't registered with us, we are just outside, and if you're interested, please give in your name and number. We would be glad to register you with us so that parents and the caregivers can reach out to you easily without any hassles to their nearest location. Thank you so much. In case of any query, we are just here. Hope to see all of them registered with us. Thank you. Thank you so much, Chitra. Can I proceed? Just trying to read the audience facial expressions. Thank you. Now I would like to invite Dr. Venkat Subbaiah sir from Adolescent Mental Hospital. He specially told me that he directly came from the hospital to the conference hall. So I would be chairing the next couple of sessions. He's working as a clinical psychologist at Eragada since long until date. Is specialized in aging psychology. He associates with Suicide Prevention Center and Disability Certifications. Now I would like to call upon Dr. Sana Varghese. She's a clinical psychologist and she's currently working with Government of Kerala. She has a lot of best paper presentations and awards to her credit. Madam, can you please come on to the stage? Should be talking about current guidelines and challenges in disability assessment and certification.
Respected Chair and all the delegates who are present here, a very warm good afternoon to one and all. It's post-lunch presentation and a bit dry too, so I would try to be crisp. Yeah. Topic is current guidelines and challenges in certification. As it's seeing the brochure itself, so many people have contacted me and started asking for so many questions. Um, so I think people will be having more questions after the presentation. So I'll just move on to my presentation. These are the guidelines, the existing guidelines. RPWD Act 2016, RPWD Act Central Rules 2017, and following that there are a couple of other gazettes also published. It's SO 76E dated 5/1/2018, Government of India. Government of India Gazette on Certification of Autism Spectrum Disorder. Government of India Gazette on Certification of Percentage of SLD. Now, what's RPWD Act? As you all know, we all are we belong to we belong to a democratic country, and the acts as the last word in many of our dissemination of services. So this is the most humanitarian act that has ever come in the field of disabilities. Prior to this, it was Persons with Disabilities Act 1995, you all know. Rights of Persons with Disabilities Act 2016 is the disability legislation passed by the Indian Parliament to fulfill its obligation to the United Nations Convention on the Rights of Persons with Disabilities, which India ratified in 2007. And the Act replaces the existing Persons with Disabilities Act of 1995. And going to the introduction, this Act lists 21 categories of conditions. Earlier, it was only very few. I think it was 7. Now it's 3 times more. So, Government of India Gazette on RPWD Act 2017 Central Rules issues the format of certification. It's not that anybody can print a certificate format and then enter the things and then get it signed by whoever wish, and all those stuff were happening all along. It's not possible these days because it's all protected with Act, and this is the front page of the Act. And coming to these points, Government of India Gazette SO 76E is the guideline of certification, where we have different sections in the Gazette, stating section 21.6 for intellectual disability, 22.5 for specific learning disability, 24 for mental illness, 25.5 for disability caused due to chronic neurological conditions, and 21 for multiple disability. And Government of India Gazette number 1621/2013, that is 2013 DD3 dated 25/4/16 had published the medical authority wide section 5 for certification of autism. So these are the guidelines that are to be stipulated while a person having disability is being certified. And Mental Health Care Act 2017 mentions clinical psychologists as a mental health professional. And coming on to the detailed presentation of section 21 of intellectual disability, 21.2 gives the definition of intellectual disability. We know it is this terminology is replaced with the earlier terminology of mental retardation. And 21.2 is screening by pediatrician, 21.3 is diagnosis, and there comes the adaptive functioning using BSMS, and IQ testing using BKT and MISIC. The psychologists who are present here would know about it. And 21.4 is disability calculation using BSMS score. It's not IQ score. Earlier, the percentage of disability it was given based on the IQ score and based on the standard deviation and the normal probability curve and all those plus minus SD and all those calculations. Though nowhere in India, clinical psychologists were a member of the board. Ideally, should have been there as per the PWD Act, because the theoretical base comes from the psychological theory of intelligence, and now it's been very clearly written in this act, so it's all replaced. And I think probably in India, it's in Kerala and in General Hospital Kottayam, the entire board is set according to this act. A government order you can see in India, I think, from General Hospital Kottayam, based on this constitutional provision. And I was a nodal officer to implement it, so that is why I'm so thorough with the practical application of the act pertaining to the profession of clinical psychology. And 21.5 is age of certification. Like if it's intellectual disability, below 5 it's GDD, and above 5 we can go for certification till 10 years. one temporary certification can be done, and at 18 years temporary permanent certification can be done. And 21.6 is the medical authority. It is very specifically written up to 18 years fall should be there. After 18 years fall should be there. It's all very specifically written. And 21.7 is validity of certificate for how many years and days and all those stuff. Now, I would just intervene here and would tell something beyond this, that now it's all UDID through online portal www.swavlamban. So we work directly to the portal, like patient apply in the I don't know in all across India whether we call it as Akshaya Center. We have this government units outside called Akshaya Center. So there people have to apply for disability certification through Swavalamban site. They'll get a printout having an enrollment number at the left corner of the print. With that, they will come to the OPD. They'll take the OP ticket. They will report to pediatrics and psychiatry, and from there, whatever referrals they give, they would complete everything, and then they will come to clinical psychology for assessment. There we do the assessments, calculate the percentage, and then we place them to the office, a medical record section for application. So they place the application in the office, they verify the details of whatever is given through the Akshaya Center and whatever is attached, and they do that verification in the online portal. And they give the application physically to us to conduct the board, noting that it's all edited. So the clerical part is over. Now comes the clinical part, where we have to work as clinicians, as a team. So we have the options, and we go working. I don't know how many of you are doing this. Maybe I have implemented it, I have done it. I have completed maybe more than 25,000 cases so far in that. Online, of course, it's very few, but physical certification, I tried a lot. Online has started very recently, so maybe only a few could be uploaded. It's government system, so one specialist will go with one computer and two specialists will be waiting for another computer, and net will not be there, and we are quite equipped to do anything with whatever kind of resources available. So that way online is not going with that speed as we used to certify. Earlier, when there were applications of 4,000 above cases, one day we sat from 7:30 in the morning till late night 1:30. It's not late night, it's again next day early morning 1:30. So this is how the team of pediatricians and psychiatrists and myself used to work in our hospital to implement and settle the crowd and issue and violence and whatever, because earlier they all used to get everything from everywhere. Now they will not get anything from anywhere. So and coming to the assessment part, which is the cumbersome part, is the tedious part, is the time consuming part. So it's very natural that the clinical psychologists get targeted. So anyway, without diluting things, we could do so much. I will show you the model how we could do it. Now moving on to section 22 of specific learning disability. These are the sections which covers the major headings as I've given. 22.1 says what exactly learning disability is, so it is definition, and 22.2 speaks about screening by teachers at the school level, and 22.3 says about diagnosis, 22.4 says about what all diagnostic tools are to be applied while certifying, and I think it is. Yeah.
Meanwhile, you can take questions.
Yeah, I'll keep touching at least. It has gone to sleep.
Diagnostic tools only enhance batteries being.
We'll come to the point. And once it's completed presentation.
Okay. Thank you. Now, 22.5 is about medical authority. 22.6 is about validity of certificate. Going to mental illness, it's 23.1 is definition, 23.2 to 23.7 process of examination, and 24 is medical authority. Now coming to disability caused due to chronic neurological conditions, 25.5 speaks about the definition, 25.2 speaks about how to calculate conditions, 25.3 conditions are to be progressive and irreversible, having sequelae. It is mentioned there. It's not that I have a seizure, so neurologist should give me a certificate. There are plenty of applications coming like that, but this is a condition applied while deciding whether to give a certificate or not. Now 25.4 speaks about shall mention name of disease, and 25.5 is about medical authority. 25.6 is about requirement and classification as per IQ assessment, and 25.7 to 25.9 same as 23.5 to 23.7 as I mentioned in mental illness. Now coming to multiple disabilities, this is 40.1 section definition, and these are the conditions that we certify in combination: blindness, low vision, leprosy cured person, hearing impairment, locomotor disability, dwarfism, intellectual disability, mental illness, autism spectrum disorder, cerebral palsy, muscular dystrophy, chronic neurological conditions, specific learning disabilities, multiple sclerosis, speech and language disability, thalassemia, hemophilia, sickle cell disease, acid attack victims, and Parkinson's disease. These are the 21 categories. Nobody should have a doubt about what all disabilities are now included, whether you will get it, we will not get it, or there should not be any. You need the slide to get photographed. This one you need. Somebody was trying to get the photograph. Yeah, okay, I'll move on to the next slide then. Okay, now 40.2 speaks about guidelines for assessment and calculations of disabilities, and 41 is medical authority. So while calculating the multiple disability, it is not A plus B is equal to C. There is a specific formula given for A, B, C, D, whatever number of, for all the 21 numbers we can add on giving the weightages and then transform it using the formula. So guidelines for evaluations and assessment of autism and procedure for certification. This is as per this the reference number 1621/2013 DD3 dated 26/4/16 Government of India Gazette. Section 3 speaks about the definition of autism, and section 4 speaks about tools for diagnosis. You know, it's incline and DISA, not CAS. And section 5 medical authority, and section 6 is validity of certificate. Now Government of India Gazette on certification of percentage of disability SLD. This was one challenge that we faced when we implemented it in 2018-19. Because at that time this gazette was not published, and we could not enter the percentage of disability in that format, for Form 7. And a lot of queries have come, and a lot of things were taken up, and finally anyway the gazette has published saying that if you find that the demands SLD battery is yielding some finding on significant finding on SLD, it goes to a benchmark disability like 40%. So it's stated if there is a diagnosis of SLD, that case must get 40% disability marked on Form 7 to assure that the client gets the rights of benchmark disability. Now, what are the challenges that we face to implement? When we sit and listen like this itself, it's a very dry subject because I'm speaking about an act in the tip of my finger, say, quoting all the sections, because these are the sections that an advocate would be asking, the judge would be asking while you sit on the court. That's it. So nothing can be diluted, nothing can be added on. So it's not our own creation, it's the act. Now, while we get into the implementation, we have a lot of restrictions, we have a lot of shortcomings, lot of things, especially in the government system. Now, we tried 4 models of implementation of RPWD Act 2016, and this is a major thing. This is change of framework from medical model to human rights model. Because in this certification model, a lot of other disability professionals have been included. Earlier, disability certification means it was only the hub of doctors. Now it is not. So while incorporating the other professionals into the system, what we see is there is a huge lack of human resource from that area in the medical system, in the government sector. So how we handle the system? To me, if I speak, like when I was trying to implement the act, I was only one person in the whole district, and the applicants were nearly 4,000, and time period was just 3 months. You can imagine to say a case is positive, it's much easier, but to say a case is negative, it is not that easier because they will go to court. If you give them a diagnosis, once they come seeking a diagnosis or a disability percentage, we give something, they'll get, and they're happy. They'll come back and they'll sue you at some other point of time that I'll tell you later. But at that point of time, you are saved, public will not assault you. But when this 4,000 come to you seeking that, saying that they have a disability, and you are sitting there as an officer saying that no, you don't have disability, definitely they are going to throw their 4,000 into 2 slippers to you. So that means 8,000 slippers plus whatever straits they have, they will expose there itself. So this is how I handled it, and it was a very good, nice experience. So that I had to had a casualty admission many times, and I had to start on with my medicines on hypertension. Now I am very settled. I am practicing my own way of doing things. So maybe I think I won't be assaulted that much for taking this decision. But I'm happy that at lifetime somebody should do something, and this is how I could do something. And the first thing that we had to do is to change this from the totally medically diagnosed and assessed and certified model to a human rights model, so that the other contributions also come into the system. And how will it happen is the next question. So for that, we have sorted out how many applications are there, and which are the specialists who are in need for the most. So the major number of applications were for learning disability certification. Naturally, it is a clinical psychologist who has to come into scene. Of course, rehabilitation psychologists can also come, but since I am the clinical psychologist who is there, I can go for clinical psychologists only. If rehabilitation psychologists are there, they can also work to come and exist in the system. Of course, you are welcome. Now, qualification of clinical psychologist has been corrected in the state, which was a very long process of 2 years. We had to fight through the court and with the government, with the chief minister, with the health secretary, negotiating so many days and nights, and then see, everything is written there in the RCA Act, but it will not happen in the government system due to so many things we know. So it is corrected, and government order was issued, and representation to government for forming panelists of clinical psychologists. It's not that I am alone going to do it. The colleagues who are sitting in the private sector, where they were used in the past by the system to get the assessment done, so that the certification was done in the government system. It was the system. Now they are there, I am here, and somewhere I have to connect with them. So I represented to the health secretary, seeking through the association that a panelist of clinical psychologists has to come to the scene, so that they do the assessment in the government system, not in their private clinic, so that we can assure our own correct procedure, and I can certify it blindly along with other medical doctors. Then they are blindly signing on the system that way. I mean, once the percentage is derivated through calculation, what is going to be there? Because diagnosis is already given by the doctor, assessment has come from this side. So it's a combined effort, and there is no point of questioning each other. So it was my responsibility to ensure that things are done in a very proper manner. So I have gone and talked to the health secretary, narrating how we function in NIMHANS OPD or the OPD of Central Institute of Psychiatry, where I am coming from. So I've been an alumni to those 2 national institutes. So whatever inputs I got from those OPDs, I have gone and talked to a health secretary and got him convinced, so that the way we function in that OPD, I have implemented the same thing in the implementation. And medical boards, including clinical psychologists as specialists for certification, was formed, so that it was assured that government won't fail, at least while implementing in at least one district. Now, I don't know whether it is going to sustain over a period of time, because every time this panelist cannot work like this. It's to implement, we did it. Now, to sustain that change, government has to put in effort, which we don't know. This is the government order that has been issued, stating the qualification of clinical psychologists. And then we have moved on to forming the board. Whatever sections I have mentioned in the previous slides, this has come into. This is in Malayalam, of course. It's a regional language. We are supposed to issue government orders in our mother tongue. So this is all about the office proceedings of the Superintendent of General Hospital, Kottayam. Quoting, at least you can see the section numbers quoted here, and the specialists who are here in each boards. Like, this is written in English. Visual is 19.4, it's ophthalmologist. Locomotor is 18.3.1, it is PMR. Then blood-related disorders 26.3, it's physician, pediatrician, orthopedician, PMR, respective specialists for visual hearing, cerebral dysfunction. it's as per that provision given in the guideline of certification. So when it comes to provisions that is pertaining to our area, mental illness is psychiatrist and clinical psychologist, and intellectual disability 21.6 is a section. It is pediatrician or pediatric neurologist for children less than 18 years, and psychiatrist or physician if age above 18 years, and clinical psychologist. Multiple disabilities is 41. Guidelines, whoever are involved in this kind of in this specialities, they can be called for. Now, specific learning disability, it is pediatrician or pediatric neurologist or clinical psychologist, special educator, bar, occupational therapist, and now after this order was issued, before that gazette was issued for percentage of disability, in that psychiatrists were also included as an option, pediatrician or pediatric neurologist or psychiatrist. So, but since we have plenty of pediatricians there and only one psychiatrist, he himself is burdened with intellectual disability and mental illness and all the other things and the treatment part, we have always gone with the implementation model itself with the pediatrician. So, these are the annexure 4 application. 5, 6, 7, 8 are the annexures given in the Act to certify. And we have certified it using a panel of 70 clinical psychologists over a longer period. These are the team who work day and night for the implementation. And we had to complete so many applications. In number of medical boards conducted are 18. 18 medical boards means we would have been certified 100 cases in a medical board sitting from early in the morning till late night. So this is how we could implement. And I'm not going to the models. It is very hectic, and I think it will be time consuming too, because in some places the specific models they ask for, but I'll come to the conclusion. I've got a hint from here also that my time is getting up. All the 4 models have a common outcome. Notice that there is a severe lack of clinical psychologists in service. Not only clinical psychologists, rehabilitation professionals as such. We had only one occupational therapist when we searched all over Kerala in service to include in the learning disability team. Speech and language pathologists, it's missing only. When psychological assessments were done, accurate certification took place, and Honorable High Court of Kerala and State Disability Commissioner has to acknowledge the existence of large number of children with borderline level of intelligence. This was a wonderful finding that we had in Kerala, and this was a big fight also that we had to face. But we didn't yield for that, because earlier they were all getting certified as SLD or as ID, and they were getting their thing done. Now that we have ruled it out, so more than 2,000, 3,000 children every year in one single district. So it's 14 districts into 2,000, 3,000 cases means that many population. Where will they go? They don't know how to even write a single sentence for the SSLC examination. So government was in a pressure, and all that pressure has been targeted onto us, but we were not ready to yield. So they have gone to court. Now, exam provisions to borderline kids were issued through these court orders, as it was giving to children with benchmark disability. This was a very major outcome of the implementation. And otherwise, to assure educational concessions, all borderline kids were certified as SLD in past certifications. This has been rectified, and now this is the OP they have filed. Filed in the with the SCPW. This is the order number. SCPWD is the State Commissioner for Persons with Disabilities, and this is the further case that they lodged against this decision in High Court. But High Court has given a decision in favor of us. The implementation was successful, but the outcome has to be handled in a different way, just by providing educational concession only to the borderline kids. Not that every rights that is being provided to the benchmark disability group to be given, like money, concession, best concession, train concession, nothing is there. Only exam concession. So this is Bibin KB versus Government of Kerala, Division Bench, interim relief by Chief Justice S. Banigumar and Justice Saji Pichali, High Court of Kerala. So now, with this I conclude my presentation. I believe you have a lot of questions. I don't know whether we have time or time permitted. I'm happy to answer, because I think this was a very big challenge that from grassroots till High Court, we had a very good journey with the NAT.
I think is a wonderful presentation, taking account of personal experiences, professional experiences, and also the law. See, like what is that things are happening in the society, and what is the laws is implementing by the government of India, state governments. See, a lot of things need to be addressed. Maybe here there are some clinical psychologists, pediatricians, and psychiatrists are here because just in Telangana also how we does that certification process. Because I know since 2009 we have done a pilot study to issuing the certificate like Sadaram. I think in Telangana and Andhra Pradesh, both the states already established certificate program in 2009. We were done a extensive pilot studies to implement smooth way. I think ma'am is in charge for a district because she knows each and every point of what the things and what is the implementation procedure or standardization of the test administration and the scoring and application. But see, in Telangana and Andhra, it was the only clinical psychologist services are available in Institute of Mental Health. Throughout Telangana, at present, the clinical psychologist is the only one that is the services are available in Institute of Mental Health. And apart from most of the institutions does not have a clinical psychologist. Still, the certifications are going on. But unless it comes to the notice of the court, things will go smooth. When the notice of the court is important. See, very recently, 20th of this month, we was done a pilot study, 21 benchmark certification program pilot study. In that, especially intellectual disability, mental illness, autism spectrum disorders, learning difficulties. These are the 4 important things comes under the category of a clinical psychologist role. There, it's a very important. You should know the familiarity about what is the definition, what are the tools supposed to be used, and how to categorize the disability percentage, and what is the format to issue the certification. Very much important. And what the panel members see. I think very clearly, Sani Varghese was taught who are the members who certifying well after assessment. It's very clear. See, in this point of time, I think Sani Varghese is having extensive real-time experiences in the certification and handling various types of mental illness or mental retardation or special learning disability cases. If you have any doubts, it's a good platform. You can ask, she can try to clarify. And later, after this, some questions may be permitted. Later, you can also talk to her in the tea break. Okay? I hope you can ask the questions.
I'm so sorry. We'll take up the questions during the tea break. Now I request Dr. Venkat Subbaiah sir to felicitate. See, post lunch.
Yeah, maybe everyone.
Processing issues.
Another topics also there. So we are here to answer for all your questions related to certification, procedure, administration, everything. Okay, don't worry.
Thank you so much, ma'am, for the wonderful presentation. I hope you'll be bombarded with questions during the break. Now, sir, you need to be chairing the next 2 sessions too, so you can have a seat comfortably on the stage. I would like to call upon Dr. G. Padmaja ma'am. She is the head and associate professor at the Center for Health Psychology, School of Medical Sciences, University of Hyderabad. She is also a deputy dean, Students Welfare at University of Hyderabad. She has more than 25 years of teaching experience and is currently doing research in psycho-oncology, geriatric health, and the women health. She is a renowned clinical and counseling psychologist across the Telugu states through the print and electronic media presentations. So today, ma'am would be covering on digital mental health interventions, a new era.
Good afternoon, everyone. I know it's a sleepy time post-lunch. Lunch was good, right? So I think I'll cover up for whatever extra time has been taken here and there from morning. Maybe I'll make my presentation pretty brief. I was asked to talk about digital mental health interventions. I would look at it as this new era, especially post-COVID. Digital mental health interventions are not really very new, but then I think, especially in the current times where we are in the post-pandemic period, the endemic post-pandemic period. So this time, I think it's much more important that we talk about digital mental health interventions. But as usual, I wouldn't directly go into the efficacy of digital mental health interventions or talking about the different mental health interventions which have been taken up by psychologists world across and other professionals as well world across. But let me first talk from the typical teacher's point of view. I would start with what is health and mental health. We all have been seeing from morning different speakers speaking about health from more often from a holistic perspective. It's a state of complete physical, mental, and social well-being, and not just the absence of disease and infirmity is something which we have already heard about. Now we talk about emotional, psychological, social well-being, and mental health. Having these components definitely has an impact upon you, how you think, the cognitive, cognitive, affective process, your behavior at large, and your experiencing aspect of it. It determines how we handle stress. Stress is the modern day demon. You ask a 2-year-old, maybe in words he or she may not be able to express what is stress, but they do manifest stress in many, many ways. Like somebody was telling today morning, we all are very skillful at making the child feel stressed by sending them to school early in the morning. Wake up, 7 o'clock, your school bus comes, play school, but school, and so on. So yes, from a 2-year-old to someone who is nearing the deathbed and who is waiting for the call from up there, I think everyone, there is no exception. If there is any lucky soul, I would like to talk to them in person and take some guidance from them. Yes, stress is something which is inevitable. And then our mental health, our health per se, with all this emotional, psychological points of view that we have been talking about, it helps us in our health. It has a large impact upon how we deal with this stress as well. So our mental and physical health are equally important components, undeniably. So, being a researcher myself, a behavioral scientist myself, and into research, and as a teacher, today I'm not going to talk about more often the application aspect as the clinical psychologists and pediatricians have been talking from morning. Probably I'll put more. Probably I'll give you a panoramic view of what the research has been talking about in terms of these DG interventions that we wish to discuss today. I'm calling it discussion, please note. So in 2017, it was shown that at least 1 in 10 people globally, that's about 10.7%, lived with a mental health disorder. Can you beat it? 10.7% across the globe. In India, more than 14% of the total population, according to Kanwal's study, about 14% of the total population reported to suffer from a variety of mental disorders, and of course, the females, adult, older females. Understandably, I see smiles all over. Well, yes, understandably. In India, the contribution of mental illnesses to total disease burden doubled. It became twofold between 1990 and 2017, and all of you in this modern era very much know how and what have been responsible. Like Gauri has been saying, what, where, why, how, when. All these we know. We have the answers, it's just that we don't acknowledge. Some of these include severe disorders, of course. When it comes to children, we have heard about several disorders right from morning. I will not go into the details anymore. I'm no clinical psychologist. I'm a counseling psychologist. I'm a health psychologist. Bipolar disorders, schizophrenia. Depression and anxiety disorders are supposed to be most prevalent among, again, female adult population. Now, digital mental health technologies, applications, website platforms, all these have brought a sea change. Now, I have this argument on many forums. We always say social media is bad. Influence of social media is bad. is bad? Is bad? Not always. Precisely. Being in a profession related to mental health and services related to mental health, I guess we should also see the other side of the coin. How social media platforms, how digital technology has also helped us, especially during the most tough time of the pandemic. During this period, I think it is the digital platform which helped us at large, be it in terms of our teaching, be it in terms of mental health interventions, be it in terms of the medical interventions for that matter. We had medicine, we had whatever. By phone, by online counseling, online medication, and several of us might have on one occasion or the other consulted one doctor or the other online. No services were stopped that way. Pandemic did not stop certain services where you cannot see them physically, you were able to visit them virtually. Well, digital platform did help us. So, well, applications and digital platforms have changed the way we interact with each other. Yes, we did have this digital network, the electronic services, or the so-called demon called internet, an all-pervasive mechanism which people have been heavily, especially those from the compared to the younger generation, those of us, people like us and our previous generations, they have been cursing, they have been criticizing, they have been talking about, not in a very positive way. Now, digital technologies have become more and more powerful, most powerful during this pandemic time, and as the most useful tool in the present day. Today, as we come out of this pandemic situation and in anticipation of one more pandemic, probably, we don't know, we can never say. At this point in time, we are much more confident than what we were in 2020 because we know that things can be reachable, if not physically, directly, maybe virtually. So, well, in India, there's a rapid growth of rates of internet and social media usage, and an estimated 90% of mobile phone use. I think we are one of the largest markets. And smart generation, smartphones, and the younger generations compared to you people are smarter. Somebody was talking about giving a small phone to a child. Today morning, I think Alvelu madam has been talking about it. Giving a small phone to the child and the child getting glued. A 9-month-old child, 1-year-old child. If you have to eat, phone. If you have to sit at a place, mommy has to work, phone. Don't disturb daddy, he's working from home, phone. So, those colors, those screen and whatever, I think we are conditioning them to getting used to that screen. The present generation especially. So, well, 90% of the mobile usage, phone use, and more than 225 million smartphone subscribers. I'm sure some of you have not one number but two numbers. Am I right? Yeah? One private, known to only few. However, statistics also report there's a lot of gap in access to connectivity and possession of smartphones. That's what we teachers have been banging our head about. We were to take classes online, and then our students are distributed across the country, some in the remote corners, no connectivity, low connectivity, zero connectivity, or cutting, here and there signals. I don't know whether it is staged or whether it is true, but sometimes it may be staged, but not always, right? There have been places where we know. So what we had to do is we had to use asynchronous modes in order to connect to them. It did happen. As teachers, we were experienced. Otherwise, if the student doesn't get, for example, the necessary information that he or she has to get when all the others are getting, that itself will create some problem, isn't it? As psychologists, as teachers, we all know about it. So, well, in rural areas, in semi-urban areas, in those remote areas where signaling and problem with network connections has been true, so, well, coming back to mental health once again, psychological disorders such as depressive disorders, anxiety disorders, insomnia they are the most often treated problems using the digital forms of treatment, and one of the best applied digital technology interventions, or DTI if I have to use the short form, has been, somebody has been talking about today morning about CBT.
In fact, the internet delivered CBT. That was supposed to be one of the greatest, highly successful forms of therapy. This has been used for quite some time. Today, we are talking because in the context of pandemic, we are talking about digital platforms. But even otherwise, there have been occasions where sitting in Hyderabad, somebody would get counseling, would be able to reach out to someone in Delhi, in Patna, in Australia, in America, somewhere else. And I do have, being myself a counseling psychologist who is into some services, just service, social service. I and people like me and Swati who have been into social service, we have experienced phone calls which go into the US time and their convenience and all, where we went online and we have answered. We have been talking to them. We have been counseling them. It's not new. It's not new. Not during pandemic. Much prior to that, we have been doing that. Digital platforms have been helpful. Not today. We used to go either through chat or through our WhatsApp today, or through a certain other Google Chat and other forums earlier. So a meta-analysis of 29 Swedish studies, including 2,866 patients treated with this ICBT that I have been talking about for anxiety disorders, depression, and other disorders, revealed 65.6% of all patients have improved. High success rate has been reported. And with 1/3, of course, achieving remission. This was a 2019 study. Please note, pre-pandemic. On the same lines, the application of artificial intelligence has, however, we have to be careful about the ethical and legal implications. We cannot totally trust the online platform for everything. There are certain ethical limitations when it comes to serving your clients on completely online platform. Well, COVID-19 pandemic has highlighted the requirement for new technologies, innovative technologies. Even those senior doctors, very senior doctors who have never been tech savvy earlier, who believed in writing their prescription, holding the pulse of the patient and directly talking, even if it is for a limited 2-minute talanostunda kind of questions, just those questions, even they went on digital platform. They used the online services, even they went online. And I know several doctors, both from here and other states and countries as well, who were available. Of course, it's a costly matter, no doubt, but then it means a lot of care and concern and service to the humanity. The pandemic brought to light major challenges for the delivery of mental health care services, especially due to lockdown and social distancing. In-person services have been affected. It was almost impossible. While the regular emergency services themselves have been a big question mark, and you know the deaths which were caused because of lack of availability of transport and resources, etc. during pandemic, especially during the first wave of pandemic, second wave as well. So, however, later on, as the time progressed, there was an improvement in mental health services as well as regular health services, thanks to digital platforms. And of course, telehealth, I think this is when the telehealth has become extremely useful tool, utilized very well, and people had to switch on to telehealth instead of in-person contact. There are several challenges, no doubt about it. Several challenges. You definitely cannot diagnose a patient by talking by phone or just by an internet contact. Studies reported that 33% of mental health care professionals preferred voice calls to video conferencing because they lacked confidence in how to use telehealth technologies with patients. And the main barriers that are faced for telehealth included creating digital health literacy, patient and clinicians' willingness to adopt to digital tools, workflow. There was a case that I was also into telecounseling, and I was associated with certain helplines, tele-helplines, and of course online services. So I did come across one student of mine who had called, who was a neighbor of a old lady, very old lady, about 80-year-old lady, who was alone in her village, remained alone because though her son was staying
not very far away. He couldn't come to see her, though it was just a 40-50 kilometer distance. The son could not come to see her, visit her, or stay with her. So this lady was not used to those mobile phones or smartphones or whatsoever. All that she would do was go to a neighbor's house and pick up the regular landline and say, "Beta, how are you?" and things like that. Em naina itlunnau. This was how she used to talk. But then, in case of some necessity, but that was not really satisfying to her. And it is somebody else's house. So this is when the younger generation like you pitched in. So this girl who was staying close to her, she somehow caught hold of the mobile phone of the phone number of the son, and she used her smartphone to make a online call, WhatsApp call, made her talk to the son, and this lady was crying uncontrollably. She was sobbing uncontrollably because the more she saw her son, the more she was worried. She was worried. She was actually worried that something had already happened to him, hence he is not coming. She was not able to understand these explanations about lockdown, inability to come out, and although she thought something happened, Corona champesindi aynani, Corona hospital lo jechindi aynani. That's why he is not coming and talking to me. This was it. So these smartphones, they are not used to it. She's not even used to a small, ordinary, tiny phone where you just press the number. She's not used to it. Imagine. And I'm not just mentioning about an 80-year-old. There are several people in the rural households who really, per force they had to learn. Of course, there were good Samaritans everywhere who did help them, like I just said. So, yeah. So there are certain, So there was one survey which was conducted in 2020 across 64 Indian cities. It was titled Feel COVID. One third of 1,106 participants faced significant psychological impact, according to a study. So it's not that any one of us has been an exception of the psychological impact. Majority of us had to face it some way or the other. It's just that there was a difference in coping with the stress that pandemic has created. A number of other internet-based surveys have been conducted between March and May 2020, which also showed high rates of anxiety and depression among general population across. There is no specific age group for this. Not just the older generation, not just the younger generation. I'll come to adolescent and child health shortly. The psychosocial consequences of COVID-19 pandemic were alarming. During COVID-19 pandemic, there are some studies which I am reporting over here. The mental health issues as reported in across countries, Chinese, Japanese, Italian, American, Turkish, Indian, Spanish, Greek, and Singaporean populations demonstrated a total prevalence of 32.6 anxiety symptoms, 27.6% depression, 30.3% insomnia, 16.7% PTSD symptoms. Out of the total sample that they have, I'm sorry, I didn't put the total sample over there. Nevertheless, there is a percentage which I have given. This was in 2021. It has been indicated that compared to adults, this pandemic may continue to have increased long-term adverse consequences on children and adolescents. This brings us to the issue of children and adolescents. I think Dr. Swati will be talking more about children, so let me focus a little more on adolescents. Older adolescents and youth are anxious regarding several. If I stop, if my time doesn't permit, otherwise, as a teacher and as a trainer, I would rather ask, many of you are adolescents, tell me what are the problems that you have faced. You would come up with at least a few of whatever I have listed out there, according to studies, and more. So these are not uncommon. You were so uncertain, the adolescents were so uncertain about their future. The typical term which was used, the ridiculous term which was used at that point in time, Corona batch. We will be branded as Corona batch, ma'am. Many students have said this to me. It was out of their own uncertainty. It was about and let me tell you now, as a teacher who is about 25 years, more than 25 years of experience, Dr. Jyotsna was saying that I have. So over so many, more than 2 decades of experience in teaching, I can see that today, after 2 years of Corona, after 2 years of being away from the offline classes, it's becoming increasingly difficult. If it has become increasingly difficult, even after one semester, I still see
problems of adjustment to offline classes among the young students. You got so very used to that online classes. Online classes, initially you were very bitter about them. What online classes? How can it be equivalent to offline classes? Now, why offline classes? Why don't you take online classes? Ma'am, can it still be online? These are the questions that. So, I mean, either ways, conditioning. You got conditioned to it. Now, reconditioning, deconditioning, all these. We teachers are at a tough phase. So, older adolescents and youth are anxious regarding cancellation of examinations, conducting of examinations, then exchange programs, academic events around that time. Many people ask me, many of my students ask me, why ma'am, for the past 2 years, why no program at all? Then I said, now I'm going to overcompensate you. There is going to be a conference today and tomorrow. And there is one more conference that we at University of Hyderabad, we are going to have an international conference on November 10th and 11th. So I'm going to overcompensate for that. So such are the problems. So various aspects like loss of family, how many neighbors, how many relatives, how many cousins, how many people around in the world, related to us, unrelated to us, have suffered. Loss of family member, at least one member. Job loss, social constraints, uncertainty about so many things in life, fear about the future, they all led to various mental health issues. So many who thought they are very secure and safe, steady with their job, have their jobs became again a question mark. So several studies have shown that, studies are listed. It's been reported that most common psychosocial and behavioral problems among children and adolescents in pandemic were inattention, clinginess during pandemic, distraction, fear of asking questions about pandemic. Now let me tell you what the experience is. It's no study. It's a direct experience. The narrations that we get from several teachers. Even today in schools, the teachers are facing the same kind of problem. Inattention. Students, the children are not ready to sit in the classes for a long time. As it is, holding their attention for 40 minutes, 50 minutes is a Herculean task. For us at higher education level, when it is a problem, why not the school? School teachers are complaining about it. School teachers are complaining, even we for that matter. We see there is a lot of there are a lot of problems related to social relationships. Breaking of relationships, making of new relationships, not being able to get along with friends anymore, not being able to stay in the same hostel room, which was okay earlier, 2 years back. Now they face a problem. Initially, when pandemic started, for a few days, we psychologists kept telling people, now this is the time that you're going to have your family united once again, your family time, best time, all those, very high level talk we had. Now today, I think this is the time where maximum number of family conflicts have been reported. All those who are otherwise okay, too much of proximity, too much of being together, I think that is where I think even today, till today, I keep getting at least 2 phone calls. I'm sure Swati agrees with me. Being in the media and both of us being in the media and television shows and so many things where people know us and somehow get our phone numbers, we'll get at least 2 phone calls a day. Venkat Subbai garu, you also agree with me, I'm sure, right? So, various mental health issues reported that most common psychological problems are all these. The disease and containment measures like social distancing, school closure, isolation have negatively impacted the mental health and well-being of children and adolescents. And let me tell you that social distancing has become a psychological distance with people. Now, reacceptance. Still we are getting used to that reacceptance of the fact that we have to get along with people, that, being together with people, coming back to the social relationships and so on and so forth. Anxiety, depression, disturbances in sleep and appetite. Yeah, someone was talking about too much exposure to screen time. Why not? Even when you have offline classes and full-time, supposed to be quote-unquote full-time classes, you still have a lot of time for screen. And now when you are doing nothing, and very often when we take online classes, it's a common experience. Any more teachers who would agree with me, I hope you will all agree with me. On the screen, several icons will be there. 20, 25 icons will be there. You call out some name and you ask a question. No answer, silence. Strategic silence. Or there will be one person who will take the responsibility for the entire class. Whosoever you ask, answer will come only from that person.
Internet connectivity. Ma'am, audio is not there. After some 10 minutes or so, you get a chat message. Meanwhile, WhatsApp message will go to that person. Ma'am is asking you a question, right? So, we have passed through that phase too. We were students too once upon a time. So, we know what happens on the other side. So, anxiety, depression, disturbances in sleep. Like someone was saying, even a child, it's difficult for a child to wake up at 7 o'clock. Why? Till 1 o'clock the parents, the significant others in the family, they have their screen time. So, why not the child? Caution me 5 minutes in advance. So, digital mental health initiatives in India during pandemic. Some information collected on this. There is what is called this EMANAS, Karnataka Mental Health Care Management System, where they delivered mental health services across their state, the government of Karnataka. They have launched an online portal called EMANAS. Someone was talking about it today. And Muskarayega India, and India Will Smile, it means, is a telecounseling initiative by Uttar Pradesh with UNICEF and Dr. Venkat Subbiah has been talking about one tele-helpline that they have launched, right? I think your director has been talking about tele-helpline that they have launched. Then systematic medical appraisal, referral and treatment, which is the acronym used was SMART Mental Health Project. Many such initiatives have been taken. Then there is this a project using technology-enabled electronic decision supporting system, EDSS, was used. I'm talking about a particular field study which talked about the provision of such a support system. Mental health services were provided by primary healthcare workers via 12 villages in West Godavari in Andhra Pradesh, very much a Telugu state. The intervention was found to be effective in enhancing the participants' understanding about common mental disorders, and the digital tools were explored to improve mental health, including telepsychiatry, teleconsultation, mental health apps and games, and others, all digital apps and processes, and many more. And most of them have been found to be successful. Now, coming to the adolescents and web-based interventions, I guess to adolescents, web-based interventions should be the most effective because it's very close to you. It's reachable to you. It's very close to you, and you're all tech savvy. Most of you are tech savvy. You get an access on your little tiny thing in your hand, which fits into your hand. It's easy for you. There is anonymity. There is easy accessibility, reachability, and at the same time, you get the services that you want. So they have been pretty successful. Web-based interventions have been successful in young adolescents, and when a study was done related to this, when some survey has been conducted, they ranged it from neutral to helpful. Some of them said such services, okay, that's all right, neutral. Most of them also found them helpful. So there was a systematic narrative review which reported that young people's perception of helpfulness of web-based resources ranged across the studies from 80% of participants in the study indicating that speaking out on web has helped. 40% reported in another study that web-based resources had helped a little. 59% in a third study that web-based resources did not make things better or worse, neutral. Young participants commonly reported wanting a way to check in and reflect on how that they have been feeling. Now, we ourselves in our university have started one tele-counseling or web-based online counseling platform. We have encouraged one of the online counseling services to offer their services. So within these 3-4 months that we have started it, what we have seen was in the first session that they have, they're quite enthusiastic. They do participate. But then by the time it comes to the follow-up, that is second session or whatsoever, they're not so very enthusiastic. Whereas when it comes to direct counseling, we have two regular counselors. I mean, two counselors who are available throughout the day during working hours in our university. We have a counseling unit over here. And when it comes to direct counseling, any number of follow-ups, they do come. Whereas when it comes to web-based online services, they do not see the importance of it as much as they do offline. However, it has been helpful. Several of them have use them. Then, in addition to that, yes, web-based interventions have been helping people with chronic illnesses, several chronic illnesses, especially the pediatric and juvenile patients who have several illnesses as well as their caregivers. I'm sure you all are aware that especially when there is a pediatric patient who has, be it a cancer or any cardiac problem or whatever, any illness of a child, definitely the caregivers are highly stressed, especially when there is a chronic illness or a terminal illness. Caregivers are the silent sufferers. They suffer a lot. So a lot of my research is related to caregiver stress as well. So even among them, web-based interventions have been helpful. Now that Jyotsna is indicating to me that I have to close, I'll very quickly close it. Talking about the barriers, yes, there are barriers, and I have already mentioned it through my as I was talking. There are several barriers in digital interventions as well. So my conclusion is, yes, is there a way ahead? Is there a way of combining the digital interventions with normal day offline direct person-to-person interventions? Yes, there is a way. Like we were talking about today morning, a multi-model approach, a multidisciplinary approach, a health team consisting of not just a medical doctor, but other professionals who are equally necessary and helpful, be it physiotherapists, be it social workers, be it clinical psychologists, being health psychologists, being counseling psychologists, be it physiotherapists, nutritionists, whatsoever. Bringing them together as a health team. I think that is where an integrative approach is a must. And digital platforms can be very helpful in that. Probably in a particular physical setup, you may not be able to bring them together. But on a virtual setup, being able to get in touch one after the other or together with quite a few of them through online platform is not impossible. Telemental health assessment and interventions has been talked about already. A coordinated and innovative mental health care delivery with the current practices and collaborative networks. And no service is complete, be it medical, non-medical, without the concern, care, and compassion. Topping it with human compassion, empathy, concern, care is what is required, whether it is online or it is offline. Thank you.
I think after post-lunch, something, the gurus always teach us, with the underground, the facts and truth of the fundamental procedures. Today, Padma ma'am is trying to see that the complete root level problems of what is the services are going on at present, post-COVID, during the COVID. And this is a great initiation that teachers talks truth. See, that from various speeches, what we can understand, lot of speakers talk about the fact, but the teachers talks about truth. Let's understand from truth and fact what is the difference it is. Maybe after tea break we can see. Maybe now inviting another speaker to introduce the speaker.
Firstly, I think you should felicitate ma'am.
Okay.
A big round of applause, please. I request the audience to be on your feet. I request the chairperson to introduce the next speaker.
Something which is actually sitting on the stage, seeing the psychology, the great people like, Padmaja ma'am and Swati ma'am, I know since 2007, how they are connected to the teaching and services. They teach us wonderfully. I think there are a lot of students are here, maybe directly or indirectly there are people are seeing us. The way they teach us, very, very root level, and like how they teach and try and make the people in the productive in the society. I think I know Swati ma'am since 2007 indirectly. But 2010, I think 9 and 10, I met her once in AV college. How humbly she is. I thought about she is a student of AV college. Later I know that she is Swati ma'am. Later I was seeing her in Usmania College and university as a faculty. Since then, so many services, so many research papers, so much of guidance, and so much of practical knowledge about the psychology. People teach you theoretical subject knowledge, but there are some few people are going to teach you practical knowledge. Swati ma'am is one of them, teaching a practical knowledge and supporting the student in light of the various scope of psychology. I invite Swati ma'am to present a presentation today, the mental health in children post-pandemic. We welcome her for a great lecture.
Good evening to everyone. I think being the last speaker of the day is always a tough job, and generally I do get that. Because from morning, I think almost every speaker has been mentioning in some context or the other all the symptoms and the impact of the pandemic on different age groups. So I think my job would also be very easy. I can just focus on very briefly, and as already cautioned by the organizers, I think scientific sessions have to be started or something like that. Yeah. So quickly, I'll try to have a brief presentation on it. I just want to know how many of you are practicing in schools, because when I looked at the topics in the abstract book, some of you are working as the school counselors, right? So can I see any school psychologists here? No? Okay. So what was your observation? Like suppose if the school-going children are there at your home or in your neighborhood, what was the observation that you had made, whether scientifically or just casual observations? Any specific things other than what we have already discussed? Okay, before going to this, from the Department of Psychology, we did a small survey during the pandemic, that is once the online classes have started, how the school teachers and how the school children between 10 to 15-year-old children, how they were responding to it. So whatever Dr. Padmasha ma'am has already mentioned, there were certain issues. Initially, they were not adapting to it, and later on, as students, they used to take the advantage of the online screening, online classes, not being completely engaged. Apart from academic issues that were affected during the pandemic, what were the psychological and behavioral changes that we have seen? So, in a nutshell, I'll just present that, and then we see what can be done. Dr. Padmasha ma'am has already expressed it out. In case if one more pandemic has to be experienced, I think by then we should already be prepared with these kind of the experiences, especially keeping in view how we have to bring into the intact like the mental health of the children. So let us see that quickly. So you all know both about the physical health and the mental health, especially during the pandemic, everyone has become very cautious about taking care of the physical fitness. But at the same time, as a blessing in disguise, I think people started thinking about the importance of the mental health at some point of the time during the pandemic. And you know that if the physical health and mental health are going together, only then we can see the developmental milestones of the children. They are perfect, or they would be almost like reaching on a correct time, accurate time. So when we say the complete holistic health is when the children are equipped with, only then we can expect the children to perform well in the academics or related to the social development or the personality development. So here when we say well-being, it is not just about whether they're absent from any kind of a psychological illness, but it is also about how they're able to adapt to the new situations, how they adapt to the crisis, how quickly they are coping with the things, and how they are able to come back to the normalcy. And if that is lacking, obviously the mental health would be affected in some form or the other in terms of anxiety, stress, depression, or feeling loneliness, all such kind of the symptoms of poor mental health which we can see. And automatically that would affect the way the children are growing, the way they are reaching their milestones, whether they are accomplishing the tasks as per the
developmental milestones are not. So the research says almost across the globe, more than 330 million youngsters were confined at home. And that has created almost a drastic impact on their development of the social skills and then their adaptation or being more rigid to the situations and all these things. And apart from that, even the parents as adults, when they were experiencing this uncertainty, when they were have to accept the new challenges, lack of maturity or lack of accessibility to adjust to the situations, that has created an impact. That is, the parenting part also has created the impact on the mental health of the children. So here, like in a 2020 survey conducted in India, around 1,000 patients across the different corners of the country, 71% of the parents said the pandemic had definitely affected their child, and 69% said it was the worst thing that happened to their own child. That is like not going to the school, not going to the playground. And because of the conflicts, as we have seen, like among the adults at home being together, how that faulty environmental home setup has created the impact on the children. So all these things, I'm not going to the detail. Like the grief, uncertainty, isolation, the social distancing, how they have missed their peer groups, and the sedentary lifestyle, not going anywhere, not even to the playground, and then getting up late, not sticking to the school sessions also, online sessions at their proper time. So all these things have really created further behavioral problems and the emotional problems in high school children. The suicidal ideation, you know about the importance of adolescence, the transition phase, what kind of changes it would bring. And during the pandemic, it has created more of the negative toll on the children, on the adolescent children. They are unable to express, most of them unable to share their experiences, and most of them suffered with levels of high levels of depression, and some of them expressed the suicidal ideation because of the fear that has triggered after watching the number of events around that were happening or reading in the newspapers. And especially children from very vulnerable social groups or children already who were at risk of physical illness and psychological illness, they were the most percentage who got affected. And if you divide the children into two different groups between 5 to 10-year-old, irritability was there because confined to the four walls due to the lockdown and other aspects. And for everything, when the parents were saying no, whether to eat something or whether to go out, that was like converted into the aggressiveness and clinginess, nightmares, then school avoidance. In the sense, this is after the pandemic. Most of them, I think you might have experienced in your own homes, they were very reluctant to go to the school. It was little difficult, like even now, to really adapt to the situations. And poor concentration because the kind of the works that they were given during the online sessions were not really demanding kind of a thing. So now when they have come back to the new normal situations, when they have to adapt to the routine kind of a thing, it was not an easy job for the children and also for the teachers as well as for the parents. And when it comes to 10 to 19-year-old children, that is early adolescent group and middle adolescent group, hyperactivity was more found, frigidity was increasing, agitation already adolescent phase itself will be triggering in certain cases, but agitation has been found to be more after the pandemic, increased conflicts because like for everything they want at their own pace, which is not possible once they come back to the normal situations. Then physical complaints, this could be because again all these 2 years due to the sedentary lifestyles. Then delinquent behavior in order to avoid certain things, in order to deal with certain stresses because of their association with the peer group, the wrong peer group, the delinquency has been increasing, and poor concentration was always a constant factor and that has triggered more. So how we have to now, as children, as parents, as teachers, as psychologists, what is that we can do? Can we really help these people who were getting affected with these kind of the issues? So probably if you're working in schools or if you're trying to talk to the parents, if they're coming up with the children who are affected with these kind of the behavioral problems, how we have to enable them to adjust to the new normal. Now we are speaking about the new normal because still we are not into the normalcy. And people are also speaking about the next normal. I don't know how many of you heard the concept next normal. So let us not think about the next normal, but if it is, we are in the phase of adapting to the new normal situations. So to help the people, to help especially the parents, the teachers, the school management, we can focus on 3 R's. One is resilience. Definitely, like there are certain setbacks in the children or with the parents or with the teachers in handling the students and the situations, but how we can revive those skills, how we can make them adapt to the present situation. Then recovery, like what are the programs that we can do to gain the concentration, to gain the attention of the children to the normal academic subjects and also make them deviate from the online screen and then come back to the classroom situations. And what are the different ways of adjusting them, readjusting them to the family environment and the school environment. So this probably we can conduct certain awareness programs and orientation programs at the school level to the teachers, to the parents, and also to the high school children. That is, in one way we can stretch a hand and then help them out to handle their crisis. So resilience is most important thing. We all know that just because we fail in certain things, it's not like we don't rise up. So let us, even if we had fallen down, even if there are setbacks in the lives of the people or with the school children, let us like stretch a hand and see like how they can be helped out to come back to their original state. So once we develop these resilience skills right from the childhood, like what they have seen, what they have undergone, giving them the scope to express their feelings, their emotions, and then making them understand to accept the situations. And when we are giving the time to express their whatever their version, obviously, like we can see that there will be an improvement in the mental aspects, the emotional expression, and the behavioral flexibility will be improved once we develop the resilience skills. And resilience can also be developed once we make the children, especially very small children and the adolescent group, to understand like why they have to feel gratitude. Okay, there was complete darkness during the pandemic. Many things were affecting. We have seen number of people around how they got affected. All this also created the fear in the children who could express, who could not express. So like making them understand the feelings of gratitude, like who helped them out, who could take care of them, or how they could survive those situations. So this is one way of developing a positive skill and positive orientation. Then self-compassion and compassion to the others. These things are missing in our daily routine because parents are attached to the technology, the digital technology, the social platforms. Even the children are following the parents. We cannot blame the children. So if parents are adapted to a particular habitual pattern, we cannot expect the children to be different from the parents. So how we need to develop the compassion towards the people and also the self-compassion. Unfortunately, one thing is what I observed, I'm sorry to say if I can hurt the feelings of you, having pets is good. Showing the love and affection towards the pets is good or towards the animals. But the same kind of the compassion which we are showing to the pets or the animals, we are not showing it towards our own fellow human beings. So how we can inculcate in the children and in the adolescents about understanding others, loving themselves. So this has to be imparted. Then similarly, acceptance. Every child is not unique. Every child is unique. Every child is not equal. So what are their limitations? What are their strengths? How they can grow within their own limitations, accepting both the positive and the negatives of them. Then making them understand the meaning of the life. Generally, we feel like meaning of the life we can think only about in the old age, but it is not so. The positive psychologist says we have to make the child understand the meaning of the life. Once they understand the importance of the life, automatically they go on the positive direction. Then forgiveness. Is it so easy to forgive others, especially who hurt us or who did some harm to us? Definitely not. But definitely it is not an impossible thing. So forgiveness and gratitude, which are part of our culture, unfortunately we are ignoring those behavioral aspects. Whereas in the Western cultures, they celebrate a day for it, gratitude day, forgiveness day. But it is not necessary in the Indian context if we can imbibe those kind of the skills right from the childhood. And once you develop the resilience, automatically, physically they can take care of themselves, they can be well physically fit, and then emotionally also they can understand how they can manage their emotions, under which situations they are losing the emotions, they are lacking the control of their emotions, or why a person is behaving in an outrageous way, how we should be empathetic towards the other individual. So the resilience will also contribute to this kind of the development of other kind of the aspects. Apart from this, even the mental and the spiritual wellness. Then the question here is now, as parents or as society or as professionals, even as school management, we are taking care of economic capital. We try to provide everything by investing the economic capital, provide the basic infrastructure that is needed, whether at home or in the school. And also we try to pool the human capital, like take the best expertise, bring in the teachers and then impart the teaching, whatever is. But are we investing the social capital and the psychological capital in the children for their well-being? So what is the social capital? Unless like we interact, we give them the opportunity to interact with the people in the reality, not in the virtual platforms. Only then they can develop the communication skills. Only then they can understand the importance of the emotions, or how the emotions are playing the role of playing the havoc in the life of the individuals. All this they can understand only in the actual realistic situations. But thanks to the technology, if we are using it in a positive way, that is better thing, better results will be there. But unfortunately, we are using it in a more of the negative aspects. As a result, we are seeing the children now with lack of communication skills, not understanding how to express, how to share their emotions. So this social capital is missing. So let us invest in the social capital, take the children to the people, make them interact. It is not that in the absence of the playground, like generally parents complain, like there is no playground or there is no space in the apartments. But something has to be done where the children can come together, even if it is an indoor game. The teamwork, the team playing, all these things can be taken care of. Then what is the role of the psychological capital? So every child wants to be a hero in their life. But how we can make them the hero? And is it only the responsibility of the teacher, or only the psychologist or the school counselor who is taking care of the children can do that? But parents also should be part of it. So when we inculcate these 4 principles in the child, that is how they have to maintain the hope, even in times of adversity, how they have to analyze the situations, how they have to learn the lessons from the failure, automatically the hope, the level of hope will be increased through small activities and exercises, which even the parents can learn from the counselors, and they can spend time with the child. Then developing the efficiency in each child, identifying what are their uniqueness, what in which area they are very good at, and then like make them perform well, giving them the opportunity to deliver those things, so the efficiency levels will be improved. Then already we spoke about resilience. Resilience is a must, not just at the individual level or at the old age, but right from the childhood. If we can develop, as adults we can be a better person, and even in the old age probably we can reduce the psychological issues which the people are suffering with. Then optimism. Optimism is like how you have it, what sort of an orientation you have towards the people, towards the life, towards yourself. Always like the world will be with both good and bad things, people will be with in both the categories, but how the child has to understand this. It's not like based on some bitter experiences the child can conclude like people are bad or this is not the world to live in. So developing an optimistic attitude towards the life and towards the people, these 4 principles, if you can inculcate in the child, definitely the child can become a hero in his or her own life. Then what are the other things that we can do at the school level? So most of the things generally we speak about giving certain training programs to the teachers or the parents. But keeping in view the pandemic situations or any such kind of the crisis which may bound to occur even in the future, at least like every teacher should be knowing certain basic counseling skills, like how to be empathetic towards the child. If child is not performing well, if the child's academic engagement is not really up to the mark, instead of just labeling them like the child is dull or the child is not interested, generally in the parent-child meeting we see this, right? Immediately the teachers will be bombarded with, parents will be bombarded with the negative remarks of the child. But here, what is the reason behind it? Why the child is not able to perform? Whether the problems related to the child or related to the family, that is whatever is happening at home, or due to the social situations. So this kind of an understanding, showing empathy towards the child, has to be taught to the teachers also, along with the parents. And especially in India, very few school psychologists we see them. And unfortunately, in most of the school psychologists are used as substitute teachers. And whose fault it is? Why you are allowing them to be employed as a substitute teacher when your role is a school psychologist? So how you have to be assertive once you are designated there as a school psychologist? What is that you can do? What are the prevention programs that you can conduct? What are the life skills program that you can create for the whole lot of the students in order to enable them to deal with the situations? And teaching the teachers also, like that is training the teachers and in certain psychological principles, like how we can make them be positive or develop resilience skills in the children. So through small activities, we are not giving here any intervention programs or teaching any intervention programs to the teacher, but how they can be part of all this. So that like certain problems, mental health related problems, not disorders, it's like certain symptoms or certain situations which affect the mental health can be minimized. Then psychoeducation can also be given to the elder children in the school, that is high school children. We can create certain groups, making them like identify, like if someone in the classroom is not interacting, extremely introvert, or have extreme levels of loneliness, exhibiting the loneliness, how they have to talk to the child, how they have to bring to the notice of the teacher or the management or the school psychologist. So such kind of the programs can also be planned at the school level. So it is not just one approach, a multidimensional approach involving children, parents, teachers, management, and some teachers can also be acted as mentors once they are trained. And another important training that which we can impart to the parents and the teachers is psychological first aid. I think most of you are familiar with this. We are aware of physical first aid, but the concept of psychological first aid is still not really popular in India. So what is that we can do? So immediately if we can identify that something is wrong with the child in the class or in the playground or in her interactions, what is the minimal thing that can be done by the parents or by the teachers or by the class representatives? So the training can be given with regard to this psychological first aid, where we first teach the principle of look, listen and link, 3 L's. That is like we train them to observe in a casual way, in a very routine way. If any child has any serious problem, any symptom which is looking very abnormal, so that immediately that can be referred to the concerned person. Then listening. If there is no one around, but the child is feeling very lonely, or the child is feeling in a very shattered condition, how the trained other classmate can listen to the child, whatever they are narrating. Or if it is to the teacher, how the teacher has to listen to the child without interrupting. What sort of questions, minimal questions can be asked to get more of the information about the child's emotional state. And then link it. Link it here is either if the school has a school psychologist, they can send to the school psychologist, or they can send to the referrals depending upon the appropriate situation. So this psychological first aid can be given to any of the population in the society, need not be only the parents or the students and the teachers, but whoever is interested in the well-being of the community. So psychological first aid can be planned in most of the schools, so that they look for the basic needs, they listen, they try to provide immediate comfort, then they connect it to the required professionals, so that we can protect the individual or prevent the individual from doing any kind of a harm, self-harm or harm to the others. And then by doing this, by connecting or by sending them to the referral, we are also instilling a hope that this is not just your problem, this is something like where many other people will also experience, but for everything there is a solution to it. So with this kind of a hope, they will be ready to go to the counseling and take the help. And the last but the most important concept to the well-being of the children is, definitely children do have negative emotions. Not only children, as human beings, we are emotional beings, right? Not only social beings, we are also emotional beings. But how we have to minimize the negative emotions, how we have to maximize our positive emotions. So this can also be created some kind of an awareness in the children, how they can express the negative emotions, how they can try to prolong the expression of the negative emotions, but how they can exhibit the positive emotions, and how they can be engaged with the peer group, with the teachers in the class, with the parents, that is, what sort of a quality time that they are spending in the family with the parents and also with the peer group. So by increasing the engagement of their lives, whether it is at home or in the school, that will also contribute to their well-being. Then positive relationships, once the engagement is more, positive engagement, automatically the relationships will also be improved. The distance between the parents and the children or between the siblings can be reduced. And once we make them understand the meaning of the life, not feeling bad about what they are deprived of or what the kind of the illnesses that they are suffering with, but what is that they have in their hand and how they can try to prove their uniqueness, and that leads to the accomplishment. Accomplishment here, it is not just academic accomplishment, but how emotionally sound they are, how they are able to have the control over their emotions, understand the other people, and how they are connecting to the people around, in what way they are able to contribute to the society, especially when they reach to the level of adolescent. By then, if we can develop these kind of the principles, definitely I think that will contribute to the well-being of the people, especially the school and the school children, and also the adolescent school-going children. And other than that, we have rehabilitation helplines and other things. Thank you.
I think after post-lunch, is a great research experience, references, and percentages, and there is a lot of ethical practice of clinical services. Now, mnemonics, those who are psychology background, clearly knows after actively listening of Swati ma'am's presentation, there are a lot of mnemonics is there. If you remember the mnemonics, you can serve whatever you want it. So such a great teachers, they try to taught how to practically prove our services. You know something, what you listen from two stalwarts in the psychology. They are basically teachers, then they are counselors. They may be only teachers or counselors, but they are teachers come counselors and teaching us the truth of the services. It's a great, I think, Swati ma'am given a tips for you to carry for the information what is the services can do for the especially school education psychologists, school counselors. You know something, 2009 AP government given a GO number 19, please each and every institution should have a educational counselor as the Supreme Court of India orders. I think how many people are really acting as a counselors. Ma'am, what it says that this council, they recruit as a counselor, they use for their teachers, a para teacher. See, that's not the way. But if you're strong enough having subject knowledge in the what is the role of school counselor, sure that it's going to be implemented. I think central government of India is bringing a concept of school counselors in each and every KV schools and Navodayas. I think such implementation should be taken care in our state board also. And if it happened that thing happened, sure that I think all psychologists, those who are completed postgraduate in psychology, specialization counseling psychology, sure that you have a lot of demand and services. I hope Swati ma'am's mnemonics, I think Padmaja ma'am's research evidence and practical knowledge of post-pandemic, and Dr. Sani Varghese clinical expertise certification process, I think it will help us to understand what is the present scenario of the psychology. I hope everyone enjoyed. I think stimulant you want it now.
So now I would like to please go.
Big round of applause, please. I invite Dr. Hrishikesh Giriprasad Garu to felicitate Dr. Venkata Subbaya sir. We are not clapping again. But see, the audience is at it. We can have a short tea break and please assemble back soon. Post tea break, we'll have the scientific presentations. I request all the presenters to come with your PPTs and upload it on the system.
Make sure all papers go so that we have a clarity on how many people are going to your please take it. Average going to your presentations. Okay, so shall we kind of give a little advisor? Presentation, minutes of session, right? So 7 minutes you'll put a buzzer and to kind of just say we'll come to the bullet points, so the key messages. Is that okay? So then you have a minute to do that, and then you probably have 2 minutes to take a question. Alright? So about 8 minutes we'll try. If we can have the aim of your study, the methodology, and your main results, then we can then accommodate everybody. I am you work very hard. Thank you.
మెయిల్ వస్తుందా? బేబీ మెయిల్ వస్తుందా? ఇంటర్నెట్ వస్తుందా?
questions or 8 minutes? 7 minutes of presentation. We give a buzzer. 8 minutes you need to come. 8 minutes. It's not. Stay here. If we're seen, I'm not even talking to my people. It's not like మార్నింగ్ బ్లాక్ లో ఉన్నారు ఇప్పుడు కొంచెం మినిట్ ఇచ్చారంటే డిక్టేట్ చేశారు అసలు మీరు రాసుకుంటారు నైట్ మీరు దీని గురించి చెప్పాలి తప్ప చెప్పండి ఆర్డర్ అలా ఉన్నారు అలా చేశారు కదా అలా వచ్చేసి నాకు కొంచెం మైక్ ఇస్తారు కదా అడ్వర్టైజ్ చేస్తుంది అవును సార్
హలో
We are just waiting for the others to join. Meanwhile, can we all practice a bit of breathing exercises? I hope you all been stressed out from morning, taking lot of input to the brain here and there, organizing it, questioning ourselves. Can we?
Yes.
No? Sleepy? Yes? You want to do it by sitting or by standing? Sitting. Very convenient. You're sitting from the morning. Come on, stand up. We'll do one small yoga pose. Everybody please stand up. All the youngsters. Can one of you volunteer? Can one of you volunteer? Anyone who is good at yoga? We'll do one balancing pose. I need one volunteer here. I'm wearing a sari, I can't do it. Please. I want everyone to gaze at one particular point. Just concentrate on it. Please remove your footwear. Stand comfortably. I request even the men to remove your footwear. We are going to do a tree pose. It's a balancing pose on one foot. So please stand. Maintain social distancing now. So Mr. Satya is going to volunteer us today. Ready? Mic check. Everyone alert? Satya came from Chennai to attend this conference. It's lovely to have you here. So now take a deep breath, deep inhalation, and exhale slowly and consciously. Just repeat it 2 times. One more inhalation. Inhale and exhale slowly and in a controlled way. Now gaze at a point. Fix your eye gaze at a point. Please don't close your eyes. Take your weight on one foot. You can start balancing on the right foot. Hope that would be easy. On the right foot. Yeah. Open up your hands. And take it up while inhaling air. Come on, gaze at a point. Please inhale and balance yourself. Okay? We'll do it for, can we do it for a minute? Okay, we'll try for 30 seconds. 7, 8. Don't hold on your breath. Please do a deep inhalation and exhalations. We're good to go. 10 more seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.5. Just relax.
Army is trying to kill you.
It's all good, right? So now I would like to invite our judges for today. Dr. Pratima Giri, developmental pediatrician from Rainbow Children's Hospital. And I would like to call upon Dr. Sarah B, pediatric geneticist from the Rainbow Children's Hospital onto the dais. So we have a small rules. Every presentation you need to wind up within 10 minutes. There would be a buzzer at 7th minute, which indicates that you need to come to your discussion slide, no matter where you are. And discussion will go on for 1 minute. So your presentation you need to wind up within 8 minutes. The last 2 minutes is for the question and answers. Okay? Any doubts in it? Or the presenters clear? I request all the presenters to come forward and occupy the front seats. Rishi sir, can you open that folder and keep this? There are 6 presentations today. I request all the 6 of them to come and occupy the front seats. Only 3, 4, 5. Who is the 6th person? Come fast, 6th person. I could see only 5. Perfect.
Total 6 papers and 1 case report.
So there are 7 total.
Total.
Altogether. 6 and 7?
Yeah.
Yeah. And now Pratima ma'am will take over.
Whatever is the first one, you can sit. Except for the second.
we go with our presentations. And the first one is Dual Challenge, a pilot study of challenges using masks in individuals with ID during COVID. And the author of this is Dr. Devika Kusana. And the presenter is herself, and she has done MD Psychiatry in the All India Institute of Medical Sciences and is a senior resident at IMH, Osmania Veda. So, yeah, over to you.
Thank you, ma'am. I will start. Good afternoon, one and all. I am Dr. Devika Kosana. I am here to present my research title, Dual Challenge, a pilot study of challenges using masks in individuals with intellectual disabilities during the COVID pandemic. Wearing a mask can help mitigate the spread of coronavirus. Using masks is difficult for general population also. However, individuals with intellectual disability face greater challenges in using masks due to several reasons. For example, hypersalivation, irritability, behavioral issues, unable to understand the reason for wearing masks, comorbid psychiatric and medical disorders, and sensory issues. Wearing masks outside can reduce the spread of respiratory infections, and individuals with intellectual disabilities should be taught to use the mask properly so that they can reduce the risk of infection and death, and also it helps in promoting their routine lifestyle. And some individuals with intellectual disability do not understand the reasons why people surrounding them are wearing masks, and they may be perplexed by this behavior and thus experience mood changes such as depression, anxiety, irritability, etc. They may also engage in undesirable behaviors such as pulling away the mask worn by caregivers, shouting, or throwing objects. They may display overt mask refusal since it is an unfamiliar experience which is perceived as aversive, and also wearing masks are uncomfortable. So they engage in several problematic behaviors to avoid wearing a mask. Ertel et al. In 2020 targeted this behavior in children with autism so that they can enhance the tolerance to wearing masks. This study was envisaged to study the challenges faced by children and adolescents with intellectual problems in using masks. And the objectives were to study the challenges that these individuals face when they are made to wear masks and when their family members wear masks, and also to correlate the severity of intellectual disability with the challenges they face. Methodology is a cross-sectional study which was conducted in the outpatient department of the National Institute of Empowerment for Persons with Intellectual Disabilities, Hyderabad. Sampling was purposive, and 25 children and adolescents who were diagnosed as intellectual disabilities attending NIPID were taken. The inclusion criteria being that these persons were diagnosed as intellectual disability according to DSM-5. The tests which are used at NIPID are Vineland Social Maturity Scale and Binet-Kamat test for diagnosing. And both males and females aged between 5 to 18 years were recruited when caregivers were willing to provide informed consent. The exclusion criteria being individuals having any other comorbidities such as medical or psychiatric disorders, and the caregivers who did not provide consent. Study flow. The participants who were satisfying the inclusion and exclusion criteria were recruited in this study, and socio-demographic details and the problems faced by these participants in using masks was collected using a semi-structured proforma. And statistical analysis was done using MS Excel and SPSS version 25. So descriptive analysis was done in the form of means and standard deviations and percentages, whereas Pearson correlation was done, wherein the correlation was considered significant at a value of 0.05 and highly significant at 0.01. Ethical clearance was obtained from the institute prior to starting this research, and written informed consent was taken from the participants. No risk was to participants was associated with this study. Coming to the results of the socio-demographic data, the mean age of participants was 11 years with a standard deviation of 3, and a total of 15 males and 10 females were recruited with a male-female ratio of 3:2. Approximately about 3/4 of the study population belonged to were Hindus, and they resided in urban areas. The most common socioeconomic status to which they belonged were lower middle and upper lower socioeconomic status according to the modified Kupuswamy scale. And regarding the degree of intellectual disability, most commonly 48%, that is almost half, were from mild intellectual disability, followed by moderate in 40%. None of the cases had profound intellectual disability. So the results of mask compliance, about 3/4 of these individuals were able to wear masks outdoor. However, only half of them could wear the mask correctly. And the masks were not fitting properly in about 44% of the individuals, and soiling of masks as a result of hypersalivation was seen in 16% of these individuals. So when the mask tolerance was observed, it was seen that almost 56% tolerated both the fabric mask and cloth and medical mask equally well. When the participants were made to wear masks, the most common mood change which was observed was irritability, which was found in 28% of the study population, followed by crying in 16% and anxiety in 8% of the participants. And the behavioral changes which were observed when these individuals were made to wear masks, the most common one was removing the mask, which was seen in 68%, followed by touching the mask repeatedly, which is again counterproductive to preventing the spread of infections. That touching the mask repeatedly was seen in about 52%, and 24%, that is 1/4, would throw the mask, and the rest, almost 12%, would throw things in the house or hit the shouted family members. And interestingly, none of the participants engaged in any self-destructive behaviors. So the reaction of these individuals when family members wear masks. So a great proportion, that is about 84% of the study population, would observe the family members while they were wearing masks, and 64% tried to imitate this behavior. And no significant mood changes were observed in these individuals when family members were wearing masks. The most common behavioral changes that these individuals faced when family members wore masks was that about 1/5 of them would just pull or throw the masks of family members. So this is again dangerous because it puts the family members at risk of acquiring COVID. And 12% each would touch the masks of family members repeatedly or throw it. And interestingly, again, none of them involved in any self-harm behaviors. So when correlating the severity of intellectual disability with mask compliance, significantly moderate positive correlation was observed between the degree of mental retardation and the ability to wear the mask properly, and also the number of efforts made to put on the mask. There were no significant correlation between the degree of intellectual disability and the mood changes observed when these participants were made to wear masks. But significantly negative Pearson correlation, which is moderate, was seen between the degree of intellectual disability and the problem of throwing masks. And when we compared, the correlation between the severity of mental retardation and the reaction these individuals face, there was two positive correlations, which was moderately positive with respect to observation of the family members as well as imitating this behavior of wearing masks. And moderately significant negative correlation was found between the degree of intellectual disability and behavioral issues such as shouting at parents and hitting them. So the discussion, the parents of children with developmental delays who couldn't wear masks, they reported that they had to stay at home, which was again counterproductive since it disrupted their normal routines. And in our study also 1/4 of the subjects couldn't wear masks. So this posed a challenge for the caregivers. Improper fitting of masks was an issue in about 44% of the study population, and this requires exercising caution while selecting suitable masks for these individuals. A previous study conducted by Ertel found that a few individuals preferred cloth masks over surgical masks, and our study also revealed similar results, that they preferred fabric over the surgical mask. But significant proportion tolerated both these masks equally well. The use of personal protective equipment, which also includes these face masks, were found to change the speech clarity, would impair the non-verbal communication since it covers part of the face, and would also provoke anxiety in these individuals. But interestingly, in this study, we did not find any mood changes in individuals with intellectual disability when their family members wore masks. This could be because of the small sample size, since we did this as a pilot study. And a significant proportions of these individuals tend to observe and imitate the family members while they were wearing masks. So this is positively correlated with severity of intellectual disability. But this finding is useful in teaching the individuals to wear masks through the process of modeling and others. So to conclude, 3/4 of the study population were wearing masks outdoors, but only half of them could wear it properly. And the findings of this study help gain insights into the various challenges faced by these individuals with intellectual disabilities while using masks. And the behavioral issues when family members wear masks would place these family members at a higher risk of contracting COVID infection. So this issue has to be addressed adequately. And the knowledge from this study will be useful in planning appropriate behavioral interventions to enhance the proper usage of masks. And mask tolerance training is essential, and it's required for preparedness for future pandemics, because it's likely that there might be multiple pandemics which might spread through the respiratory route. So in future also they might require to wear masks. So mask tolerance training is essential. These are my references, and thank you for your kind attention and patient listening.
Thank you, Devika, for that.
Thank you.
One very quick question, if there's any. So we'll move on to the second topic then, just
Thank you
because
so
we're
much.
towards the end of the day now. So our second presentation today.
No questions from the audience? Do we need one more yoga pose? Are we all here? What happened?
So our next presenter is Dr. Swati Pandey, a consultant psychologist at autism therapist and child development counselor. And your topic is psychosocial and behavioral changes among Indian children after COVID-19 pandemic, a systematic review. So over to you.
Yeah, thank you, ma'am. And thank you all of you who are being here and listening to me. So I'll begin my presentation. So the background of the problem is when this COVID pandemic just came over, it was not only challenging for the parents, it was a greater challenge for the students and children as well. Now this rising mental health issue concern for children have been dubbed as a second pandemic, because they must be having many challenges in terms of their academics, in terms of their behavioral behavior and psychological mental health and all that. So parents, teachers and mental health professionals has to deal with this as a second pandemic, because they are going to be a long lasting effect on them. So this population has faced a major psychological and emotional burn because of this pandemic, and they greatly struggled greatly struggled with fear and anxiety, uncertainty in terms of future, and losing one of the loved ones, seeing families conflicts, depressive symptoms, and constant worry about their future. So the aim of this study was basically to investigate the detrimental effects of this COVID pandemic on the mental health, specifically in terms of psychosocial and behavioral issue of children. So I reviewed various studies which were related to mental health aspects of children and which collected a very good data on how it has been impacted the children. And this study was mainly explored the psychosocial and behavioral changes, as I already mentioned, in Indian children. Also, the aim of the study was to ensure that there are greater challenges for the children, for the growing kids, for the newborns, for the infants and school-going children. So there has to be appropriate measure and interventions are required so that we should be having well-equipped how to deal with those challenges and how to make a prevention for the further development of this high-risk mental health issues among this population. And I will be also explaining few of the recommendations for parents, school teachers, mental health professionals, and pediatricians, how we can work together in this regard. So in the methodology, this study was purely a systematic literature review. I can say it was a kind of a rapid review, and I have collected studies basically from 2020 to 2022, and the data collection was done entirely based on the electronic databases, as you can see on the screen. EBSCOhost, ProQuest, PubMed, NCBI, Sage Open, all peer-reviewed articles were collected. Nearly 67 articles I have collected and shortlisted 40 articles for final screening. So 25 studies have been included in my this study. The participants were mainly children from 2 to 14 years. Exclusion criteria were children who were having neurodevelopmental difficulties, disabilities, or any pre-existing mental health conditions. And in this study, the population, the children were all across India, different ethnicities and socioeconomic groups were included. So there were three main findings: the psychological impact on children, the social health impact on children, and the behavioral impact. So under the psychological impact, it's been found that children are being facing with trouble focusing, lack of attention in the school, and while doing their activities at home, doing their homework and academics. And also the irritability was great and the greater level found in among the children. One study that revealed that the children also have developed a restlessness and nervousness because they have a very restricted social interaction during these 2 years. So they were very nervous and to deal and to meet with the people in the social scenario. And of course, few of the children who have been going through some traumatic experiences during this COVID time, they have developed some depressive symptoms, and post-traumatic stress disorder was also a challenging thing that has to be handled very carefully. And many children have been found showing the clinging behavior because they were infant and they went into the toddler, and so they were so much attached with the parents. They had a separation anxiety. They were not ready to leave their parents and go to school. Also, a lot of internalizing and externalizing problems were also found, which is related with the depressive symptoms, the anxiety symptoms, and the externalizing problems like antisocial behavior, substance abuse, kind of a thing. Also, new term, emotional contagion, because of the increased digital interaction. This is also kind of a new challenge that's coming before us. It's a contagious that children are too much involved. The interaction is happening on the digital platform. All kind of gaming abuse, gaming disorders are coming up. So when one children is learning something, it's passing on through one by another. So it's kind of a contagious actually. And disrupted neurodevelopment in infants, because the children who were born during this time, they didn't get the proper stimulation, the sensory stimulation among them, a proper exposure, physical activity, and so there was a delay. Can be found, maybe more studies needs to require how they are developing in terms of neurodevelopmental psychology. And social, emotional, and cognitive impairment was of course there. As they were supposed to be developed in the normal scenario, it wasn't there, and anxiety about future, of course. Now, in the social impact on children, there was a loss of quality education because there was no one-to-one interaction. Inadequate learning, the students were mainly into e-learning, online learning. So sometimes they are attending, their focus is low. They're not able to grab the things. They're not able to understand that there was no one-to-one interaction or attention on each child. Fall in educational outputs was there in terms of fine motor skills because they lost the ability to write, do the writing, and do the things with their fine motor skills. So many studies they show that the children were having great difficulty in the development of fine motor skills. And there was a wide learning gap between low and high socioeconomic group because the children who belonged to a high socioeconomic group, they were able to afford the education, doing online, they were having laptops or gadgets or everything. But in low socioeconomic group, they were struggling with the things because I've came across many clients who are saying, we have 3 children and we can't afford a laptop for each child or mobile for each child. So there was a gap in education. And oversharing of private information on social media, that was the biggest challenge because children, they have no idea how much to share, whom to share. They're just signing in the applications, in the websites, and all the private information is passing from one side to another. And of course, the social isolation stress is there. Yeah, and a gap in social touch and social network and social inequalities, neglect and distress, and of course the addiction to social media and internet, as we all know, we have been discussing from since morning. Cyberbullying and sexual exploitation is also after effect of this pandemic. In the behavioral impact on children, the reduced physical activity, screen time, more sedentary behavior, no physical activity, disrupted sleep schedule, there is no proper time of sleeping and getting up, and impaired sleep quality, that is also bringing up more challenges, more physical challenges. Changes in eating pattern, aggressive behavioral challenges and changes, and overreactivity about the situation, and reduced healthy movement behaviors. So now with the thorough research, I just came up with few recommendations for parents because these are the first the caregivers for the children. So I'm sorry, it should be increased physical activity. So the parents needs to be motivate their children to involve them in more physical activity, and there should be a healthy parenting. They should be involved with the children not only by sending to the classes, by physically present with them in the interactive play. It can be inside the premises, or if they can afford, they can go out and join their children with, in the sports or something. And there needs to be a consistent routine, and that will definitely start with the parents. If they are a role model for the children, of course the children will follow them, and they are supposed to promote healthy behavior and practicing healthy communication and mental health hygiene, being positive role models, and practicing adaptive coping skills. Role of teachers is very, very essential because now the children are going back to school and spending about 6 to 7 hours in school. So they need to educate them about not only COVID-19. It's done? Okay. So I'll just move the slide. Maybe they can just go through. Okay. And that's it. Yeah. So again, it's a collaborative approach. It's not a one-man job. So we need to come together and make a plan. Thank you.
Great presentation, Swati. I just have one question. Since this was a systematic literature review, did you use any statistics for the results?
No, not really, because it was completely systematic review. As I said, it was a rapid review because it has been done within 4 weeks. I can't say it was.
How many papers did you go through to get
for about, I can say, 70 to 80.
How did you come to the results?
Yeah, so using Prisma guideline, Prisma method.
Okay.
Yeah. Thank you. Thank you.
There's one question from the audience.
How many authors participated in the study? I mean, how many researchers were there? But for systematic review, we need at least 3. Then And also data extraction techniques won't be possible. I mean, so it won't be a systematic review in that sense.
And why I say systematic because I use the Prisma guidelines, so there is no.
For using Prisma guidelines, you have three people doing the minimum, three people doing the study. Now those things, I think you have to combine the results.
Yeah, so
It was mainly, I can say it was more about review that rather than systematic review. Yeah, I like change that. Yeah.
Systematic reviews, I think like that computer is a review presentation like this. What I really
Okay. Yeah.
Thank you.
So our next topic is impact of feeding issues on parents with ASD children, to be presented by Arpita and Kirtika, child psychologist, Daffodil CDC, Hyderabad. Over to you.
Hello, good evening everyone. I'm Grace George, psychologist from Daffodil CDC, Hyderabad. So originally this paper was prepared by two of my colleagues. Unfortunately, they are sick and couldn't make it today. So I'll be presenting it on behalf of them. So let's move on to the topic, the impact of feeding issues on parents with children having autism spectrum disorder. Eating and drinking are essential components of everyday life. Adequate nutrition and hydration need to be maintained for growth and development. When something goes wrong with any part of eating or drinking, it is called dysphagia. Problems eating and drinking in children could impact the family and create more stress for parents. Parenthood is regarded as one of the most rewarding yet challenging chapters of a person's life. The stress of being a parent, however, appears to amplify in relation to the child's level of dependence. The number of children with feeding and swallowing problems is on the rise. The prevalence of feeding problem is estimated to be between 25 to 45% in typically developing children. Children with developmental disabilities often display an array of symptoms that place a high demand on parents' time, energy, and abilities. Across the literature, parents of children with autism spectrum disorder frequently reported higher levels of anxiety. Children with ASD, that is autism spectrum disorder, are more at risk for feeding problems, putting the prevalence in this population as high as 80%. Feeding disorders can be difficult to diagnose and treat due to the unique combination of medical and behavioral influences that results in a child's food refusal. It is important to look at parenting stress of autism spectrum disorder children with feeding and swallowing issues based on the perception of their child's functional health. So, the major objectives of current study is to examine the stress levels and the impact of feeding on parents and children with autism spectrum disorder. We used feeding impact scale developed by Eston and Thayer to assess how child feeding behavior impacts parents. It has 25 items and administered in children from birth to 18 years of age. It is a 5-point rating scale ranging from strongly disagree to strongly agree. So the lower the score, lower the stress level, and higher the score will be the higher stress level. Let's have the samples used were with study group and the control group. So study group is the parents with autism spectrum disorder children, and the control group contains parents with typically developing children. Let's have a look in the inclusion criteria and exclusion criteria. We included children from 3 to 5 years of age diagnosed with autism spectrum disorder and excluded children with developmental delays, that is structural and neurological issues like seizures. Study group were recruited from Daffodil's Child Development Center through the feeding and psychology departments. Control group was taken from the parents who have given consent to participate in the study from a play group. We mailed the feeding impact scale after taking the consent from parents, and they have rated it on their individual perception. After finishing of the test, the scoring was done and the results were analyzed using the statistical analysis. The mean scores of each group were analyzed using t-test to identify the parental stress level. Now, let's take a look on the results. As you could see in the graph, stress level of the study group parents is higher when compared to the stress level of control group. In the next slide, we try to analyze 3 important factors contributing to the highest stress level in the parents. As you could see, prolonged feeding time is major contributing factor, followed by invalidating environment and negative feeding behavior. Now let's move on to the discussion part. Majority of autism spectrum disorder parents mention prolonged feeding times for their children. Negative feeding behaviors like nagging, not eating variety of foods, spitting, fussing about food are noticed in children with autism spectrum disorder children. Next is that a parent feels personally responsible for their child's nourishment. Feeding is considered as one of the most fundamental responsibility of the parents, and the inability to do so can affect on one's feelings of self-efficacy, self-confidence, and self-esteem. The children having autism spectrum disorder are facing high invalidating environment and regarding their child's feeding. Now, by concluding, let me state that stress level in parents is related to feeding is definitely high in the study group compared to the control group. Thus, psychological counseling will help to cope better with the stress and enhance overall mental health and mental well-being. Being empathetic and providing coping techniques like mindfulness, cognitive reframing might help. Providing specific plan involving related disciplines to support appropriate feeding behaviors. Various social support groups will help in distress tolerance and overcome emotional pain. The next is the limitations. The study didn't throw much light on the contributing factors and other social variables related to increased stress levels in parents with children having autism spectrum disorder. No information was provided on how the child fared in the overall program and whether any child variables affected caregiver stress levels. These are the references. So if you have any doubts regarding this, you can ask Arpita, who did all this. Thank you so much. Thank you, ma'am.
Good evening. So my introduction is going to be a little different from others because it's already the end of the day, so I hope this evokes everyone. So, a girl who dreamt all her life of being a doctor, the gold medalist of her batch, who sacrificed every party to achieve this dream of hers, was the best doctor in the next 3 years, is now a mother, a housewife who is diagnosed with clinical depression, an engineer who left his well-paying job, an artist who sacrificed her passion, a family who moved from their city of dreams, leaving behind their house for the treatment of their child. A traveler who once traveled half of the world is now traveling back and forth to hospitals with their child. A couple who once married out of love can now hardly stay for an hour under one roof without arguing about what's right for their child. That shopaholic girl from the class is now saving every penny of her earning to provide for her child's treatment. These are very few of many stories I have heard in my experience from the parents and caregivers of children with autism. So that is my topic today, the stress and parents and caregivers of children with autism. So what exactly is autism? It is a neurodevelopmental condition that poses various difficulties and stresses for the parents. The child diagnosed with autism faces difficulties in communication, social skills, and developmental skills. Assistance required for the child diagnosed with autism varies depending upon the severity of the symptoms and the prevalence of the behavioral conditions. Parents and caregivers of autism spectrum disorder have found to be having higher amounts of stress compared to other developmental disorders, as they have a constant need of maintaining equilibrium and balance for their child. Why is it so? How many of you here have closely interacted with an autistic child? Can I have hands up, please? How many of you here have closely interacted with a child diagnosed with autism? So, can we have the difference? Autism is not the identity of the child. Autism is an issue the child is diagnosed with. Child is not an autistic. The child is diagnosed with autism. Lack of awareness, lack of clear awareness is downsizing a child's identity to the issues they have instead of perceiving them as a whole person. And this is increasing stress among parents and caregivers. What are the major causes of stress? The first starts with the diagnosis. When should I get my child diagnosed? Where should I get my child diagnosed? Who is the right person to diagnose the child? What is the qualification of the person that should diagnose my child? Next, once the diagnosis is out of the way, there comes the treatment. What is the right treatment out there for my child? Where do I get it? How long do I have to get the treatment for the child? These two factors are major causes of stress. If the parent is made aware of what their child's position is, where the child is standing, do they need a midway support or a lifelong assistance or the support for the initial stages of life? It will be easier for the parent to have realistic expectations, resulting in maintaining good levels of stress. Parents live a life full of sacrifices for the children on the spectrum. I conducted a study. The aim of my study is to find the levels of stress among parents and caregivers of children with autism. The need for the study is to determine whether stress is becoming more prominent among parents and caregivers of people with autism. The hypothesis: there is a significant prevalence of stress among parents and caregivers of children with autism. The methodology I used perceived stress scale to measure the stress levels among parents. Along with this, a personalized interview was done in order to know more about the factors that influence the parent's stress. The factors such as employment status, the social status and financial status, and social support. I took a sample of 50, out of which 26 were female and 24 were male. Parents were 36 and other caregivers were 40. The main objective was to find out psychological and social factors contributing to stress among parents and children with autism, and the education and financial factors contributing to the stress among parents and children with autism, to find out factors related to future concern of child with autism. It is observed that in the parents whose child exhibit major behavior sensory issues with little to no communication have higher amounts of stress. Men who stay away from the family report moderate levels of stress. Women who still continue their job experience moderate levels of stress. Homekeepers with little to no social support are experiencing higher amounts of stress. The inclusion criteria for the study was to be a parent or a caregiver of a child with autism, should be staying in the same household as the child. The exclusion criteria: the parent or a caregiver who do not meet the child regularly. So first, to know in depth after conducting the stress scale, we conducted a personalized interview asking parents about the various contributions they have from the society and from their family members. Personal interview threw a very good light on the factors such as increasing demand that the child has as they transition from the early intervention therapy to school to teenage. So, especially the mother of teenagers on spectrum faced greater difficulties in balancing parent-child relationship. What are the reasons for the caregiver stress? The major cause is observed to be lack of insight. After years of running around the child to provide the right treatment, they have lost the touch within themselves and the acknowledgement of their feelings and emotions is lost. Increasing demand of the child with constant days have also increased the amounts of stress. Lack of awareness to set balanced goals and expectations from the child. The major tips that we can follow are divide the care. A parent alone do not have to do the tasks. Assign menial tasks to other caregivers. Set realistic goals. Talk to the treatment team and understand your child's capability. Setting realistic goals will help you manage your levels of stress. Avoid the feeling of guilt. Celebrate small and major changes and achievements of your child. Increase your social support. So the limitations of the study. Sample size is limited to the patients who attended our clinic, Let's Habilitate. In-depth analysis is not done on the individual factorial influence. Monitoring of stress levels for a brief period of time is not done. This is the scale I have used, perceived stress scale. And conclusion, autism is a condition, not an identity itself. Living in a diverse cultural world, let's try being neurodiverse by including inclusion and stop labeling a child autistic, instead calling them a child with autism. Let us all take a movement to appreciate all the caregivers who provide their best for their child. Let's start caring for the parents and caregivers. They are the great values. Thank you.
Vaishnavi, I have a question.
Yeah.
So you said in your exclusion criteria that parents are not regularly visiting their children.
Yes,
Do you have
exactly.
any set definition for that?
Yes, like a parent who is staying out of the town, who is not in the same household. We did
Have
not
you defined it?
Yes.
Not an example. Have you defined it?
Sorry?
Do you have a definition for exclusion criteria?
No, not really. Like I have an example that on basis of which we took the exclusion criteria.
Yeah.
Thank you.
Okay. Thank you.
What is the result showed in this? What are the results?
The stress levels are higher in female compared to male. And especially, as I mentioned in my results, the stress levels among women, female who left their job are higher compared to the women who are seeking the social and family support.
So in exclusion criteria, stress levels, you did not exclude any parents with past mental disorders, something like that, right?
No, I did not.
Then how can you say that they don't have any other disorder? Your
So-
example, when you started your presentation, you said that the patient who is worrying had some problems went into clinical depression.
Yes.
So probably they would have clinical depression or something like that.
No,
So
I
you
did
have
not.
ex-
I did not mention it in my exclusion criteria. But when I selected my sample of 50 parents, it was considered that any of these 50 parents did not have any kind of mental health disorders before the diagnosis of the child.
How do we know that?
I
If you don't
made
mention it.
no,
If you
it
don't
was
mention it.
yeah, I did not mention it, but that was the exclusion criteria that we followed.
It should have been mentioned because the stress level can affect in so many ways, not just the most of the exclusion criteria should be included.
Yes. And before I end, I just have a small request. For everyone who raised their hand when we said autistic child, can you please stop labeling them autistic child and calling them a child with autism, please? Thank you.
Just one more question. How did you calculate the sample size?
The
Of
sample.
50?
I took a sample of 50 because I had access to the sample of 70. And talking to few parents, a majority of them did not spend time with the child in the same household. So they were not staying with the child. So we excluded that. As I mentioned, only the caregivers who stayed in the same household as a child were taken. So after that, anyone who did not have any mental health conditions
Was a random selection.
Yes, it was a random sampling technique. Thank you.
And also, was it a qualitative or quantitative study?
Sorry?
Was it a qualitative or quantitative research?
I used both the stress scale and the personalized interviews. So I would like to majorly focus it on the qualitative side rather than the quantitative side of it.
To select a sample size, we have to use a formula for previous studies. Just can't take a sample and say that this is the
It was a random sampling technique.
sampling technique.
Yeah.
But to do a study, to select a sample, you have to pick some similar studies in the past and take an average. From that average, you have to use a formula to find out how much sample should have been taken.
Yeah, sure.
That's what usually we have to do. Otherwise, it won't give you any much results.
Sure, I'll take it into consideration next time.
Yeah,
Thank you.
because she said it was a qualitative, quantitative hybrid study, so that's why she didn't power the study yet.
Yes. Yes, that's right. Thank you so much. Thank you.
I now invite our next presenter, who's going to speak on impact of COVID-19 on autism spectrum disorder management, a therapist's perspective. By presenter is Ms. Shama Lakhani. Yeah, welcome you.
Thank you. Good evening, everyone. This was a survey which we conducted during the pandemic. We were in the pandemic for 3 months, and we did this survey. So I am a principal advisory at Cognitive Botics, wherein we are developing an app for artificial intelligence based on therapist perspective for the children in autism spectrum disorder. Introduction. In India, therapist-led intervention are a correlation in the management and the children with autism spectrum disorder. COVID-19 pandemic has disrupted several aspects of ASD management. The name of the study was to understand the impact of COVID-19 pandemic on ASD therapists from the therapist perspective. Here, what happened during the pandemic, everyone was very skeptical about going digital, wherein we always wanted the child in front of us, wherein we can do the therapies and where we can do the little exercise with them and give the little changes in them. But we were very apprehensive about going it online. Method was online survey was conducted using the Google form questionnaire format. The form was open for responses between 23rd June to 23rd July 2020. The responses were extracted in the Excel sheet and analyzed using the descriptive strategies. The questions were constructed by basic demographic data as in age, gender, professional background, the type of therapies they were giving, their experience in the field and the location, how they used to do it. Question change in day-to-day practice in pre-COVID and during the COVID era. So this were the certain questions wherein we got how the therapist used to do it before pre-COVID and after COVID. And how the therapist, the style has varied during that particular aspect. The place of the therapy were given and number of the hours of the therapy per day was described. Therapist subjective, they were on learning how the child's learning will happen, the parents' emotional and psychological well-being, because during the COVID, what happened, everyone was in the stress. So, especially for the autism kid, what exactly happened was because they were not able to express it to anyone. They always thought that the therapist is the person who will understand everything. So they were always happy to come to our therapy center to do something. But during the pandemic, what happened, they didn't get that kind of support. And parents being at home, they were not able to provide the way we as a therapist used to give them how to channelize. They do it properly, but they don't know how to do it in the systematic order. So as a therapist, what we did was we always had to have a parent counseling after each session, which was not happening. Because of that reason, it started deteriorating. And this was on the scale of 1 to 10, where 1 has no impact and 10 was a significant impact. The result states that we had 75 therapists who did the survey and 41 were actively participating. The mean of the age of the therapists were 44 years, and from that 48 were women, special educators were 49, ASD therapists were 32, and the others were 19. There were less than 5% of experienced people with 63. The result says that the actual therapy sessions where it was happening physically were 63%. Due to the pandemic, it has went to 17%. But the online therapist aspect went from 15% to 61%, which was a drastic change during the pandemic. The therapist felt the destruction had the impact on learning, 73%. When we were also taking the therapies, we were not pretty confident about how the child is responding, how much the parents are supporting the child. Because whenever there is a question asked to the child and we wait for the answer, because parents are not trained to wait for certain processing time or stuff, so what happens is they started giving the answers, due to which the anxiety level in the children started increasing. Parents' emotional and psychological well-being were affected 85%, because all of them were at home, like father, mother, grandparents, kids and everything. So parents were not having that me time or self-love at time which they were able to do it before pandemic. Only 22% of the therapists were using online or digital-based therapies before the pandemic. 51% of the therapists were not sure whether the digital-based therapies would help the parents to make the efforts. However, 65% of the therapists were willing to go digital in the future. COVID-19 pandemic has disrupted ASD therapists in India. Willing to use online and digital therapists could open up a new dimension. Reliable and effective digital therapists are the need of today. As in, we all know that Byju's is there or some other thing is there for the neurotypical. But what about our ASD kids? We don't have anything which says that yes, there is an improvement or this is the right way of doing it. So because of that, we have to create something with the support of everyone to make sure that there is something for them also. If we have to go it again for a COVID, then what will happen? We need to develop something before that so that our kids are also taken proper care of. Thank you so much. If there is any questions.
Some time for questions.
I think I was too clear about my topic, or I opened up many minds to think more questions. So thank you so much.
How did you measure children's learning disruption?
We had an Excel format wherein we took just the subjective information from the therapists who are already working with them. We didn't have any measurement because it was online. So it was more of the subjective kind of thing rather than anything officially formulated.
So in terms of impact, how many parameters did you look at within the all the factors that you looked at? So you looked at learning, you looked at...
We took in the pattern of learning and parental stress. There were only 2 parameters.
One question. How is the questionnaire framed, and also if it is subjective perception of therapists only, how valid will be the results?
So we did it subjective because it was online, so we didn't had any more scope because we were just inside the COVID and we wanted to see how the impact is happening. So we just made a regular questionnaire with the help of certain criteria. That's it. We didn't get inside it completely because we just wanted to know how much it is positively affecting or negatively affecting that.
Can we have a look at the questionnaire?
I have have to look in my mails and send you. I'll send you. Okay. Thank you.
Thank you. Then we are on to our last presentation. Is that right? Is there a case report for today?
That would be in the end.
A very good evening to everybody. Long day, but I'll keep it crisp. So, when we talk about socio-demographic factors or socio-demographic attributions, we mean different social and demographic features help us know what members of a group have in common. So, that is what we have done in the study. A sample of 850 was taken, and common factors and attributions from the sample was assessed. So, the socio-demographic correlating factors in children with autistic spectrum disorder, this is the retrospective study. The background of the study, that is autistic spectrum disorder, is a complex developmental condition involving persistent challenges with social communication, restricted interests, and repetitive behavior. While autism is considered a lifelong disorder, the degree of impairment in functioning because of these challenges varies between individuals with autism. We've heard a lot about ADHD since morning, so I'm not going to touch on that. According to the DSM-5 criteria, symptoms should start in the early developmental period because significant impairment in important areas of functioning such as social and occupational ones, and should not be better explained by other conditions such as intellectual disabilities or global developmental delays. Aim and objective of the study. The aim of this investigation is to study and evaluate different types of demographic parameters affecting on children with autism from the age of 16 months and above. The specific objectives proposed under the investigation are to identify, list, and record the baseline of different categories of demographic parameters children having with ASD, to evaluate various levels of severity of the autistic traits in children with ASD, to find out their current level of development and or intellectual abilities of the child. Coming to the inclusion criteria, children of chronological age 16 months and above were taken, children assessed and diagnosed with ASD by professionals, children assessed with developmental scales, and children whose CAR scores are above or equal to 30. And coming to the exclusion criteria, children having severe emotional and conduct disorders were excluded, children with organic brain dysfunctioning and children with genetic disorders were not taken into the study. Children having any other chronic illnesses were also excluded from the study. Coming to the materials and methods, Rainbow Hospitals, Bandara Hills was the study site. We have taken the study population of children who are coming from OPD diagnosis, and this is a retrospective study being conducted at the Department of Pediatric Neurology. And the sample size was 870 of pediatric OPD, and the age was 16 months and above. The study duration was of 1 year, that is from September 2020 to August 2021. The materials used are socio-demographic data, developmental and screening tests, childhood autism rating scale, that's CARS. Coming to the statistical methodology, data was entered in an MS Excel spreadsheet and analyzed using SPSS V21 software. Coming to the results and discussions, the first attribution that we've taken is age. Minimum age is 16 months and maximum age is 159 months, that is nearly 13 years, 3 months, in which minimum age of the males is 16 months and maximum is 1 or 3 months, as you can see in the bar box and tables. The mean and median have been derived, whereas in females the minimum is 17 months and the maximum is 159 months, and males is 16 and maximum is 1 or 3 months. Coming to the gender, gender is again a very important attribution in our study. As the pie chart shows, male is 82% and female is 18%. The next is place of birth, rural, urban, and abroad. Rural is 156, urban of 464, and abroad of 85 in males and females. Rural of 124, urban of 110, and abroad of 22, and is the total male. of 705 and male population of 156. This is currently where does the child live. You can see the comparative bar plots of urban, abroad, and rural. Type of family is another important factor, whether it is single or a joint family. Single of 637 and joint of 224 were taken. And next is father's education. Highest percentage of education is the postgraduate, which accounting to 52%, undergraduation with 41, HSC and SSC of 5 and 3% respectively. Next is the mother's education. Mother's education accounting to 51%, undergraduates 40% of post-graduation, and HSC and SSC of 6 and 4% as represented in the pie chart. Is the mother working? Another important factor while diagnosing. In the total, 22% of mothers are working and 78% of mothers are not working. Pregnancy and medication use at the time of pregnancy, and total of 861 samples, 762 are normal pregnancies according to 4%, and medication of 47% and 6%. IVF of 73 according to 51%. And next criteria is cars, and 88 above is 85% and 8 below is the 15%, as you can see in the pie chart. And age of 2 and above 2 years. Next is M chart, and mean, median, average of were taken. And IQ and DQ tests, minimum of DQ 22 and maximum of 25 were taken, and the average is 76.57. And the present study understands the current trends of various demographic characters' impact on autism spectrum disorder. It aids in understanding the correlating factors and severity of autism. And the study suggests a developmental-oriented parent training intervention treatment, and it can be useful in the factors relating to it. Thank you.
What age exactly we diagnose autism? After what age? At what age we can diagnose autism?
From the sample we've seen, what we've received is above 3 years, but an ideal age for diagnosis would be 2 years.
When you're 16 months, your age group of taken is 16 months, right?
Yes.
Then how can you say it is autism? You can suspect autism at that age, but you can't say it is autism, right?
Yeah, so risk factors. So we haven't implied or said that that is the diagnosis. We have
This
just
is the studies on autism children. And after 2 years only you can diagnose autism by using cards. If you have to use visa, then it is 3 years. MCHAT will tell you only the risk. So if you are using sample size should be more than 2 years, probably then it would be appropriate. More than 2 years children and above. 16 months, probably using this again as a study will tell you. And your scales you said only cards and ISA. Now again you lastly you said about MCHAT. So if you would have included MCHAT in the initial phase and said all these things would have been more appropriate.
Right. I will see that next time. Thank you.
Nikita, please take that inputs and modify your studies for next time, okay?
Good evening, everyone. Today I'm going to discuss about a case report. It's a case of bulimia nervosa with body dysmorphic disorder and role of social media. Myself, Dr. Jahnavi, final year PG from Kakatiya Medical College, Bangalore. So, body dysmorphic disorder, it is characterized by preoccupation with one or more perceived defects
or flaws in physical appearance, which are usually not observable or appear slight to others, which causes significant distress or impairment in functioning. Definition of eating disorder: it is characterized by persistent disturbance of eating or eating related behavior, which results in the altered consumption or absorption of food that significantly impairs physical health or psychosocial functioning. So, patients with body dysmorphic disorder and eating disorder also present with can also present with compulsive behaviors like calories counting in eating disorders, excessive use of cosmetics in body dysmorphic disorders, mirror checking, and need self assurance from others in both the conditions. So, both of them also share several socio-demographic and clinical features, including sex ratio. That is, both are more common in females, symptomatology, patterns of comorbidity. Uh, the purpose of this case report is mainly to discuss whether there is any role of social media influence and an unusual finding of bulimia nervosa with comorbid body dysmorphic disorder and depression. The prevalence of body dysmorphic disorder is 1.7 to 2.4%. This is one of more common of obsessive compulsive related disorders. And mean age of onset is usually late adolescence, and it's more common seen in women. And lifetime prevalence of eating disorder is slightly more, that is 2 to 6%. It is also more common in women than men. But here the typical age of onset is early adolescence to young adulthood. Coming to our case, a 16-year-old female reported to our OPD with the following complaints from her mother, like pervasive low mood, irritability, easy fatigability, death wishes, unable to concentrate properly, continuous weeping spells, and sleep disturbances. She also had excessive intake of food, which is followed by purging in the form of vomiting, almost 15 to 20 times per week. And she also used laxatives, almost 3 to 4 times per week. So with this, she had repeated complaints of generalized body aches, weakness, for which she was taken to general physician first. And she was given antiemetics and multivitamin supplements, but she showed no improvement. So she was referred to psychiatry, our OPD. Then on going to details of history, she aspired to become an actress or YouTuber. She was making videos and reels, which were not encouraged or supported by her family. Even though she used to upload them on social media, she was not getting the views, likes as much she expected, and she was receiving negative comments instead. In spite of this, she continued making those videos, and she used to check repeatedly if she is getting any views, comments, or likes. But as she's not getting the popularity she expected, she developed low self-esteem and used to be irritable most of the time. Gradually, she became preoccupied with perceived defects in her physical appearance, and she attributed this to her failure in social media. Although there were no observable abnormalities in her as such, her aim mainly was to maintain good looks, and she considered herself to be too fat and dark. She frequently sought reassurance from others about her appearance and was preoccupied, especially in social situations, what others might have thought about her appearance. So this preoccupation of her led to constantly look her into mirrors and check her appearance. These mirror checks would briefly reduce her concerns about her appearance, but she would soon continue again ruminating and have to repeat the same checking behavior. These concerns explain her reason for binge eating and purging episodes. So her current BMI was 17 kg per meter square, that is body mass index, and she has irregular menses. So with these, she was diagnosed as having body dysmorphic disorder along with bulimia nervosa, that is eating disorder, and she's currently diagnosed with moderate depressive episode. She has a family history. Her mother was diagnosed as having bipolar disorder, and she was taking medication currently. her investigations, her body mass index was found to be 17 kg per meter square. In complete blood picture, her hemoglobin was 8.5 gram percent. Her WBC count is 8,700. Her platelets were normal, 1.5 lakhs. So the patient was started initially with escitalopram 10 mg and clonazepam 0.5 mg in the first visit. In the subsequent visit, clonazepam was tapered, and gradually the escitalopram was increased to 20 mg as we didn't obtain the proper response. So in the next visit, as there was partial response, sertraline was started 50 mg and it is increased gradually to 100 mg in the further visits. So now the patient is maintaining well with sertraline 100 mg and escitalopram 20 mg. So concluding the report, this case highlights the importance of assessing additional concerns like role of social media about physical appearance, which is central to eating disorder. And body dysmorphic disorder is also overlooked in most individuals with eating disorders. So recent studies found a higher incidence of body dysmorphic disorder in patients with eating disorder and the vice versa, higher incidence of eating disorder in patients with body dysmorphic disorder. In recent days, the concept of perfect images, that is, it is influenced the society, it has been influencing the way the people should look. So body dysmorphia due to social beauty standards has been increasing. So since the main source resides in social media, it is mandatory to further explore the part of social media in body dissatisfaction and eating disorders. So to our best knowledge so far, there are less number of these studies reported from India. These are my references. Thank you.
Since yours is a case report, what was the diagnostic criteria for the body dysmorphic disorder?
Perceived. Just a moment.
You have the DSM-5?
Yes, ma'am. Criteria.
She fit in those criteria?
She is fitting. Perceived defects. Preoccupied with the perceived defects of physical appearance, even though there are no such defects, and that should compulsive checking of her appearance should also be there, as it comes under OC related, obsessive compulsive related spectrum, obsessions about her appearance, compulsions about her repeated checking.
And which eating disorder did she have?
Bulimia nervosa.
Okay.
Repeated binge eating episodes followed by purging in the form of vomiting and use of laxatives.
Did she lose a lot of weight in the process?
Not a very significant loss, as the main difference between bulimia and anorexia is in bulimia there will be no significant weight loss. So she lost her weight, but not that significant.
You said her BMI was 17.
17.
That comes in the normal range, isn't it?
Actually, we have to see according to her age and thing. So she lost her weight, but not that significant.
Not significant. Okay. Thank you to all the speakers and their respective teams for putting in all the hard work and for a very good learning session this evening. I just wanted to suggest that prior to sort of when the research is planned, is there a sort of a research committee or something? Because all these things that you're telling now, it would have been great if this sort of an input went at the planning stage, soon after the ethics and all that,
Usually we have ethics committee for every institution.
Right.
Ethics committee will, if you're in government service,
yeah.
I'm from Osmania, so I have to take the ethics committee permission from Osmania.
That's right.
So if they are doing, if their individual institution is there, probably then they have to take permission from them. If there is institution is registered,
Right, yeah, because I think
Or else, if you have a hospital where you're doing research, you should select some members from the hospital group for a research committee. From there, probably from any group of studies who can actually have statistical knowledge and everything, and so that they can make a committee and submit same to the MCA, State Medical Council, so that it can form a body, then do the research.
Because of the high number of now private institutes, I think it will be good to have that sort of a research interface. Yeah.
Private colleges and government colleges, the institution ethical committee is already there, man. It's already there. In hospitals, if you want to establish without medical college, you have to do a research. You have to find out your own members where you can ask them to be members and represent the same to state medical council, so that ethical committee approval can be taken from them.
Thank you for that. Yes, and that's the end of the day.
That's all for today. We can bombard our brains tomorrow. Let's meet.